welcome you all to the first academic event from Ferty9 organization in Vijayawada, FERTYGNAN 2024. Robert Noyce once said, knowledge is power, and knowledge shared is power multiplied. We all gathered here today to share knowledge, continue learning, and empower ourselves. So without further delay, let's start our CME program. We are all aware that maternal health before pregnancy plays an important role in determining the pregnancy outcome. Malnutrition, obesity, and any medical disorder has detrimental effects on several functions of human body, including reproductive health. Educating individuals and couples to assess risks, optimize medical care, and offer interventions before pregnancy can minimize the likelihood of poor pregnancy-related outcomes. To chair the first session today regarding preconceptional counseling and metabolic health and infertility, we would like to invite on stage Dr. Himabindu Garu. Madam is the HOD of Government Medical College, Vijayawada. And Dr. Padmavati Garu. Madam is the Director of Ashwini Mother and Child Hospital at Narsapur and current President of Bhimavaram OBG Society. We request our chairperson to introduce our speakers.
Very good scientific session, and we'll be happy with the knowledge we are going to acquire. So first topic is by Dr. Pujita Maineni, consultant at Ankura Hospital, Vijayawada. So incidentally, she also worked with us in government hospital for a few months. She was very active at that time. Come. Obstetric medicine and high-risk pregnancy specialist and executive member of the VOGS. So I request her to continue with the program.
Actually, when Suma ma'am gave me the opportunity to speak in this on this day, we were like, what is an obstetrician who is only keen on fertility once the UPT is positive, doing in a fertility conference? So maybe I guess making my job easy after the pregnancy test comes positive. So we will be discussing preconceptional care before pregnancy. So what is preconceptional care? Why is preconceptional care important? Who needs preconceptional care? And when is preconceptional care needed? So what is preconceptional care? Preconceptional care is taking care of the mother and identifying the risk factors before the pregnancy becomes positive or while the patient plans pregnancy, and modifying all the modifiable risk factors and giving all the vaccinations. So why preconceptional counseling is necessary? Because most of the poor pregnancy outcomes are due to avoidable risk factors like unplanned pregnancy, maternal age, undernutrition, obesity, iron deficiency, anemia, vaccines, preventable diseases, sexually transmitted diseases, epilepsy, smoking and alcohol. If we can see, all these risk factors are modifiable if the patient can be counseled at the proper time. So, who should seek preconceptional counseling? Any woman before the reproductive age or during the reproductive age. So, best time is to target adolescents as well as young adults and should be continued through the pregnancy, through the reproductive years and towards the menopausal age also, as late pregnancies are have higher risks. So, every woman should be having preconceptional care throughout their reproductive years at different points of time, because risk factors change with age and with advanced. So, when is the ideal time for preconceptional counseling? So, no woman comes for preconceptional counseling we have to identify the times when the preconceptional counseling can be done. Like in adolescent who comes for AUB can be identified and treated for risk factors like the diabetes, thyroid, obesity, and any person, marital or unmarried, who is coming for MTP, that opportunity can be taken to counsel for preconceptional counseling. Women requesting for postponement of periods, like we have marriage next month, so please give me something to postpone my periods. Anybody who is coming for postponement of periods, reproductive age girls visiting with her mom, and especially women can be identified and selected for preconceptional counseling when they come with history of subfertility. That is the time when we can address their issues and do preconceptional counseling and give care. And postpartum, before the patient gets discharged or in the follow-ups postpartum, preconceptional care can be provided. So what should preconceptional care include? Primarily, preconceptional care should include contraception. It should be the first step of conceptional care, because providing a knowledge of adequate contraception and effective contraception, avoiding the unwanted pregnancies and abortions is the first step towards preconceptional care. So, we have to educate the women about different methods of contraception and emphasis on long-acting reversible contraceptives and mechanism of action of the same can be, and need for the follow-up of the once the contraceptive method is chosen, and especially return to fertility. When is the fertility returned once the contraceptive method is stopped? Like in DMPA, the return to fertility takes up to an year. So these should be discussed. Along with this, the ideal age for first pregnancy, planning first pregnancy, need for planned pregnancy, unplanned pregnancy should be avoided, and need for prompt antenatal dating, because so many problems occur because of lack of dating of pregnancy. So need for prompt dating and immediate visit as soon as the pregnancy test is positive should be emphasized. So the second step is addition of folic acid. So in low risk women, 0.5 mg folic acid should be started 1 month before planning pregnancy and to be continued first 3 months of her pregnancy. In women with moderate risk factors, it is 1 mg folic acid started 1 month prior to planning pregnancy. And in women with high risk factors like previous neural tube defects, increased BMI, diabetes, thalassemia, 4 mg of folic acid should be prescribed. And preferably methyl tetrahydrofolate should be offered, as it also addresses women with methyl tetrahydrofolate deficiencies. So this should be preferably prescribed. Other multiple multi-nutrient supplementation is not recommended along with folic acid, and DHA don't have a role pre-pregnancy and in first trimester. So the second most common thing is anemia. Anemia is more prevalent during adolescent and reproductive age women. So every woman that comes to our OPD should be screened for anemia, and women in the reproductive age group should be supplemented with 100 mg elemental iron and 500 mg folic acid every weekly, along with deworming every 6 months. So third is optimizing the body weight management. So even underweight or mostly seen overweight and obesity have grave risk factors during pregnancy. So this should be addressed before pregnancy is planned, because once the pregnancy is positive, even if the underweight people gain weight during pregnancy or overweight people cannot reduce weight during pregnancy, it will cause more risk. In underweight, counseling about the risk factors during pregnancy. Weight gain in pregnancy does not reduce the risk associated with the low pre-pregnancy weight. Screening for eating disorders must be done, and nutritional modifications should be advised. When it comes to overweight, counseling about the risk factors during pregnancy like diabetes, hypertension, and increased chance of cesarean section, stillbirth should be counseled, And irrespective of the pre-pregnancy weight loss during pregnancy is not possible. So, weight loss should be advocated before planning pregnancy itself. Like nutritional modifications and strength conditioning exercises can be advised, and realistic targets like 5 to 10% of weight loss in over 6 months should be advised. So, in women with BMI more than 32.5 with comorbidities and with BMI 37.5 without comorbidities can be referred to for a bariatric surgery. But once the bariatric surgery is done, then the pregnancy should be avoided for at least 1 to 1.5 years, because there is rapid weight loss and as well as malabsorption during that period. So, genetics. Any history of consanguinity, any history of multiple disorders in the family, advanced maternal age, any exposure to teratogenic things, or fever with rash or chickenpox just before planning pregnancy, or any ethnic backgrounds where there is high risk for disorders like thalassemia and sickle cell anemia. All these history, along with any presence of birth defects in the family, or recurrent pregnancy loss, or family history of early onset cancers or other non-malignant disorders like Alzheimer's should be noted while taking the history. Preconceptional universal thalassemia screening is advocated because India is a high-risk population for thalassemia and sickle cell anemia. Universal screening should be advocated, and a woman should be advised to get HPLC done at least once in her lifetime. And when she is positive as thalassemia or sickle cell heterozygous trait, 25% of women carrying thalassemia who don't present with thalassemia have a chance of giving 25% of thalassemia major babies if the partner is also carrier. So this should be acknowledged, and every woman should be advised to get a HPLC done. Particular patient is not willing to get the thalassemia screen done, at least thalassemia screen must be done in patients with MCV less than 79 or MCH less than 27, as they are at higher risk for thalassemia. Because even thalassemia minors, they only present with borderline anemia, or they may have normal HP levels. So diabetes mellitus, pre-pregnancy, everyone should be universally screened for diabetes, like as India is high risk capital of diabetes. So fasting plasma glucose more than 126 and 2-hour plasma glucose more than 200 is diagnostic of over DM. So diabetes self-management should be taught, and importance of maintaining good lifestyle and maintaining the sugar levels while planning pregnancy should be addressed, because and the high risk risks associated with not controlling the diabetes should be addressed. So as we can see, if the HbA1c is less than 7 while planning pregnancy, the risk of anomalies in the fetus are similar to the baseline risk of the general population. But when it increases to 9.1, the risk of fetal malformations increase to 14. And when it comes to 11.2, it increases to about 25%. Means 1 in 4 babies can have fetal abnormalities. Patients with over GM should be advised to plan pregnancy once the HbA1c goal of less than 6.5 is reached, and they have to be supplemented with folic acid 1 month before conception. So before planning pregnancy, renal must be evaluated before planning pregnancy itself. When the targets are not adequate, adequate contraception should be advised, which include combined hormonal pills or progesterone pills when there are no vasculopathies, and IUCD can also be offered with caution. So now coming to thyroid disease. So universal screening of every woman that presents to our OPD for preconceptional counseling must be screened for thyroid disease. So hyperthyroidism must be optimized before conception. If the patient is planning pregnancy within 2 years, then the surgery is a better option than radioactive iodine. But once the radioactive ablation therapies are given, pregnancy should be deferred at least for 6 months. So, propylthiouracil is the drug of choice for first trimester as there are risks of embryopathies with methimazole. But prolonged use of propylthiouracil can cause hepatotoxicity. Hence, the drug should be converted to methimazole once the first trimester is done, in the second trimester. So, when coming to the hypothyroid, the target of TSH is less than 2.5. So, looking at this, any patient with TSH between 4 to 10 anti-TPO antibodies must be done. Ideally, more than 2.5 anti-TPO antibodies must be done, but anybody between 2.5 to 4 anti-TPO antibodies must be done. And looking here, any patient with TSH more than 10, irrespective of TPO status, treat the patient. Between 4 to 10, if anti-TPO antibodies are positive, then treat the patient. And if they are negative, still consider treatment. And between 2.5 to 4, if anti-TPO positive, then consider treatment. When it below 4, and if it is negative or less than 2.5, routine treatment with thyronome should not be preferred. Only with history of prior losses, thyroid supplementation should be offered. Once the pregnancy test becomes positive, the dose of levothyroxine should be increased 30% as soon as the pregnancy is positive. So, next, coming to heart disease in pregnancy, universal basic clinical cardiac examination should be done to every patient and discuss the consequences of pre-existing heart conditions and the medications used for the pre-existing heart conditions on pregnancy outcome should be discussed in detail, and the approach should be multidisciplinary always. So, even before planning pregnancy and patients with prior cardiac disease, a detailed cardiac assessment with a cardiologist is must to assess the baseline cardiac condition, reviewing the medication, evaluating any need for corrective surgeries so that the surgery can be done before planning pregnancy itself, and identifying women whom pregnancy would not be advisable. So, genetic counseling must be done in patients with congenital heart diseases, and warfarin is associated with risk of embryopathy in 5 to 10%, but is highly effective and has better patient compliance. So, risk versus benefit between converting to heparin or continuing warfarin should be discussed and informed decision to be made. Patients having severe pulmonary artery hypertension, severe systemic ventricular dysfunction, any Newark Heart Association grade 3 or 4 LV EF less than 30, previous PPCM with residual dysfunction, severe left heart obstruction, Marfan syndrome, aortic dilatation more than 50 mm, and native severe coagutation must be refrained from pregnancy. So, adequate contraception with progesterone-only pills should be advised. So, next, coming to pre-pregnancy hypertension. Universally, every woman should be screened for hypertension before planning pregnancy, and counseling about the risks when the hypertension is not controlled should be advised, and the target blood pressure for planning pregnancy is 140/90. So, like in DM, renal disease, ventricular hypertrophy and retinopathy should be evaluated before planning pregnancy itself. So, AC inhibitors and ARBs should be avoided, and safe antihypertensives like labetalol, nifedipine and methyl-dopa should be initiated, and till the contraception is, till the target pressure levels are achieved, adequate contraception to be advised. So, next, coming to epilepsy, need for planned pregnancy and avoiding unplanned pregnancy should be emphasized, and counseling regarding the risk of aggravation and effects of epilepsy and anticonvulsant drugs on pregnancy should be discussed. So, phenytoin, valproate, carbamazepine, which are teratogenic, to be converted to safer alternatives like levetiracetam, and preferably monotherapy at lowest effective dose should be initiated, and stable anticonvulsant regime for at least 6 months should be advised prior to conception. So, and every patient with epilepsy on antiepileptics should be advised to take folic acid at least 1 month prior to conception. And multidisciplinary care is mandatory. And cancers. In young patients diagnosed to have cancer, fertility preservation methods like sperm cryopreservation for an male and embryo or oocyte preservation for female should be advised. A cancer survivor should be counseled on potential of the subfertility, reproductive effects by cancer, as well as the cancer treatment should be discussed. And cancer survivors planning pregnancy should be assessed for subfertility. Level of subfertility depends on the age of the patient, type of cancer, and treatment of cancer. So women with any personal or family history of cancers with associated genetic mutations, genetic counseling should be done. And breast cancer survivors should be advised not to plan pregnancy for the next 2 years when they are highest risk for recurrence. So female cancer survivors treated with chemotherapeutic drugs and radiation to the heart should be evaluated by cardiologists prior to planning pregnancy. And reliable non-hormonal contraceptives like SCRMs should be advised. So cervical cancer screening must be done according to the protocol before planning pregnancy. American Cancer Society 2020 says initiation of cancer screening at 25 years till 50 years, and primary HPV DNA testing every 5 years, LBC every 3 years, or if co-testing is done every 5 years. So next, coming to autoimmune diseases. Autoimmune diseases can improve, worsen, or remain unaffected during pregnancy. These things has to be discussed. And when coming to the most common autoimmune disease, SLE women are high risk for multiple complications in mother and fetus. Hence, all the complications must be discussed, and quiescence of at least 6 months should be advised before planning pregnancy, and increased risk of flare post-delivery should be discussed. And toxic drugs like methotrexate, cyclophosphamide should be avoided while planning pregnancy, and multidisciplinary care is the key. So next, coming to asthma. Asthma, there is a chance of exacerbation during pregnancy, and there is a chance of preterm delivery, FGR, and malformations. So these things have to be discussed. And inhalational beta-2 agonists and steroids are the best first drugs of choice in asthma complicating pregnancy. And long-acting beta agonists should be reserved when the maximum dose of inhalational steroids are not sufficient to control the disease, and oral steroid should be reserved when exacerbation occurs. So infections, universal preconceptional screening. Every patient that comes to the OPD should be screened for HIV, HBsAg, and syphilis. And target populations who are high risk for other infections like chlamydia, gonorrhea, tuberculosis, and toxoplasmosis. Only high risk population should be screened for these diseases. Routine screening is not necessary. So in a HIV positive woman, dual contraception should be advised before planning pregnancy, and need for continuous combined ART should be addressed, and risk of transmission to the unaffected partner or the fetus should be discussed. And in a serodiscordant couple, if the woman is HIV positive, home insemination with partner semen during ovulation for 3 to 6 months should be considered before other methods are considered. And if the male partner is HIV positive, referral to fertility specialist, and option for semen washing with intrauterine insemination should be given. So psychiatric illnesses, these are often underdiagnosed and not addressed properly. So when underdiagnosed and untreated, the risk of aggravation during pregnancy and postpartum, and the risk of potential teratogenicity when the patient doesn't take medication properly should be discussed with the patient, and teratogenic drugs should be avoided, and multidisciplinary approach should be initiated, and optimization of disease is mandatory before planning pregnancy. And intimate partner violence. Intimate partner violence is more prevalent than we think it is. A patient should always be spoken to in private in a confidential manner with non-judgmental outcome, and when intimate partner violence is identified, a patient should be provided with right kind of information to who to seek when there is any abuse. So substance abuse, both the partners should be evaluated for substance abuse, and risk factors associated with smoking and alcohol should be discussed, and psychosocial and pharmacotherapeutic intervention should be initiated before pregnancy and during planning pregnancy so that the pregnancy is safe. Vaccinations. Vaccinating every woman at reproductive age group and who comes for pregnancy counseling with MMR vaccine is recommended. MMR vaccine is superior to giving only rubella vaccine. So pregnancy must be avoided for at least 3 months post vaccination. But when unplanned pregnancy occurs, it is not an indication for termination. The pregnancy can be continued. So, along with MMR, hepatitis B vaccination should also be checked if the patient is vaccinated for hepatitis B. If not, even hepatitis B vaccine should be initiated. And every woman coming to the OPD should be vaccinated for HPV. And pregnancy must be avoided for 1 month after the last dose. If unplanned pregnancy occurs during the course of vaccination, then the course should be completed post-delivery. So, along with these, varicella vaccine, flu vaccine and Tdap should also be given. And Tdap and flu vaccine, if not given pre-pregnancy, must be given during pregnancy, because pregnancy is high risk for flu, and when Tdap is given, it gives protection to the fetus during the first month of life when the fetus is not yet vaccinated. So in recurrent miscarriages, recurrent miscarriage is more than 2 pregnancy losses. TSH with anti-TPO antibodies recommended, HbA1c recommended, pelvic ultrasound with 3D recommended, APLA testing recommended, parental karyotyping recommended after 3 losses, BDRL recommended, torch is not recommended, prolactin levels not recommended in asymptomatic patient, and thrombophilia testing is not recommended. But thrombophilia testing is recommended in patients with the history of thrombosis, in the personal history of thrombosis or any family history of thrombosis. But thrombophilia testing is not recommended in RPL. So, thrombophilia positive patients should be educated about risk factors, and women with long-term warfarin should be converted to, unlike in cardiac disease where warfarin can be, risk versus benefit should be assessed. Thromboembolic disease, patients with thromboembolic disease should be converted to heparin preconceptionally or in early pregnancy. So, dental hygiene should be addressed and stressed upon before planning pregnancy. And skincare, most of people use skincare and they are unaware of the consequences of the skincare. While planning pregnancy, vitamin A, retinol and isotretinoin and minoxidil should be stopped while planning pregnancy, and mineral sunscreen should be used in place of chemical sunscreen. So, it is always ideal to have a checklist in our OPDs so that we evaluate each and every patient ideally. So, birth is not only about making the babies, it's about making mothers strong, confident and capable. Thank you.
Thank you, Dr. Pujita, for extensive explanation for preconception counseling. Only one point just I want to tell. So, what we teach the students is putting a pedigree chart also in the preconception counseling, so that previous 3 generations, if they have any problem, most of the times they won't tell. In such cases, karyotyping can be advised before planning for pregnancy only. Thank you.
Thank you. I want to tell one more thing. There is a South Zone Menopause Society conference happening in Vijayawada on August 31st and September 1st. Registrations are open and are being done at the front desk. So anybody who is interested in becoming a member of Menopause Society, because our society is very active and educational programs happen every month, and anybody interested in conference also can register at the registrations desk outside. Thank you so much.
And Dr. Himobindo is my teacher, and Dr. Padmavati my senior, and thank you for being the chairpersons for this session. So I also thank Dr. Suma, Varsha, Dr. Jyothi and Ferty9 team for the opportunity. So the topic is metabolic health and infertility, and please pardon me, I'll be using these terms maybe 40 or 50 times in my talk. So this is a very important topic, not only in general medicine to say, it is an important topic for preventive obstetrics, preventive gynecology and also in infertility. So the metabolic health and infertility includes what is metabolic health, what are the risk factors for the metabolic dysfunction, what are the influences on the fertility, what are the preventive strategies and what is our role. So metabolic health is nothing but effective regulation of blood pressure, blood lipids and blood glucose. So there is no abnormality in the metabolic process. So the individual does not have any diabetes, nor dyslipidemia, nor insulin resistance or hypertension. The International Diabetic Federation has defined metabolically unhealthy, not healthy, metabolically unhealthy as who presents with systolic or systolic and diastolic pressure more than or equal to 130/85 or using antihypertensive drugs or a triglyceride level more than 150 or equal to 150, HDL cholesterol less than or equal to 40 in men, less than or equal to 15 men, or on lipid lowering drugs or fasting blood sugar more than or equal to 100 or on anti-diabetic drugs. So any one of the criteria we can say the individual is metabolically unhealthy. So this definition does not include abdominal obesity, but we all know that the obesity has a negative impact on metabolic health. It causes hyperglycemia, hyperlipidemia, inflammation, oxidative stress. All these factors are enhanced, or we have to say exponentially increase the problems of infertility, pregnancy problems, overall health and disease prevention. So the metabolic health has been said to be a metabolic syndrome when we add the obesity to it. So in this slide we see if the individual the woman can be metabolically healthy or metabolically unhealthy, and when we add when the obesity is added to the metabolic health, then it becomes like metabolically healthy non-obese, metabolically unhealthy non-obese, metabolically healthy obese, metabolically unhealthy obese. Normal weight in the first two and abnormal weight on the lower two. So what is the difference? So whenever the metabolically healthy obese, that is they are physically active, they have good nutritional status, so the insulin sensitivity is preserved, they have normal blood pressure, normal lipid profile. But when they have the problem that is aging or sedentary lifestyle or increase in the diet, then they become insulin resistant, hypertensive, dyslipidemia starts, and also there is alteration in the liver function where the fatty liver appears, and also the visceral fat accumulation occurs. And the problems when we see the metabolically healthy non-obese to metabolically unhealthy obese, almost there is a 12% rise in all the diseases. So there have been many publications, that is from 1980 to 2014, see the number of publications. So the obesity is on rise and also the female infertility was on the rise. So the number of the publications, almost like 4,000 publications have been put on this obesity and female infertility. So metabolic health or metabolic syndrome is a new disease, a new term, which was in the aged population, now occasionally in 40s later on. Now it has become very rampant in all age groups and causing a problem with infertility, and also it is a transgenerational problem, that is will be seen in the next generations too, from the mother to the babies, and basically due to industrialization and urbanization. So we all know that the BMI, how do we calculate, and then the mainly why I put the slide is, and when we calculate BMI in age groups below 17 years, it is the triponderal index, not the BMI we need to calculate. And the WHO mainly classifies depending upon the weight to hip ratio, that is the abdominal obesity is defined by World Health Organization when the waist hip ratio is above 0.9 in males and 0.85 in females. So the obesity and fertility, they go other way around, that is not in the same direction. And the infertility in females due to obesity are due to problems with endometrium, atresia of the early follicles, increase in tumor necrosis factor, increase in insulin resistance, hyperinsulinemia, decrease in sex hormone binding globulin, and also problems at the hypothalamus level. Coming to the males, it is increase in the adipose tissue which causes the aromatization of the testosterone to estrogen, increase in the reactive oxygen species, hypogonadism, pro-inflammatory reaction, causing increased spermatogenesis, sperm DNA fragmentation, and male infertility. So basically, either it is in the male or female, it is basically the leptin resistant state and the insulin resistant state causing the problems. And also it is due to the circulating cholesterol, increase in free fatty acids. All these affect at each and every level in the reproductive system. And also there is an imbalance between the oxidative and the antioxidant systems which causes infertility. And obesity not only affects few systems, it affects the gastrointestinal, CNS, inflammatory pathways, liver, and overall it affects all these again affect the female reproductive system. So the metabolic health is quite important whenever we think of fertility. And the woman becomes apple shaped, that is there is an abdominal obesity, that is it's a central obesity rather than the pear shaped where it is a subcutaneous fat accumulation. So this slide shows that before these lines is the non-obese, the other way is the obesity. This is quite important because the insulin resistance and the metabolic health is reversible when it is below 30 BMI. When it is more than 30, it becomes irreversible. So the number of the infertility cases increase after the BMI of 30, and the probability of pregnancy is reduced by about 5 per unit of BMI exceeding 29 kilocalories per meter square. So this is the important thing, and then the target is 29 and above. We have to be very careful for counseling. The other important point which goes hand in hand with the obesity is the insulin resistance. Normal metabolism, we all know that the insulin helps for the entry of the glucose into the cell, that is there is an intracellular glucose by the insulin. But when there is a defect in the insulin receptors, intracellular glucose comes down. This leads to insulin resistance and a compensatory hyperinsulinemia. This compensatory hyperinsulinemia causes decrease in serum hormone binding globulin, increase in androgens, hyperandrogenism, affected the hypothalamic area, affected the follicular fluid where the myoinositol level is decreased and causing the impaired fertility. So again the same thing I am stressing this line where the insulin hyperinsulinemia after that becomes the diabetes. So that is a cutoff line where we need to have a proper knowledge of it. Obesity is strongly associated with glucose intolerance, insulin resistance, has negative impact on fertility and pregnancy, and also insulin resistance is the main pathophysiological mechanism and central aspect of infertility in polycystic ovarian syndrome. So polycystic ovarian system is one of the part of insulin resistance and obesity. And this is mainly because there is a reduced mitochondrial function and release of inflammatory factors which decrease the quality of the oocytes. So the insulin resistance whenever is there in the infertile women, they need higher doses of the gonadotropins, and also they have a high risk of GDM. And the insulin resistance, to say it has it is not so associated with worse IVF outcomes, but definitely it would have a negative impact on the ART procedures. Again, the slide on the right shows that the insulin resistance, normal HbA1c and diabetes. So definitely when we go through it, the amount of the gonadotropins we use is quite more in diabetes compared to the insulin resistance and in normal. That is the point where the metabolic profile has to be improved. And we all know the effects of the diabetes. In the male it is sexual dysfunction, there's a problem with sperm quality, and in female infertility again it causes the genitourinary infections, pregnancy complications, menstrual abnormalities, anovulation, and autoimmune reaction preventing the implantation. And the important thing is triple threat of diabetes, PCO and obesity. So that is so important because we have to maintain the metabolic profile for fertility. And the other point is hypertension. We know that in male and also in the female gonads and also at the level of the implantation. And dyslipidemia, again anywhere in the body where, when the fat is more, there is increase in androgens, there is increase in oxidative stress, mitochondrial dysfunction. Because more the lipids, more is the problem with the mitochondrial dysfunction. This causes infertility at the level of the ovum and the sperm. And in the males also it is the same. There is erectile dysfunction, there is spermatogenesis arrest, and acrosomal reaction is reduced, capacitation is reduced. So the main important point is how do we combine all these factors, that is the metabolic health with the obesity. The triglyceride glucose body mass index is the one which is a stable and a strong positive association with the female infertility. I could not put the chart, I could not get it, but otherwise this is the one which gives the relation between the metabolic syndrome and the female infertility. And gestational hypertriglyceridemia, if it is there, we have to anticipate acute pancreatitis in pregnancy. And other point, as I have already stressed upon, is PCO is due to the insulin resistance and very high, almost rampant to say in adolescent group nowadays. And PCO is a combination of the hormonal, metabolic and immunological disorder, which again causes low grade inflammation and leading to implantation disorders and ovulation problems. So what we see when the patient comes for the infertility is only the tip of the iceberg. Beneath that, it is to say so many disorders, hormonal, immunological, metabolic disorders, and also disorder of insulin resistance, and lifelong they need the physician's help, maybe from the pediatric to geriatric, from dermatologists, gynecologists, endocrinologists throughout their life, in each step of the life. Not only PCO affects the causes infertility, it also causes pregnancy complication, future of the health, and also it is a transgenerational disorder. So we have to, when the mother has a good metabolic profile, no obesity, then probably we have a good next generation. So whenever there is a good metabolic health, the hormonal balance is maintained, the ovum, sperm are good, the egg quality is good, the favorable uterine environment is there. But when there is obesity, PCO, insulin resistance, there is a hormonal disturbances, chronic anovulation, oxidative stress, and increase in reproductive wastage too. So early detection and management of the metabolic disorder is essential for optimizing fertility, improving the reproductive outcome, probably in the preconceptional evaluation, and lifestyle counseling is important. Coming to the preventive strategies, how do we educate the patients? So suppose a patient with obesity comes to us, we have to be very cautious, use non-stigmatizing language, ask permission to talk about the weight, never use a language like fat, obese, etc. So instead of that, use good language like overweight, healthy diet, eating habits, physically active instead of exercise, which will be proactive for them too. So we all know that the diet and lifestyle contributes to reduce the risk of infertility, reduce the risk of metabolic dysfunction, and well-planned nutrition also translates into effectiveness of fertility, conception, ART, etc. And diet, in case it is not possible, diets and commercial weight loss programs can be taken up by the women. And polyphenols is one of the new concepts where it is said that it decreases weight and also decreases the PCO. Fruits, vegetables and herbs, all this where there is coloring like orange, red, purple, these are all called polyphenols. And these polyphenols have anti-inflammatory effect, antioxidants, change bacterial population, reduce the blood glucose, and reduce the response of insulin glucose to the high carb meals. So 2.5 cups per day of these polyphenols has shown improvement in the fertility in case of PCO patients. So this is also known to everyone, surplus in proteins, fibers, avoid sweetened beverages, sugars, junk food. Physical activity not only improves the metabolic health, it improves other systems also like bone, increased energy output, muscle mass. All these again are indirectly helpful for fertility, because once the mental health improves, the hormonal balance improves, and then the success of the fertility treatment would be much more. So the all types of fasting, maybe it is intermittent fasting, any of these, that is you do fasting every day, you do once in a week or part of a day, everything is okay. Don't eat food when you are obese, that will help you. And bad sleep can cause binge eating, hunger, craving. So proper health is important. Eat well, move well, live longer to change. That brings a lot of change. That gives a positive effect on the hormones and fertility. And bariatric surgery is one of the options for obese patients if BMI is more than 40 or 35 to 40 when they have comorbidities. Definitely this will help them to lose weight, and as Dr. Pujita said, 1 year or after that, like it is a time gap they have to give to conceive. And this is again the time frame which I said, like difference between the metabolically healthy obesity, metabolically at risk obesity. And this is an important chart which gives everything about the metabolic health. So what are the points why there is a problem with the metabolic health when there is a weight gain, and then what are the plans to be done, what are the hormonal changes. And this graph shows whenever there is an increase in the weight, the fertility, the infertility increases. That is, it is at the level of the 28, 29 and waist circumference also. So this is one of the paper, yeah, I'll finish in last 2 or 3 slides, I'll finish. So in the American journal where metabolic syndrome incidence is 27.2, longer infertility duration and during ovarian stimulation requires high doses of gonadotropins and have the problem with the low peak estradiol levels, and the cumulative live birth rate did not show a big difference between the. So we all know the problems, infertility, pregnancy and other outcomes, and good metabolic control and decrease in the weight is the main goal preconceptionally in all cases of the metabolic disorders. And as I said, reproductive wastage is also high. The point is, the quality of the egg is a problem. On the top of it, there is procedure of assisted reproductive technique, which again increases the burden on the defective embryos, which again causes a reproductive wastage. Other important thing is the Barker's hypothesis. In all the cases of metabolic dysfunction, the babies are going to be low birth weight, or there is a metabolic problem in the fetus, which leads to malnutrition, and after delivery, high energy input causes them to be obese. And these obese become adolescent obesity in children. Once they become pregnant, again the cycle continues. This is what is the Barker's hypothesis, and we need to break this cycle. How do we break the cycle? Is counsel the adolescent, counsel preconceptionally, and probably IVF after the metabolic goals are met and normal weight is achieved. So we can break the Barker's hypothesis or this cycle of vicious cycle of metabolic ill health and problems in the next transgeneration problem with the proper metabolic health. So the metabolic dysfunction is the root cause of infertility, and the metabolic health is crucial for fertility, and declining fertility rate is running parallel to the global metabolic health rate. So obesity should be avoided regardless of the metabolic disorders. Maintain a healthy weight for all. Maintain a healthy weight should be for all, and even the metabolic health should be for all. Thank you.
Thank you, Susila, for your excellent and elaborate information. Thank you for introducing me also. I am very thankful to Ferty9 people and Dr. Suma Varsha, because I have chaired with my teacher, Dr. Himabindu Jaganmohan. Both are very famous at that moment in 1993 for their special book, which is very important book for all PG aspirants. And my teacher and my madam, Dr. Prabha madam and Shalini madam is also here. Thank you, ma'am, for attending this session. Thank you.
One small suggestion is, whoever the patients who are coming to us, we should advise them, all of them, to bring their children or girls before marriage, before they are planning for marriage, not just before marriage for postponement like that. So 1 year at least before planning for marriage, to see all these things, so that they will have reduced chances of having infertility in their later life. So if all of us follow this, then the problem may become less. And thank you very much.
Very true, ma'am. Thank you so much.
Of hydrosalpinges, endometriosis and uterine anomalies. Hysteroscopy is considered as office procedure now, but can sometimes lead to life-threatening complications. So let's learn how to make it safe. Laparoscopy is often done for endometriosis, but how to do a fertility enhancing procedure? We have our esteemed speaker to throw some light. To chair the session, we would like to invite on stage Dr. Bahadur Garu, Professor, OBG, NRI Medical College, and Joint Secretary, Works, Dr. Aruna Kumari Garu. Madam is current President of Rajamandri Obstetric and Gynecology Society.
The first session is Hysteroscopy Made Safe. This is by Dr. Chandana, past Secretary of Fox, past Secretary of APSR, past Treasurer of Vox,
who has rightly said that hysteroscope should be considered the stethoscope for the uterus. Today, why are we talking more about hysteroscopy and why this topic of hysteroscopy and making it so safe has been addressed by Ferty9? We are all humans, and for humans, uterus is their first home. So this topic is definitely validated in this FERTYGNAN CME. The flow of the talk today shall be on the basic instrumentation and the room setup needed, the basic principles of hysteroscopy, the distension media, the safe hysteroscopy, role in infertility, the trials, Cochrane review, and a take-home message. Hysteroscopy had to wait for technical innovations in endoscopic fields. Difficulty in distincting the uterine cavity, the friable nature of the uterine mucosa, and the deadly bleeding that can happen, and the need for anesthesia and cervical dilatation were its hindrances in initial days. It has soon surpassed the dilatation and curettage for gynecological indications and also decreased the need for laparotomy for treating septate uterus and different uterine anomalies. And now it has set itself as a gold standard for endoscopic surgeries. Before doing a hysteroscopy for any patients, first, suppose you have posted a case, you have to be very sure and know which type of hysteroscopy are you planning in your theatre today. Is it a level 1, level 2 or level 3 hysteroscopy? Level 1 will be a just diagnostic hysteroscopy and a target biopsy with the removal of a simple polyp. Level 2 will be a proximal fallopian tube cannulation and removal of a pedunculated fibroid, and level 3 goes to the resection of the uterine septums, endometrial ablations and resections of submucous fibroids. This is the basic instrumentation which is to be there on your trolley. This is the uterine sounds, speculums, the sponge holders, the basic hysteroscope with its outer sheet, and this is the resectoscope, and when you are using a resectoscope you should have a TURP set available with you. These are the different diagnostic hysteroscopies which have been shown. A flexible fiber optic hysteroscopy, a miniature hysteroscopy has come up with a diameter of 2 mm which can be used in your daily office procedures. And these are the different instruments inserted through the office hysteroscope, the forceps, scissors, unipolar and bipolar electrodes. And this is the telescope. Remember that to see the uterine cavity, the basic wattage should be around 150 watts when you are buying a light source. For the fiber optic smallest of the hysteroscope, you need as high as 300 wattage. And the video cameras have gone from a single chip to 3 chip and now has come the HDs. Lithotomy position is the ideal position to do your hysteroscopy. This is an endoscopic trolley which has to be there in your theatre. And what are all the systems to control the pressure and flow? Now that you have started your hysteroscopy, what do I use? I have a basic setup. Is gravity fall system okay, or should I use a power cuff, pressure cuff, or all of us should have a hysteromat? The basic hysteromat is as costly as 4.5 lakhs. Should all of us have this? No, definitely. For a level 1 and most of the level 2 surgeries also, you can do your hysteroscopies with a gravity fall system. The hysteromat has a suction irrigation system, and it is important to maintain this suction irrigation continuously to have a clear flow. And it has a preset flow rate, suction and irrigation pressure, which automatically adjusts the inflow and outflow of the fluid. A point to mention here is inflow accounts for how many fluids you have been using and also whatever your anesthetist has been using. Suppose you have used just 3 to 4 or around 3 to 4 bottles of normal saline, which were around 500 ml, it amounts to 2 liters, and your anesthetist has pushed out another 3 liters. It becomes 5 liters, and your output is not as much as it. Definitely the patient will go into hyperdynamic circulation. So you have to watch what anesthetist is pumping in apart from what fluids you are using also, and the ideal flow rate is around 200 millimeters of Hg, and the ideal outflow pressure is around 75 millimeters of Hg. This is a resectoscope which has been assembled to do the procedure. We can see here that it has an inflow tract, outflow tract, and an outer sheath, and a cable connected for the cautery to work. And this is a ideal operating room setup. We should have you operating from the foot end of the patient, the anesthesia monitor, the anesthesiologist at the head end of the patient, and electrosurgical unit on the right side of the patient's leg, and a monitor near the almost at the thigh level of the patient, and your table on the right side. So we are all set with all the available instruments, be it a high level or a lowest setup, whatever we have. We are starting to do a level 1 or a level 2 or level 3 hysteroscopy. The most important thing which we have to learn, the basic principles are, what is this viscosity of the media? What is high and low? High means it has more number of particles, low means it has low number of particles. It's a simple way to tell. That's what we have learned in our physiology. And does it have an electrolyte content or not? This is most important, because when you're using a unipolar system and doing a septal resection, which is most commonly done with glycine, which is a hypoosmolar media, you should be very careful. You should never use a normal saline with a unipolar system, because electrons flow from the generator to the loop, to the tissue, then to the neutral electrode, and there should definitely be a non-conductive media for this. If you use a normal saline when you are using a unipolar system, what happens is these electrons get dissipated and the tissue doesn't get any reaction. So the whatever surgery you are doing, it doesn't happen, and it's very minimal tissue which will be cut. When using an isotonic saline, the path traveled by the electrons is unknown. That's the reason why you should not use saline while doing a unipolar current cutting. And thanks to the technology, the new generators have a cutting power adjusted to the tissue resistance. This is a very good article which I have seen on the net while preparing for this CME. This is an AAGL practice report guideline for the management of hysteroscopic distending media, which every one of us have to read before embarking onto a hysteroscopic surgery. This shows the different distension media which are available. Normal saline, which can be used for a diagnostic and operative hysteroscopy, which is isoosmolar and electrolyte free, and it can be used for mechanical cutting with scissors, a bipolar or a razor. And of course it is not recommended with monopolar energy, as it disperses the electric current without having any surgical effect on the tissue, as I have told. Ringer's lactate can be used in both the situations. Glycine can be used in operative hysteroscopy. It is hypoosmolar and it has to be used with monopolar current. In the same way, dextrose and sorbitol. The incidence of fluid overload will vary according to the case mix and type of hysteroscopic surgery. In general, when using large diameter resectoscopes, the incidence of fluid overload should be less than 5%. So don't be afraid of fluid overload before starting to learn hysteroscopy or doing a level 1 surgery, because it's not very common. The clinical course and outcome of all women with fluid overload should be audited, of course. This should include the unrecognized fluid overload which your anesthetist has been pumping. The important point all of us should know about this fluid dynamics is, what is fluid deficit? It is a difference between the input and the output. Input means what you are using and what the anesthetist is using. A fluid deficit, what is an ideal fluid deficit? A fluid deficit of more than 1000 ml should be used as threshold to define fluid overload when using hypotonic salines in a healthy woman of reproductive age. Healthy woman has been mentioned means she is fit and healthy. Suppose she is having any underlying decompensated disease like a minor cardiac issue, then it has to be restricted to around 750 ml. A fluid deficit of 2500 ml should be treated as threshold to define fluid overload when using isotonic salines. So this can go up to around 3500 ml also sometimes, and it has to be restricted to around 1500 ml in an decompensated patient. So as beginners, it is always better to go with an isotonic normal saline and use a unipolar current. This is a very good pictorial representation of how to go about and how does the damage occur in a case of resection of submucous fibroid. As we can see here, the overlying endometrium on the submucosal fibroid. Once you start resecting, you will be resecting the endometrium, then the submucosal fibroid per se, and almost when it is invading the myometrium to less than 50% is the stage when you can do a submucosal resection of the fibroid. Beyond that, you should not do it hysteroscopically. Surgeon should understand the factors that can lead to a systemic fluid absorption. Means this case selection is most important in such cases. High uterine distension pressure, low mean arterial pressure, means the patient is already in hypertension, then definitely you are going to fluid overload the patient. And when you are invading the myometrium very deeply and you are going ahead with a very prolonged surgery and you are going ahead with a very large uterine cavity, these all increase the likelihood of systemic fluid absorption. And how about the myometrial vessels section? It has been documented that when the myometrial vessels are around 400 to 500 microns, per minute of invasion, 9 ml of your fluid is going to go into the plasma. And if it is greater than 1 millimeter vessel section, around 400 ml per minute with gravity system infusion and 250 ml per minute for Histromat. And never exceed your operating time maximum of 30 minutes. Suppose you're a beginner and you're unable to do your surgery, suppose a septal resection or a submucosal fibroid resection, always it's better to counsel our patients that is, this surgery might be done on a second look also. In that way, we'll be very safe and we can restrict to this time limit so that we will not have this fluid overload. So, here are the small tips and tricks to how to go about hysteroscopy. Always allow free flow of distending medium through the system, which will eliminate the air embolism. You started your hysteroscopy. I'm doing a hysteroscopy with normal saline. Always see to that in the IV set or the TURP set which you are using, already it is full. The tube is already full so that air embolism doesn't occur. This is a very important trick the beginner should know, and remember to do the hysteroscopy in the proliferative phase, because always remember that the isthmus doesn't give way when you do it in the secretory phase, and the mucosa is better to see in a proliferative phase. The morphological changes are very minimal in the proliferative phase. And suppose you're not able to pass the sound only, what do? Shall I abandon the procedure? No. The 2.9 mm hysteroscope or a 4 mm hysteroscope also, you can take out the outer sheet and you can go how the axis is going. Means see and do the surgery. That is what everyone of us has to remember, and you have to adjust the right source sometimes, right side, left side, posteriorly or anteriorly, depending upon whether the uterus is acutely anteverted or retroverted. This is a very important tip the beginners have to know. And suppose you find that everything is so hazy, just open up the outflow tract, let some of the fluid go, then the cavity will be visualized. And sometimes you might have to touch the mucosa so that the camera is visualized properly. In a nutshell, the movement of hysteroscope should follow the uterine anatomy. What are the contraindications? A pelvic inflammatory disease, acute cervicovaginitis, intense metrorrhagia, and a pregnancy. And here comes to the complications. Overall incidence of hysteroscopy complications are just 0.95%. So definitely we all can start doing level 1 hysteroscopies with the minimum setup we have. And the most frequent of them are a hemorrhage, which accounts to 2.4%, uterine perforation, which accounts to 1.5%, a cervical laceration around 1 to 11%. Intra or immediate postoperative complications, you have to involve an anesthetist also in their management. These usually mainly occur due to cervical dilatation, the distension media, and the technique what you are using. And here goes the intraoperative complications, which can be arrhythmias, a uterine perforation, distension media related, a gas embolism, a hemorrhage due to cervical laceration, and of course the electrosurgical burns. The light complications include PID, intrauterine adhesions, hematometra, and post-ablation sterilization syndrome, which so happens in endometrial ablation, which is over-resected. Perforation, this is of course the most commonest complication. This can happen during cervical dilatation or insertion of a scope. How do you recognize it? You have happily gone inside the uterine cavity. Suddenly you feel that your instrument is going beyond the fundus. It means your procedure, you can feel that something is given way. Then you have to definitely suspect that there might be a perforation, and suddenly you lose the visualization and you can see the momentum popping up from the fundus. And sometimes if you are very unlucky, you can see the bowel also at the level of the fundus. And sudden bleeding, your visualization was very clear, but suddenly you will find there is more amount of bleeding. Suddenly you will feel that find that the fluid deficit has increased, because whatever fluid you are pumping is going into the abdominal cavity. So deficit definitely will increase. So these are the earliest signs of perforation. A randomized controlled trial evaluated the use of vaginal misoprostol 200 micrograms before office hysteroscopy. This reduced the cervical dilatation and operative time and trauma. And when you embark a hysteroscopy on a postmenopausal lady, it has been validated to use 14 days of pre-treatment of vaginal estradiol so that you can get an adequate cervical dilatation. When you find a perforation, or suspect a perforation, abandon the procedure, check the hemodynamic status. Don't hesitate to proceed with a laparoscopy or a laparotomy. Always have people with you to counsel when you are doing a surgery, to counsel outside the theatre also. And hemorrhage, usually it happens in level 3 hysteroscopics. This is mostly controlled by unipolar coagulation or an oxytocin drip, or a Foley's catheter which can be dilated to around 30 ml. A skilled surgeon will almost always avoid this. And regarding the distension media, CO2 is obsolete now. Fluids with a very good hysteromat with continuous irrigation allows clear picture and enables us to do a mechanical or electrosurgical cutting. Infection is very rare. In a retrospective study of 21,676 procedures, it has been found that is just 0.01%. Actually, prophylactic antibiotics are also not recommended while doing a hysteroscopy. A prospective observational study has showed that it is just 1.4%. Endometriosis is around 0.9% and UTI is around 0.6%. Operative hysteroscopy intravascular syndrome. This is caused due to invasion of the distension medium leading to hyponatremia, and if severe, it can lead to metabolic acidosis, pulmonary edema and cerebral edema. As I have mentioned before, remember the British Society Endoscopy Guidelines and European Society Endoscopic Guidelines. Do remember to go back and read the article which I have mentioned before for the fluid dynamics. And an air embolism, the basic tip I have told to avoid the basic air embolism which can occur at the outset of starting a hysteroscopy. And once you encounter it, avoid an exaggerated Tenelberg position. Height of irrigation system should be restricted to less than 1 meter, and avoid nitrous oxide. And how do you detect this? A sudden decrease in the PeCO2 levels will occur, and dyspnea and chest pain. So how do you know that this has occurred to the patient? Of late, the anesthesia, which if at all you have to give anesthesia to a hysteroscopic patient, other than the office setting, the best is a epidural or spinal anesthesia also, rather than going for a short general or general anesthesia, because all these signs can be picked up very easily. Here goes the debate, is it transvaginal scan, SIS or a hysteroscopy? We can see here that hysteroscopy has a sensitivity and specificity. These are all the intrauterine pathologies which can be operated while doing a hysteroscope, and hysteroscopy is validated for all these procedures. And do we use hysteroscopy routinely for all our infertility patients is the topic of debate today. An insight study, trophy study have been done wherein hysteroscopy has been used for non-IVF patients and failed IVF patients also. None of these studies have shown that it is useful, but these studies had limitations because endometritis has not been taken into account, and 1/3 of the patients in the insight studies did not have the pathology treated, and 45% of patients in trophy study which incorporated failed IVF cycle patients into the study had a hysteroscopy already done. So these studies actually are not validated. And let's see what our most famous Cochrane database system tells. It says that hysteroscopy has a moderate evidence to be used in recurrent IVF failures, but routine IVF, no. How is hysteroscopy evolving in modern practice? As reproductive endocrinology and infertility practitioners, I stands for infertility and IVF nowadays. And why not we optimize the womb where the fetus spends most of his time rather than spending more time on the culture systems wherein the baby is going to grow for 5 days. So much of funding is going into the culture systems, but there is less of funding to deal with the hysteroscopy and the studies. And regarding the cost, the setup will cost around $1,200. Procedure disposals will cost around $25. And it is a 20-minute procedure, as simple as a annual examination of a patient. A small take-home message: no question of endoscopy if Bozzini in 1805 had not used lantern and speculum, and there is no question of hysteroscopy if Pantolomei in 1869 hadn't used a cystoscope developed by Desemex to remove a polyp from a postmenopausal woman. As reproductive endocrinology and infertility specialist, it's time to rekindle office hysteroscopy for benefit of our patients. They deserve nothing less. Let us enjoy the little things in life. Thank you. I thank FERTYGNAN and Ferty9 Dr. Jyothi Madam and Suma for this opportunity, and Vox for this wonderful platform. Thank you.
Thank you, Chandana, for this elaborate talk how to make hysteroscopy safe and simple. As Madam said, now ultrasound is the second hand of all gynecologists. It's a must for all gynecologists in our OPD. The hysteroscopy will become same. It's a stethoscope of uterus, as Madam said. So we all should learn how to do office hysteroscopy to complete our all gynecological procedures like DUB, postmenopausal bleeding, and infertility. So we all should learn this procedure, and Madam made it very simple.
Thank you,
ma'am.
Thank you.
Endometriosis Foundation of India, and she's a director of Center for PCOS and Endometriosis. She has several awards to her credit, and I welcome you, Dr. Bindra, and she's going to talk on fertility enhancing surgeries in endometriosis. Endometriosis Foundation of India, and she's a director of Center for PCOS and Endometriosis. She has several awards to her credit, and I welcome you, Dr. Bindra, and she's going to talk on fertility enhancing surgeries in endometriosis.
A very good morning to all of you, and it's my honor and pleasure to be here. I would like to thank VOGS, Ferty9, and especially Dr. Suma for kind invitation. So on a Sunday morning, the hall is full. It's really a pleasure to talk because every speaker puts in a lot of effort when they prepare a talk, and we have such interesting audience. We love to talk to you and discuss these things. So I would like to disclose that I am a proctor for Intuitive Surgicals. We all know that 30 to 50% of female with endometriosis experience fertility issues and typically present with endometriosis during infertility screening. And some of them are completely asymptomatic and are incidentally diagnosed when they come for their screening. So endometriosis affects ovarian reserve, oocyte quality, maturation of oocytes, tubal function, fertilization, implantation as well. And there is always a debate between the fertility specialist and the surgeon for an optimal treatment, to go for IVF or do a surgery. Surgery should be preceded before the IVF, or the IVF should be done before the surgery. It is always a debate. When a patient goes to an IVF specialist, they are told, do IVF, once you are pregnant, your endometriosis will go away. And that is not a fact. There are multiple implantation failures for these patients. And believe me, these patients do not stick to one fertility clinic. They go to one fertility clinic, one implantation failure, they go to another one, another implantation failure. But then for stage 4 endometriosis or advanced endometriosis, deep endometriosis cases, the excision surgery does enhances fertility rates. So when do we treat them surgically? We treat them surgically for pain, to improve the quality of life, to enhance the fertility, and for severe disease impacting several organ functions. If a patient have a subocclusive or occlusive bowel disease impacting the ureter or hydroureteronephrosis, and suspected malignancy. So first of all of us have to reduce the tunnel vision for looking at endometriosis as only an endometrioma. So this is not only an endometrioma, it involves the adjacent organs. We should evaluate all these patients for the disease outside the ovaries as well, so that we can also help them have a improved quality of life and reduce their pain. Pain during defecation they have pain during sex, they have pain during urination. And most of these times, if you keep exploring or keep asking the patients, their intercourse frequency is very less. So that is also one of the reasons for infertility for patients who have pain with endometriosis. I'm not talking about patients who don't have pain, but there is a set of patients who have pain and infertility both. To minimize the adverse effect on the ovarian reserve, surgical treatment should be performed by a gynecologist with a specific expertise in endometriosis and fertility enhancing surgeries. In cases of young females who are not yet planning to become pregnant, it would be appropriate if we offer them fertility preservation such as oocyte freezing, embryo or ovarian tissue cryopreservation before surgery. Now, surgery for different phenotypes, endometriosis and adenomyosis both have different phenotypes, and we should address both of them together. 42% of endometriosis patients have adenomyosis as well. So endometriomas and impact on AMH with surgery, peritoneal or early disease and its impact on fertility, deep endometriosis excision, colorectal endometriosis excision and its impact on fertility, foam excision and its impact on fertility, and intrinsic adenomyosis and its impact on fertility. And I'll take you all through these phenotypes. Endometriomas are found in 40% of women with endometriosis and 50% of infertile women. The best surgical approach is still controversial. An ovarian cystectomy is the preferred technique. It is associated with lower recurrence and higher spontaneous pregnancy rates. Preoperative assessment is of vital importance. We should know the size, extent, number, location. They are unilateral or bilateral. Cyst before surgery. Meticulous preoperative planning is the part of procedure and it should include examination, check for adnexal masses, rectovaginal involvement, pelvic ultrasound or MRI to determine the number, size and location, endometriotic nodules, extent of pouch of Douglas obliteration, presence of hydronephrosis, hydrosalpinx. And also not to forget, we should check their ovarian reserve before surgery in terms of AMH levels and antral follicle count when future fertility is a concern. So there are different treatments which we do for endometriomas. There are many treatments which have been reported: the decapsulation or stripping, the drainage, CO2 ablative therapy, sclerotherapy, especially when endometriomas are bilateral. The best surgical option always remains controversial and treatment must be patient tailored. The most popularly which we do is the cystectomy or endometrioma excision. What is the role of serum CA25? The accuracy of serum tumor markers may be limited as some of these are raised to presence of endometriosis. Now this particular patient had a ruptured endometrioma and her CA125 was 2000, but it was absolutely benign. So many of the times patients are also told that CA125 is high. Even if it is 150 or 200, they are told that it may be cancer, but that is not true. CA125 is not a marker for endometrioid carcinoma anymore. Let's go to the steps of endometrioma excision. How we start it? We start separating the endometrioma from the pelvic side wall, drainage of endometrioma. Visualize the ureter because most of the time these endometriomas are stuck to the lateral pelvic wall. Dissect the ureter in case of dense adhesions. Dissect endometriotic tissue from the pelvic side walls. Extend the opening from the drainage side. Avoid multiple incisions. Cyst, sometimes if it is big, may be turned inside out. Identify a dissection plane. Saline and vasopressin can be used to dissect the plane between the cyst wall and the ovarian tissue, and traction and counter traction helps. For the treatment of endometrioma, excisional surgery for endometrioma was shown to be better than drainage and ablation, so I would recommend that drainage and ablation should not be done, both for recurrence of endometrioma, pain symptoms and fertility outcome. Now when we talk about ablation, there is a new treatment on the horizon called as alcohol sclerotherapy, and it is becoming quite popular. We have been using it for fertility patients in our practice and it has really very good results, and the evidence has supported this as well. I am not talking about ultrasound guided ablation of endometrioma. I am talking about endometrioma ablation with 100%, 99% alcohol during laparoscopy or a robotic surgery with deep endometriosis excision. So this, in this what we do is we first of all drain the cyst, we suck it out the contents, we wash it with a normal saline, and then we put a Foley's catheter inside the endometrioma. We fill up the bulb of the catheter so that it does not come out, and then we calculate the volume required to ablate the endometrial tissue. and we inject 99% to 100% alcohol, medical grade alcohol inside the endometrium and keep it there for 15 minutes, and your assistant can keep irrigating the tissue surrounding, because the spillage of alcohol can cause sometimes abrasive changes in the other adjacent organs as well. So this is a very good technique, but there are certain cases only we can use. The endometrioma should be at least more than 6 centimeter in size. It should not be multilocular, it should be a unilocular endometrioma. And we have very limited series, but whatever patients we have done, in 6 months their ovarian size was absolutely normal, even with such big endometrioma where the chocolate material was around 1 liter inside. Now this was a paper which has a very big series from Horace Roman, where around 482 patients were included. So it has shown that laparoscopic sclerotherapy for endometrioma more than 4 centimeter during surgery for deep endometriosis excision has a low impact on AMH, preserves fertility and prevents recurrence as well. Impact of surgical management on endometrioma on AMH levels and pregnancy rates. The reduction of ovarian reserve after surgery for endometrioma is inevitable. All of us know that. Regardless of the technique, both excisional and ablative approaches lead to a post-surgical decrease of up to 60% in AMH levels. So AMH opinions are always divided. Some studies show enhanced fertility rates with surgical treatment. Some have shown negative impact of surgery on ovarian reserve. So what are the things important and determining factors are the bilaterality, size of endometrioma, stage of endometriosis, and patient's age. These should also be considered when planning a surgery in patients who are interested in preserving their fertility. The damage to ovarian reserve observed in patients with endometriomas is related to surgical procedure, the presence of previous cyst, also the previous surgery, and it is also unclear what the risk factors for damage to ovarian reserve after surgery. Now coming to a very important fact, where what happens is when you advise a surgery and immediately you do AMH, there will be a decline in AMH. So never do AMH immediately after surgery, and it gives a false impression of the AMH levels. Why? Because after ovarian injury, compensatory mechanisms may include recruitment and growth of primordial follicles and excessive activation of granulosa cells. And delay in this recovery is explained by approximately 180-day duration of folliculogenesis from the primordial follicles to the pre-ovulatory follicles. So we, in our practice, don't do AMH levels before 9 months to 1 year. So there is an initial decline of AMH and then it starts increasing. So if you want to check, please check their AMH levels after 9 months to 1 year, and definitely they will be either at par with the preoperative levels or they may be little more as well. Ovarian endometrioma, I want to emphasize that they are rarely isolated. They do not exist alone. So presence of ovarian endometrioma has been reported as being a marker for deep endometriosis and multifocal deep vaginal and intestinal with ureteric lesions. Ovarian endometrioma negatively impacts oocyte quality and quantity but not pregnancy outcomes. So the results of this study have demonstrated that ovarian reserve and response following ovarian stimulation for IVF ICSI treatment was significantly lower in patients with ovarian endometrioma compared with controls after adjusting for age, BMI and infertility duration. Coming to the minimal endometriosis. So minimal endometriosis, we are not addressing. Sometimes you see the bluish spots and peritoneal lesions. People ablate it and come out. But there are studies where minimal endometriosis excision has enhanced fertility and has good implantation rates as well. Impact of minimal endometriosis on fertility outcome: ovulatory dysfunction, impaired folliculogenesis, defective implantation, decreased embryo quality, abnormal immunological peritoneal involvement and luteal phase problems. The relationship between infertility and disease is not evident because pelvic adhesions are not severe enough to create damaging anatomical effects. So normal anatomy is well maintained, but the inflammation caused by these lesions is responsible for implantation failures also. This was published in Facts, Views and Vision. In women with minimal and mild endometriosis, surgical excision or ablation of endometriosis is recommended as first line with doubling the pregnancy rate. In patients who fail to conceive spontaneously after surgery, assisted reproduction is more effective than the repeat surgery. So this is for a minimal endometriosis cases. In this case also, pelvis looks so clean, but if you go closer and see, there are multiple endometriotic lesions near the uterosacral ligament. So for these cases, we usually do posterior peritonectomy and uterosacral ligament nodule excision. In these cases, bilateral ureterolysis is the primary step, I'm not saying for all early endometriosis we take them for surgery. Definitely we tailor the treatment, which one size does not fit all in endometriosis. So we select these cases where they have already tried naturally or taken some treatment, but they have not achieved success. We plan for excision surgery. Or if patient has pain, there are patients who have very, very small, less than a centimeter uterosacral nodules, and they have severe pain. So here you can see very, very small blue spots, but this patient was also a infertility patient, 4 implantation failures, and then she came to us and we did the surgery. Along with the implantation failure, she had pain as well. So in presence of endometriosis, the clinical pregnancy rate after IVF ET is lower than in controls, as was proven by this study. Now there is another study in BMC Women's Health where reproductive and post-surgical outcomes of infertile women with DIE was seen, and there was a pregnancy rate of 61.82%. We all should know that kissing ovaries are a marker of deep endometriosis. Now this patient also had kissing ovaries. She also had 2 IVF failures, severe pain, pain during defecation, pain during intercourse, but no surgery was done. So she had bilateral endometriomas along with the bilateral uterosacral nodules along with the bowel nodule. So we did a bilateral endometrioma excision, we did a uterosacral nodule excision and bowel discoid excision as well. So what you can see is that I'm putting a thread on that. So usually I use this ventro suspension so that my posterior compartment, the uterus can be hanged to the anti-abdominal wall and posterior compartment becomes very free for me to work around. So this is a very good technique. If your manipulator is not helping you, you can just put a suture through the uterus and hang the uterus to the anti-abdominal wall. Similarly, after excision of the endometrioma, you can hang the ovaries also on the anti-abdominal wall, and you can work on the posterior compartment for the posterior peritoneum, uterosacral nodules and the bowel nodules. So whenever we excise endometrioma, we have to be careful that we don't damage the normal ovarian tissue, and minimal use of electrocautery, minimal damage to the healthy ovarian tissue to be done, and we should find a proper plane. Should not bleed much. So these are the precautions if you take during endometrioma excision. Usually ovarian reserve can be preserved very well. This was again a recent article where the study was done on infertile women who had more than 2 IVF ICSI failures. So infertile women with more than 2 IVF ICSI failures may be referred for surgery as it appears related to reasonable post-operative pregnancy outcomes, particularly when endometrioma surgery is either not required or not performed. Now coming to the bowel surgery, like colorectal surgery, how it is related to infertility. So definitely colorectal surgery, bowel involvement or any organ involvement in endometriosis can influence the pregnancy rates and also the implantation rates, because the inflammation and the environment it creates is not very conducive for the embryo implantation. So discoid excision for colorectal endometriosis associated infertility, a balance between the fertility outcomes and complication rates. This study has also shown that excision of the colorectal endometriosis enhances fertility rates. So we do it by 3 ways. We do rectal shaving, we do discoid excision, or we do segmental resection as well, depending on the size of the nodules, depth of involvement, circumference involvement, or it is unifocal or multifocal. So this result supported that discoid excision is safe and associated with good fertility outcomes. Whether first-line surgery using discoid excision is superior to first-line ART remains to be determined. The high post-operative fertility rate following surgical management of colorectal endometriosis, another study supported this statement. DIE affecting the urinary tract. Now I'm coming to the urinary tract, which amounts to 1% of the endometriosis. This also impacts fertility. With the use of preoperative imaging, planning, multidisciplinary teamwork, the complication and recurrence rate of operatively treated urinary tract endometriosis are acceptable, and 2/3 of women who wished for pregnancy conceived after excision. So bladder endometriosis, ureteric endometriosis, these patients, they also have infertility, but after excision, the fertility rates enhance and as well as implantation rates enhance. So this was a full thickness bladder nodule. This is a cystoscopic picture, but we did it robotically. We did the partial cystectomy after stenting the ureter, because this nodule was quite close to the ureter. So if the distance of the ureter and the nodule is 1 or less than 1 centimeter, it's better to stent it, so that when we suture the defect, we reduce the chances of getting a ureteric stricture. The radicality of operation improves the fertility outcome and reduces recurrence rates. A history of prior surgery and presence of adhesions are negative prognostic factors for recurrence. Now, I'll just touch base with the adenomyosis because, as I said, 42% of endometriosis patients have adenomyosis as well, and they should be counseled for the same. So, they may present with junctional zone abnormality, diffuse adenomyosis with DIE, or focal adenomyosis of outer myometrium, JC or ACUM, and atypical adenomyosis as well. So, adenomyomectomy procedure, it depends. It is definitely not a first line treatment. As for endometriosis, we always say that deep endometriosis excision can be the first line treatment for pain and as well as infertility, but adenomyomectomy is not a first line treatment. The first line treatment still remains medical. If medical treatment does not work, then adenomyomectomy for patients who are desirous of retaining their fertility, then adenomyomectomy can be done. So focal adenomyomectomy is much easier and comparable to the myomectomy, but diffuse adenomyosis surgery for adenomyomectomy are much difficult and expertise is required to do those surgeries. And nowadays we are getting huge uterus, as you can see in the third video on the right side. This was a huge uterus where volume of the uterus was around 1100 cc, and we had to debulk the uterus. She was only 23 years old. So we had done a double flap adenomyomectomy to do the debulking surgery and retain the fertility as well. Focal adenomyosis of outer myometrium is an entity which is in some of the evidences it says that it is a deep infiltrating endometriosis of the outer myometrium. So when you see a question mark sign on ultrasound, it signifies a fixed anteverted retroverted uterus with the fundus adhered posteriorly to the rectum and or sigmoid colon. It's a marker for uterosacral, retrocervical, deep endometriosis and foam. So if we find foam in our patients with deep endometriosis, we do excise it. And as compared to the diffuse adenomyosis, excision of foam is much easier as compared to because it is on the outer myometrium, it spares the inner myometrium. The suturing is also much easier in these cases. This is from our own data where patients with foam we had evaluated. And if you compare with the diffuse adenomyosis, the foam patients have normal flow during periods as compared to diffuse adenomyosis patients where they have heavy periods and menorrhagia. So patients mainly presented with symptoms of dysmenorrhea seen in all of them with an average pain score of 6.3 on a scale of 10. 46.2% were trying for pregnancy. 29.7% had primary infertility and 16.5% had secondary infertility. 39.6% had taken treatment for infertility and 19.8% of them had failed IVF. Our main diagnostic tool for clinically suspected patients was ultrasound, which picked up the lesions in 79.2% of the cases, and MRI was needed in only 6.6% of the cases. Both imaging modality were used in 13.2%. So it's not the which type of imaging modality, it's the expertise. If you have a good sonologist who can map the disease, ultrasound is good enough. Otherwise, you can use MRI. I'll just take 2 more minutes. So thickness of junctional zone is also important because these patients will have disproportionate dysmenorrhea. So look for the junctional zone abnormality also for patients who have dysmenorrhea, and it is more than 10 on 10 even after excision of surgery. And if we look at the lesion distribution, so this is how, this is from our patients only. Now, if you see the O compartment, this is the ovarian compartment, but it is also associated with all other compartments in so many percentage of the cases. So idea to show this is that do not deal only with the endometrioma. When you go in for a surgery, map the disease preoperatively and excise the other compartment disease as well to enhance the fertility and improve her quality of life. So lesion distribution characteristics in women diagnosed with histologically proven ovarian endometrioma associated with DIE were frequently multifocal and severe. Involvement of rectal or bowel nodule in these patients would require rectal shaving, discoid or segmental bowel resection. The surgeon should then anticipate availability of instruments, surgical time, and most importantly, a multidisciplinary team to continue the procedure and ensure completeness of the procedure. The usage of #NZN in these cases with ovarian endometrioma bridges the gap and acts as a unique mode of communication between surgeon and helps in assessing the treatment outcomes, and true recurrence of disease can be calculated as well. This indicates endometrioma should not be addressed alone as DIE is associated in most of the cases and must be handled by a multidisciplinary team. Cystectomy is not the only surgery it requires, and correlation with patient symptoms is also important to avoid leaving the lesion behind, leading to residual disease. Hence, the importance of preoperative imaging. Various risk factors have been suggested for fertility reduction or enhancement, and these are both patient and surgeon dependent. The quality of surgery and not the surgery itself is important. Surgery is the gold standard treatment for ovarian and extra-ovarian DIE, but it should be performed with proper technique by a specially trained surgeon in a multidisciplinary team. So we have to tailor the treatment. It should be a radical nerve-sparing approach, radical against the disease but not against the organ function, patient-oriented approach. First surgery should be the best one, and it should be multidisciplinary. And we have to work in collaboration with the reproductive specialist. If endometriomas are not very big, ovarian reserve is low, offer oocyte or embryo freezing before excision surgery. Now, basically, if we don't collaborate, ultimately the patient suffers. So we have to collaborate with each other. We have to work in teams. So talk to your reproductive specialist, talk to your surgeon, and then make a best plan for your patients. So patient will have a best outcome in a anatomy like this on the left side and not an anatomy like the right side. These are various cases, but I think I'm running out of time. So balance is the key. We have to balance between the desire to conceive and the quality of life, balancing the avoidance of invasive procedure without preoperative mapping, balancing the asymptomatic disease and preventing the silent organ loss, balance between surgical and non-surgical treatment, balancing the incomplete surgery and residual disease versus surgery done by MDT and preventing recurrences. As I said, one size does not fit all, one size fits one. So we have to tailor the treatment for these patients, and we should not subject these patients to multiple surgeries, and don't save the best for the last. The first surgery has to be the best one for endometriosis patients. And there is no perfect timing for surgery in endometriosis. Collaboration works, and this is my team from Apollo Hyderabad. It's a multidisciplinary team. We have a colorectal surgeon, a gynae onco surgeon, a uro surgeon, and recently we also did a thoracic endometriosis. So we also have thoracic surgeon and a pulmonologist as well. And you can contact me at these social media handles. Thank you so much. And we have a robotic in surgery in endometriosis masterclass on 17th and 18th in Hyderabad Apollo. So if anybody is interested in learning robotics in endometriosis, can contact me.
For a recurrent endometriosis, when we are planning IVF, can we do this? Do you have any experience doing this clearotherapy with under ultrasound guidance?
No, ma'am. I don't have any experience. We don't do it ultrasound guidance.
Ma'am, I have one more thing. Recently, I'm seeing this radiologists and young girls. I am sending him so that because endometriosis, they will definitely require 1 or 2 surgeries in their entire lifespan. So aspirating the fluid, the chocolate fluid.
Good morning. So happy to see the air full of knowledge, but yet colorful. So on a Sunday, taking all your precious time and you're here. So a big heartful thanks for each of you. I welcome each of you with a flower bouquet and with a saluting hand. I'm doing this here, but I don't have a bouquet for each of you. Please, thank you for being here. And then, they always say, Vidya Dadati Vinayam. Education is a powerful tool. it not only leads to wisdom, but end of the day, every human being is searching for peace. So knowledge is symbolifying peace. So, and also we know from hearing from great gurus, they say, whatever the age is, anybody who stops learning, he is 20 or 80, it doesn't matter. The person who learns is more valuable, young, and regardless his physical capacity. So each of you here are very young and energetic. Salute to all the teachers. What I learned from our legendary teachers are, any tree which has to grow tall and touch the sky, it has to go deep down itself. The roots has to go deep down. So we need to be humble, very well mannered, and then the nature helps us in growing tall. Big thanks to the Vijayawada Society, Dr. Sarjana and Dr. Kavita. I think they're busy, they had their own issues. So thank you for them for giving Ferty9 this opportunity. And just 2 minutes about Ferty9. I don't want to waste most of your time. We value each of your time. So 10 years back, the story of Ferty9 started, 2013. We started simple like one nursing home, just we know the art of fertility, we'll start serving the society, started like that. Of course, to keep transparency, ethics, and then cutting edge technology, and also learning, making it as a training institute was always there from the beginning itself. Then I also believe in, Abdul Kalam. He always says, anything, you purely feel from your heart, and in any profession, when there is service involved, man's energy with that, nature's energy will set in. When a man's energy, he can achieve only something. But when nature's energy set in, you never know where it can grow. So, we believe that, and touchwood, we are seeing Ferty9 multiplying the same way. And we started with 1. In 5 years, we reached to 7. Now, we are, 4 more centers are coming up. It's going to be 11, Tirupati, Rajmundry, Kurnool and Banjara Hills. So in a couple of months, we'll be inaugurating 4 more centers. So that is what, and we have a set of, these women all look with a laparoscopic surgeon and our anesthetist very colorful, but it not only colors, it is also, I always feel women should be of substance, both brain and beauty, both together. And these are the backbone of Ferty9 team, all our consultants. And of course, now some new changes has happened in our lab. We have our lab totally, it is going towards a lot of accreditation. And we have this person called Javier, from Spain. He's taking care of all our labs put together, 11 labs of Ferty9. So what changed was, of course, quality control. There was enormous change, revamping in the lab. But for me, it was like, 6 times the media consumption become more on the lighter note. So definitely, but later we understood that with this quality, the success rate, sustainability is maintained, and we are seeing it, the improvement in the success rate. And then these were some of his SOPs. And we do have our embryology taken care from the India level. Mr. Sandeep, he is there. I think it's not an easy job, taking care of 42 embryologists with him. It is not at all easy. So, Sandeep, thank you for taking care of embryology lab, because for a consultant, embryology is something which we want somebody dedicated to do this job. Thank you, Sandeep, for this. And then we have our board members, all of them here. So before it was, we were all doing the same job. See, as a clinician, being in managing is very tough. So I thank the whole board members. So every system, like the front desk is organized, reception, 1 person is taking care, embryology department, 1 person, clinician, 1. So we have everybody in place doing their job. About software, 1 person is taking care. So thanks to all of them. So if you have to see some new changes, what we did was RI Witness system we got into our system. So if you see RI Witness, it is something we launched, in AP and Telangana. So most of the people, when it comes to IVF, they feel gametes are handled outside. How can I trust that's my gametes. This RA witness has a barcode. So it helps us. There is no human error. 100% mismatch is prevented with this RA witness system. And again, this is something we recently launched. This is a Ziltrix. It is a sensor phone. Babies are stored in lab, and in IVF lab, we create babies. It is something like a holy place to us. But leaving these babies and going home is little worry sometimes because of power fluctuation. So we need somebody dedicated to monitor there. So we have this Ziltrix system where even little fluctuation in any temperature or in the QA/QC, there are alarms. First alarm goes to the lab manager, then second to the CEO of the company, and third to the director. So there is no way, the gametes are very safe. So this is something which we always wanted. And then actually we don't have data, only 3 years data we took out. Before we never used to have data properly maintained. 3 years data, we have 11,000 happy couples from our center. So we are so happy about that. And we are also training institute. You all know about Ferty9, so much we give importance to academic. More than 300 gynecologists somewhere or the other in different courses have been trained from Ferty9. So thanks for my team, all of them here who are always relentlessly, involved in the learning program. Of course, lot of camps we do. And then this one statement I like from Henry Ford. He says, if everyone is moving in the forward together, then success takes care of itself. We don't have to chase success. So this is our team. And then also I believe now the tree has grown tall and it is ready to give the fruit. So it's all because of you. You have trusted us with your patients, and we have helped them in becoming parents and then sent back to you, because we don't do maternity. So this is how the gift of life continues. Thank you so much for patient hearing. Thank you so much.
We now welcome Dr. Sridevi ma'am to speak a few words.
Good afternoon, all of you. I congratulate Ferty9 Fertility Center, the entire team, for organizing such a wonderful program in the ages of VOX. Yes, it takes vision, progressive thinking for any institute to be established and flourish. Of course, congratulations. As you all can see, all the CME program, all the topics have been well curated, both practical and academic. We all know that knowledge applied is skill, and I am also proud that our own VOXians are in the faculty, like Dr. Susila, Dr. Chandana, Dr. Pujita, and of course Dr. Suma Varsha, and they are doing an extremely good job. It's been a very happy learning experience. Once again, wish you all a very happy learning today afternoon. Thank you very much for giving us this opportunity. Thank behalf of VOX for organizing this program under the aegis of Vijayawada OBG Society. Thank you very much.
We request our APMC observer, Dr. Purnima Garu, to speak a few words.
Good afternoon to all the respected seniors and colleagues. So I am Dr. Purnima. I am basically a dermatologist. I have come here as APMC observer. I am happy to see this large crowd. It reminds me of our cosmetology conference, and I wish all the success for this workshop. Thank you.
So very good afternoon. At the outset, I thank Dr. Suma Varsha for having given me this opportunity to chair the important session on. The morning session has went on well, and by seeing all these delegates, so in a sunny summer of Sunday today, so the beautiful speakers, the beautiful all the ladies having come 350 registrations, it's a very great to come to the FERTYGNAN to learn knowledge of today's not only obstetrics, gynecology, and the more important topics, preconceptional and infertility concern. So now I am very privileged to welcome our Kundan Ingel, Chairperson, AMOGS Endocrinology Committee, former Chairperson Infertility Committee FOXY, Vice President POX, former Managing Council Member ISOR, and Founder Treasurer Maharashtra Chapter ISOR. The topic is resistant PCO. What next we are supposed to do? He wants to tell everything we should learn. Thank you very much.
Good afternoon, everybody. First of all, thank you very much, Vijayawada Obstetric and Gynec Society, Dr. Suma, Dr. Jyothi for inviting me. Thank you very much. And it's really amazed to see all of you in so many large number. So friends, I'm going to talk about clomiphene resistance. So though it sounds like a very usual topic, but really one question before I start my presentation, can you raise your hand if you are using 50% of your patient's clomiphene? How many of you really use it? Just raise your hand, please. So I do understand. And okay, so this is what those who uses clomiphene, this is what they suffer. The first cycle, they try to develop follicle, it doesn't develop. And second cycle, again, we increase the dose, it doesn't develop. Third cycle, again, it happens, and that brings a lot of frustration, and we just give it off. And we just want that patient somewhere to develop that follicle and, give us some kind of hope that we can achieve a pregnancy. Now, friends, jokes apart, but strength doesn't come from what you can do. It doesn't come from what you can do. It comes from overcoming the things you once thought you could not. And that's what we are going to learn today. So, what are the principles of ovulation induction? It should come to our mind whenever we start the ovulation induction cycle. First is achieve a pregnancy in the shortest time. Now that instead of first intention, the last words are very important, and that is called shortest time. And that's what we have to, really have aim. Then, of course, to avoid all those complications like multiple pregnancy and ovarian hyperstimulation. And we have these drugs as a ovulation induction agents. Nothing new for us, clomiphene, letrozole, and gonadotropins. The concept of threshold for ovulation induction in PCOS is very clear, that we want adequate stimulation. There is a threshold for stimulation. We don't want no response. Of course not, because that cancels our cycle. Which also don't want hyper response, so multiple follicular development, because not only we cancel because in view of ovarian hyperstimulation, but also increases the risk of multiple pregnancy. So what we want is a threshold for stimulation. Now what you mean by clomiphene resistance? So when you give a clomiphene, there is a failure of follicular growth or ovulation, very clearly. So there are two different terminologies, clomiphene resistance and clomiphene failure. The difference, important difference is in clomiphene resistance, there is no follicular growth. And in clomiphene failure, where a patient has responded to your clomiphene, developed a follicle, she has ovulated, but she did not give a pregnancy. So that's completely two different. And we are going to deal with that clomiphene resistance. Now, this is more commonly seen in polycystic ovarian syndrome. There is a reason behind it. We are going to understand that endocrinology today. But these are the three things should come into your mind when you are dealing with clomiphene resistance in PCO patients, and that is presence of insulin resistance in that woman, hyperandrogenemia, and the obesity. We know the basic endocrine defect is hyperestrogenemia, and that leads to hyperproduction of LH and reduction in the FSH. Now, obesity, again there is excessive fat. It's going to contribute more estrogen. That's going to keep the FSH low and keep the LH low high. So these are the three things which has to come in to our mind, and that's why the whole management based on these parameters. Now let's understand and focus the diagram, because that is very important. If you look at the top part of the diagram, that is mimicking a natural cycle. So what happens on the first or the second day, FSH is normally in the range of 5 to 7. Now the moment there is a lower reduction in the estrogen level, the FSH rises. You can see the dotted line. Unfortunately, this pointer cannot work on LED, but the FSH levels goes beyond dotted line. That is, dotted line is a threshold for FSH. So to recruit the follicle, FSH has to go above this threshold level. Okay. Now, once it goes, you can see, look at the down part of the diagram. There are 2 or 3 follicles which are recruited. Now, the moment the follicles are recruited, they start growing. They are going to produce estrogen. Now, once the estrogen comes into the circulation, it is endocrine principle is always the estrogen suppresses FSH. Remember that simple thing. Always estrogen going to reduce FSH. So those FSH levels which have gone beyond threshold is going to fall down. The moment it goes again below the threshold, the couple of follicles, 2 or 3 follicles which are recruited, out of them only 1 will remain and 2 will go into atresia, because there is a down in the FSH level, right? So if you understand similarly, that's what is the dominant theory, where a single follicle develop as a dominant follicle. Now we need to understand why clomiphene only has got these kind of effects, and why in PCOS patient only this thing happens, not in unexplained infertility patient who are normal ovulating. So remember friends, the FSH level which is on the 5th and between 5 to 7 or 5 to 8 on second day, it is suppressed because of hyperestrogenemia. So it is more lower on the first or second day. So your anti-estrogenic drugs, they are not able to raise that FSH beyond the threshold, and that's why follicles are not getting selected. And that's why even sometimes we start with 50, then go to 100, and sometimes even go to 150, still it doesn't respond because FSH is not going beyond threshold, and that is typically clomiphene resistance. Now, what are the options we have? So we have metformin, we have aromatase inhibitors, gonadotropins, adjuvants, and ovarian drilling. 5 strategies. We'll understand each of them patiently. Insulin sensitizers. The first cause I said for clomiphene resistance is a insulin resistance. So obviously insulin sensitizers are going to help. We have many molecules now. Out of them we have to understand which is better. So this was way back in 2003 when metformin was compared with a placebo when initial studies, and it was clearly evident that ovulation rate was favoring metformin. If a patient is on metformin, she will spontaneously ovulate also if you compare with the placebo. So then 2003 onwards we understood the importance of metformin. Then came metformin combined with ovulation induction agents. So you can see these marked studies 2002, and these are the clomiphene resistant patient or PCO patients who were given metformin along with clomiphene, and they realized that it is giving us a positive odds ratio favoring the combination. The ovulation rates are increasing, which the same patient group was not responding to clomiphene. The moment you add metformin, they start responding because it reduces the insulin resistance. Then came 2012. This was a study which actually, there was some time where we started, let's not prescribe metformin, because it said that it increases clinical pregnancy rate, but it doesn't increase the live birth rate, right? So 2012 onwards, again, there was a downfall for metformin because this study said that it doesn't increase the live birth. So the ultimate outcome is not increasing. So we didn't, feel like, why should we give it? But you have to understand one statement, that it increases the clinical pregnancy rate. Clinical pregnancy is a live pregnancy at 7 weeks. So our intention, we need to understand that there are several other factors, several other causes which can affect beyond 7 weeks, which can lead to miscarriage, which can lead to extreme premature deliveries or IUDs. So we cannot compare a drug for a live birth rate. That's very important. And that's what happens because of this study. It was for slight few years, we thought of that, no, let's not prescribe in every patient. But then we came many other studies, like in this 2015, when they compared, that was a randomized systematic review of RCTs, they compared with gonadotropins, the combination of metformin and clomiphene, and they found that it resulted in significantly fewer ovulations and pregnancies. No significant difference were found when metformin clomiphene was compared with laparoscopic ovarian diathermy. So gonadotropins were better, but compared to ovarian drilling, metformin and clomiphene was much better. Then likewise, there was no difference were observed in comparison with aromatase inhibitors and clomiphene citrate. So what it told us that there are these 5 strategies. We need to understand what is our first choice, what is our second choice, what is our third choice. So aromatase inhibitors came in as a first choice, then came in as a clomiphene with metformin as a second choice, then third choice came in as a gonadotropins, and last choice came in as a ovarian drilling. So there is a evidence for the superiority of gonadotropins, but the metformin clomiphene combination is mainly relevant for clomiphene resistant polycystic ovarian syndrome patient. If not effective, the next step could be gonadotropins. So that was a conclusion of this review. Now, which insulin sensitizer is better? Can we have only metformin or can we give both? So this was only single study which was in 2019 done by our Indian faculty at AIIMS, and they concluded that if you give metformin along with myoinositol, there is a definitely significant increase in the live birth rate, as you can see 55% versus 26%. Now again, this study was little misinterpreted by many of us, because why should we talk about live birth rate? We don't want to test a drug by comparing live birth rate. But it did show that the secondary outcomes like improvement in menstrual cycle, hormonal and biochemical parameters, spontaneous conceptions, abortions were less, multiple pregnancies were less, ovarian hyperstimulation syndrome was less, and there is a significant improvement into menstrual cycle when you give both. So those secondary measures which were expecting that the drugs or agent should give us this outcome, they were much better in combination. So then came in a new protocol. We always love new protocols because it always criticizes the previous. The conventional protocol is that we give it from clomiphene from second day till sixth day, 5 days of the early cycle. But can we do more? Can we reduce this resistance? So this is called a stair-step protocol. A stair-step is, as you can climb the stair, it is not only that you are continuing the drug, but you are increasing the doses. So that's what is stair-step protocol. So this was in 2015, 60 PCO patients who failed, who were clomiphene resistant, they were allocated randomly, where one group received conventional protocol, so 5 days clomiphene, that's it. And stair-step was, you give 50 milligram for 5 days, no response, continue with 100 milligram for another 5 days. That is called stair-step. And they found that ovulation and pregnancy rates were similar between the stair-step and the control group. Duration of treatment was significantly shorter in a stair-step. So somewhere if you continue giving clomiphene further from 50 to 100 milligram, probably you will still see a better result, shorter duration of treatment, and without affecting the ovulation pregnancy rate. So we are getting the similar pregnancy rate, we are getting lower cancellation of the cycles. So that was regarding some modification of clomiphene. Now let's understand the aromatase inhibitors. We know our favorite drug is letrozole, and we know that 2.5, 5 milligram is the dose available, and let's understand how it is better. So when letrozole was compared with clomiphene, the biggest important difference we saw is that cycle cancellation due to ovarian hyperstimulation was 0% into letrozole group, and it was 5 to 6% almost in the clomiphene group. So very important complications of ovulation induction was 0 with letrozole, and that's why it is our favorite. Not only that, with letrozole, the endometrial thickness, the endometrial milieu was better, the pregnancy rate was much better, the rate of abortion was not so significantly different, and OHSS was significantly less. And that's why letrozole became our favorite drug. Now can we combine letrozole along with highly purified HMG low dose in clomiphene resistant cycle? How it does it benefit? And when this prospective single and single central trial, the ongoing pregnancy rate was 28% per cycle. Have you understood? We always say 10 to 12% of pregnancy rate which we get normally in IUI cycles when we use oral ovulogins. With combination, we can actually go to 28% per cycle, and per patient, if you look at it, really goes till almost 68%. So that's something is a combination which is going to give us a better. The ovulation rate also increases almost 97%. We know with only letrozole we have 75-80% ovulation rate, but with combination it has gone further to 97%. So these few studies, so that was a comparison. Can we give letrozole only? Can we give only clomiphene, or can we give letrozole along with HMG 75? And then it realized that the pregnancy rate of letrozole with HMG was almost 55.7% cumulative pregnancy rate. So it was much better. So it opened up some era that not only letrozole is better, but its combination is better. So that's the next step for our clomiphene resistant patient. So then this randomized clinical trial came that yes, letrozole is associated with higher rate of ovulation, more dominant follicles, better endometrial thickness, those all advantages. Reproductive outcomes were much better. So then clomiphene went down and letrozole we took up as a best ovulation induction drug. Now, can we use 5 milligram versus 2.5 milligram? What is the difference? Should we only stick to 2.5 or should we go to 5 milligram? So with 5 milligram, we had total number of follicles were significantly higher. So again, this study through the light that pregnancy rate per cycle also was significantly better when instead of 2.5 we use 5 milligram. So again there was a study who compared 5 milligram versus 7.5 milligram. It showed no, you don't need to use beyond 5 milligram. It doesn't change. So result of this study who compared did not show any advantage of using 7.5 milligram. So the conclusion came in that 5 milligram is enough. We don't want to go beyond 5 milligram. Now this was a good study in 2016 which wanted to compare that efficiency of clomiphene citrate and letrozole when they combine with metformin. See, we know metformin with clomiphene has got advantage. It gives us better results. But does metformin combining with letrozole has any advantages? So what they realized that endometrial thickness more in favor of letrozole and metformin combination. If you look at the first cycle when this combination was used, pregnancy rate was 17% versus clomiphene only 6.5. At the end of 3 cycles, 20 versus 9.6. So again, if you want to use letrozole, if you have a patient who's got an insulin resistant, use metformin along with letrozole. It will give you better pregnancy rate at the end of 3 cycles. So simple, if you have a PCO patient, investigate for insulin insulin resistance. If you feel, give insulin sensitizers for maybe a couple of months. Then start these stimulation protocols where you can give only letrozole from 5 milligram per day, second day to day 6, and follow the follicular monitoring. Typically, this will give only one dominant follicle. You won't get more 3 or 4 follicles or 2 follicles. If you want that 2 or 3 follicles, then you need to add HMG. So give letrozole for 5 days. From day 7, you can give low dose of HMG, that is 75 IU, but please give it daily. Please give it daily. Don't give it alternate day. The problem is, can you remain one day without any food? No, we can't. So same way, if follicular growth rate needs a pace. So they also need a daily pulsatile FSH. So you have to give it daily. Remember that. It will give us a better results because it will give you synchronized follicular growth when you have 2-3 follicles. Because if you don't give it one day, you will see fluctuations in the serum FSH levels and some follicles will go into atresia. So please give it daily. You can use low dose, enough, 75 is enough. If you feel that follicle is growing, you can step up to 150, no problem. But monitor follicles daily, monitor follicles by giving daily HMG. Now if you want that, the theory says that if a woman develops 4 oocytes, only 1 out of 4 will give rise to a good competent blastocyst. If you understand this theory, then we will always like to have, if one cycle gives me 3 or 4 oocytes ovulated and available for fertilization, my chances in one cycle going to increase. And for that matter, what you need to go to that physiological level. So you need to increase FSH beyond the threshold and let the levels remain above the threshold, above that, don't let it fall down. So what you can do, this protocol helps for that. You give letrozole only on 2nd and 3rd day, and 4th day onwards only introduce gonadotropins. There you can start giving either 75 or 150. So what it happens, it's a pure gonadotropins, biological hormone. It remains in the circulation, FSH remains above the threshold line. Your no follicle is going to go into atresia. So what you want to get is 2 or 3 follicles are growing in synchrony. Nothing is inferior or 5 millimeter lesser than the dominant follicle. You will have 2-3 follicles which are, so when they ovulate, they will give you more M2 oocytes. And if 3 or 4 M2 oocytes ovulate, then there are good chance that your chances of pregnancy in one cycle also increases. So this theory again goes back to the physiology. Now gonadotropins, we know different preparation. I don't need to tell you this. When to use? Remember, first choice is 2 cycles of letrozole. Now if you don't have pregnancy with single follicle ovulation, time is 3rd cycle is to go for multiple follicles, that is 2 or 3 dominant follicles. There gonadotropins role comes. But we need to keep it in mind that we don't want multiple pregnancy. So use judiciously but in an adequate dose. When low dose HMG pure gonadotropins was compared with clomiphene in clomiphene resistant patient, it proven better in terms of every parameter: clinical pregnancy, live birth rate, multiple live birth rate, number of pre-ovulatory follicles and ET. Everything was in favor of HMG. So gonadotropins are better. Then why they are not first choice? Only reason is that it gives a little slightly higher multiple pregnancy rate, and that's what we don't want. That is not a good outcome of your treatment. So even recombinant FSH you can use. Still with comparison with clomiphene, it gives you much better reproductive outcomes. So gonadotropins are better. They give shorter duration of treatment, lower total gonadotropin zones, and better follicular and endometrial milieu or characteristics. So gonadotropins gives you better outcomes and better parameters, but you have to seriously use it very properly, because we don't want, because with gonadotropins you can have 5, 6, 7 follicles developing if the dose is not proper. I'll skip this few and go to the protocol. So you can directly start from second day. So if you want to use recombinant FSH, really you don't need to start 75 IU. Only dose, starting dose should be either 37.5 or only 50 IU, which is possible. This titration is possible with recombinant FSH. But with 75, if you want to give HMG, then you have to, starting dose should be 75. Then you monitor. Now depending on the dominance of the follicle or follicular size, you can decide to step up the dose and increase it till you find a good growth of the follicle. Now when you use gonadotropins, remember how you should judge that my dose is adequate. A follicle has to develop 1.5 to 2 millimeter per day. If it is growing good, there is no need to increase the doses. If it is only 0.5 to 1 millimeter, you need to step up. Okay, because that's what is the advantage of using gonadotropins. Now we did this study, which I wanted, my whole point of intention here today is, when you want to use oral ovulogins with gonadotropins with this protocol, which I mentioned that you introduce gonadotropins by 4th day. So we did our own retrospective analysis and we
checked our implantation rate, clinical pregnancy rate and miscarriage rate per stimulation cycle. What we realized, we use clomiphene on 2nd, 3rd day, and 4th day onward we introduce HMG 150, and we did almost all PCO patients. We did this stimulation cycle. What we realized, the positive pregnancy test per cycle was found to be 26%. Per cycle 26%, which was quite good. Clinical pregnancy rate was 17.48%. So cardiac activity out of this 26% patient, 17% had a good cardiac activity at 7 weeks. Miscarriage rate was only 9%. Then we calculated our per patient. Like suppose I might do 3 cycles for one patient. So I wanted to know if 100 patients I subjected, how much is the pregnancy rate for my patient if I do these cycles in this protocol. Then we found out that positive pregnancy was 47% per patient which was subjected with this protocol. Cumulative pregnancy rate was 31% and miscarriage rate 16%. Now let's see the main outcome, because gonadotropins is multiple pregnancy, we are more worried. Then we realized out of these all 25 pregnant patient, only one patient had triplet. So it was 4%. 6 out of 25 patient had twin gestation, that was 24%. Now that was little slightly higher than expected. And that's what 18 out of 25 patient had a single gestation, almost 72% had a single gestation. So it was not bad. So remember, if you want to increase your pregnancy rate, because we know IUI treatment cycles, ovulation induction IUI treatment cycle gives us a very average pregnancy rate. We need to step up with certain protocols where we increase our chances of getting success in the same cycle. And these are important things. Now what can be the adjuvants, the last important point, what adjuvants we can use? Suppose you are still want to use, you are a kind of a very, no, I want to use clomiphene only because I am happy and I am more satisfied with that drug as a ovulation induction drug. If you want to increase your ovulation rate with clomiphene, few adjuvants if you add, then it will help you to increase your ovulation rate and pregnancy rate, and that is CoQ. What is CoQ is nothing but is a good antioxidant which is naturally present in every cell membrane of the body. So if you give CoQ from outside, it has been seen that CoQ with clomiphene, ovulation rate increased to 70%, pregnancy rate which was increased to 48% in comparison with, we continued only clomiphene without CoQ. When it was stratified by obesity, means only obese patients were compared. Again, obese patient had a ovulation rate which was on the lower side, and non-obese patient had a 85% ovulation rate. Pregnancy rate was also with non-obese patient. So if you use CoQ with especially average weight or lower than average weight, I think those clomiphene resistance patients will do well with CoQ. Again, it has been seen that in clomiphene resistance, if you use oral contraceptive pills 1 cycle prior to your ovulation induction, it's going to down regulate pituitary. It's going to keep that LH also on the lower side during early follicular phase. So OC pills proven again better option as an adjuvant for clomiphene induction cycles. As we have seen, metformin or N-acetylcysteine, again, if you give N-acetylcysteine along with clomiphene, it has shown a significantly increased ovulation and pregnancy rate. So these adjuvants are good. So if you want to do clomiphene-induced cycle, these are the few things which you can add as adjuvants, and they have shown a better results. Ovarian drilling, I think big no, it's a last resort, we know. Still there are a lot of endoscopies, they practice ovarian drilling, and I think I urge all of them, please stop doing it. Because we don't need a surgical way to ovulate her. We don't need it. We have fantastic ovulation induction drugs. We just need to learn our skill to use them properly. Take my word and practice it. You use letrozole with HMG, you will not have single cycle where there is no follicular growth. Experience comes from 17 years. But no ovarian drilling. Please stop doing it. It's not required. Ovarian drilling is reserved only for those patients who cannot follow up with you. We know that possibly a poor patient, far distance patient who cannot follow up, you feel that I do drilling and I leave her alone because spontaneous pregnancy rate is good with drilling, but at the end of 18-20 months, at the end of 1.5 years to 2 years. But it is not shortest way of achieving a pregnancy. It has shown quite a side effects, destruction of ovarian reserve, ovarian adhesions. They are all side effects of ovarian drilling. So benefits are lower than the risk, and that's what we need to understand. The evidence is also clear. If you compare ovarian drilling with the gonadotropins, the pregnancy rates, live birth rate are lesser. So that should be your last resort, and I told you where you can use ovarian drilling. I think I'll skip now to summarize. Ovulation induction in PCOS needs individualization. Letrozole should be our first choice. Letrozole with HMG gives better clinical pregnancy rate than only clomiphene alone or clomiphene with metformin. And metformin as an insulin sensitizer is a very useful drug. I always feel that the moment I diagnose PCOS patient, I always like to put the patient on metformin first. Now the previous old dictum says that you select only obese PCOS patient and put them on metformin. Average PCO patient do not need them because they are only 20%. That incidence is quite old. We see now lot of below average weight PCO patient has a insulin resistance, and that is what is reducing our success rate. So I always feel that metformin should be started for our all PCO patients, and then use a ovulation induction drug. Do not use ovarian drilling as your first strategy. And sometimes those who are doing gonadotropin cycles learn how to use GnRH antagonists, because the biggest cause of failure with gonadotropin cycle is a premature LH surge. That has to be diagnosed. Maybe some other day I will speak about it. So true scholarship consists in knowing what things exist. We just need to know the physiology, endocrinology, and that's it. We have to handle the drugs. But what they mean, it is not memory, but the judgment. Whose judgment? It is our judgment. It's not what literature says. It is our own experience. When you start using drugs, will make you much better expert in handling and giving you pregnancy in a shortest time. So thank you very much for the patient here.
Explanation of all ovulation induction drugs. So when do you say PCO resistant means following 3 cycles of clomiphene citrate? But for the first time the PCO patient comes, ovulation induction, what is the drug of choice you are telling? Letrozole. Should we start then metformin along with that?
I will recommend yes. Only thing is I always recommend is that also do a GTT, 75 gram 2 hour GTT, because 20% of your PCOS patient not only have a insulin resistance, but they do have a diabetes.
That we know.
So we will miss out them who needs even beyond metformin.
But people who do not have insulin resistance, normal blood sugars, and even in fasting insulin levels normal.
Yes. So what you can do in such patients is, because sometimes subclinical insulin resistance is not picked up by GTT test. Okay. So what you should do is you should follow the ovulation induction cycles. The moment you see luteinized unruptured follicle within the time frame of ovulation, that is typically within 48 hours from SCG. If you have a luteinized unruptured follicle, 1 or 2 cycles, it's better to put them on metformin, irrespective of your GTT report. So that is very important. And also important is look for the clinical signs. So even acanthosis nigricans, hirsutism patient, I think you don't need biochemistry test to make you understand that she does have an insulin resistance. You can start with clinical
having
signs.
nigricans and all, but insulin levels is so normal sometimes.
Yeah, that's what. If you compare GTT with fasting insulin and those levels, still now none of the tests practically which we do nowadays is superior than each other. So you have to rely on GTT. Why? Because it is simple, very easily reproducible, and it gives you idea, because we don't want to miss out patients who are actually having diabetes. Their insulin resistance is severe, where they are having sugars like diabetes, and they need not only metformin but more additional drugs to control their sugars. And that's why please do GTT for every patient and give metformin to all of your PCO patients. It will help you definitely to reduce that insulin resistance, which is a kind of a tip of the iceberg which is lying below the sea, which we don't see, which we cannot diagnose by every test. That's why it is important.
Thank you once again. Thank you very much.
Recommend Dr. Suma Varsha to chair the next session, start the next session. Topic is low AMH, what next? She's a consultant at Ferty9 Hospital, Vijayawada, Joint Secretary, APIFS, member of Youth Brigade SR, Executive member of VOX. She has received Dr. Jaideep Malhotra Yuva Orator this year and Hall of Fame Award by Economic Times 2024. Thank you, Suma Varsha.
Thank you, Dear Chairpersons. So, today as Sir has spoken one end of the spectrum, I am going to talk about the other end of the spectrum, that is low AMH, low reserve, what next? So let's look at the story of this couple, 25-year-old Riya, 29-year-old Raj. They're married since 2 years. They're planning for a baby. She has regular cycles, and when the couple comes to us, we routinely do a ultrasound, transvaginal ultrasound, and what we notice is her antral follicle count is 2 in each ovary. So when the antral follicle count is low, the next step we do is we test for her AMH, and her AMH turns out to be 0.8. So I'm sure all of us are facing similar situations where we are seeing young girls, young ladies, recently married, coming to us, and they have regular cycles, they don't have anything else, which strikingly tells us she may have less reserve. But when we put a probe, we see that she has extremely less reserve. And this trend is increasing day by day. We are seeing more and more patients with less AMH. So if I am seeing maybe 10, 20 patients, I'm getting almost 7, 8 patients with a low AMH. So once we counsel her about this, there comes a plethora of questions. First of all, she doesn't accept it. She says, why did this happen to me? I don't have any bad habits. Why did this happen to me? Nobody in my family has this problem. My mom conceived, my sister conceived, then why me? Will I conceive naturally? Do I have to go for treatment? I am young. I just had a very short married life. Or maybe I'm not even trying properly for the last 2 years. Don't I have a chance to conceive naturally? Do I need treatment immediately? You mean to say if there's no time at all? Can't my reserve be improved? Can't you do anything? Can't you give me some medication where you can put me out of this situation? So these are the common questions that we encounter in such a situation. So all of us know that AMH is one of the earliest markers of ovarian aging. I'm not going into the details. It's basically secreted by the preantral, small antral follicles. And routinely we don't test for AMH because if the reserve is normal when we do an ultrasound scan, usually we go ahead with the treatment. But when the AMH, when the antral follicle count is less, generally we test it. But ACOG recommends that definitely it has to be tested for women who are more than 35 years. They have a history of smoking. They have a prior surgery for endometriosis. There is a previous history of oophorectomy, cystectomy, gonadotoxic therapy, or any autoimmune conditions like Hashimoto's thyroiditis and SLE. And as we had a huge discussion about metabolic disorders, any metabolic disorder also, I think AMH has to be tested. So generally more than 2.2 we have good fertility, less than 2.2 the fertility declines, and anything less than 1.2 actually is considered as less reserve. So there are a few terminologies which are a bit confusing. Premature ovarian failure, premature ovarian insufficiency. So failure is when FSH is more than 40 at an age less than 40 and she actually has amenorrhea. But premature ovarian insufficiency is a part of the spectrum of aging which occurs prematurely. That is, it occurs less than 40 years. When you expect the AMH to fall after 40, it is actually happening earlier. So initially it is occult where she has regular cycles, she has normal AMH and FSH, but she has reduced fecundity. Then it becomes biochemical where you see variations in AMH and FSH, but still the cycles are regular. And then it becomes overt when you even see amenorrhea. So that is a spectrum. And the biochemical part of it actually refers to the poor reserve that we are talking about, because that is where we actually trace, or that is where we actually figure out. Poor ovarian response is when she has good reserve, but she doesn't respond adequately. Say for example, she had 10 follicles to start off with. We stimulate her in an IVF, but only 5 ultimately grow, or less than 50% response is what we get. And functional ovarian reserve refers to only those recruitable follicles which actually can respond to our gonadotropins. So we have a non-growing follicular pool as well, which will not respond, and we have antral follicle pool, which are actually recruitable. So as the age increases, especially post-puberty, the non-growing follicular pool decreases and the recruitable follicular pool increases. So AMH peaks at the age of 20 to 25 years. And after 25 years, both the non-growing follicular pool as well as the antral follicular pool starts to decline. So this is what happens normally, but we have situations where this occurs at a faster pace in some of the individuals. So this was a study which was published in Journal of Human Reproductive Sciences, which stated that Indian women seeking for infertility treatment face early ovarian senescence. That is, you see a lot of Indian women at the late 20s and early 30s itself who come for infertility treatment having very low AMH. So the reasons, as I've already discussed, is increasing age, endometriosis, PID, obesity, chemoradiotherapy, autoimmune, surgical removal, whatever, all of this. But what about Ria? She didn't have any of these risk factors. So in spite of not having all of this, we still can have a low AMH. Now what are we actually looking at? So it could be something related to lifestyle changes. It could be intangible cultural factors linked to social habits, ethnicity, diet, genetic predispositions, environmental factors like endocrine disrupting chemicals. So endocrine disrupting chemicals, there's a lot of research in this area which has actually lead to increased oxidative stress, early senescence, early aging, decreased AMH. So the world is changing, we are technologically advancing, we are reaching the moon. But just look at this picture. What are we doing here? So 70% of water is unfit to drink in India and 40 million liters of water is contaminated in a day. 25% of the food we eat is adulterated. It is more than 40% in UP, Rajasthan and Jharkhand. We are consuming 40,000 microplastics, breathing 74,000 microplastics per year. Endocrine disrupting chemicals, there's a lot of data supporting that it actually plays a role in disrupting the hypothalamo-pituitary ovarian axis as well. So this was one study where the fetal ovarian cells were incubated with BPA, bisphenol A, which is an integral part of plastic, which shows that it affected the meiotic progression. So definitely these plastics are something we are getting exposed to. So all of these factors probably in Ria, she doesn't even know that it is happening to her. The food she's eating, the water she's drinking, the environment she's exposed to, the plastics that she's getting in touch with, all of these are causing some changes and she has no clue about all of these. So as Madam has elaborately discussed about the metabolic changes as well. So when glucose, carbohydrate, lipid metabolism, all of them are perfectly fine, reserve is normal. But when there is any changes that is happening, and there's a disruption in the metabolism, there is increased oxidative stress which causes early senescence because of increased apoptosis of the follicles that we have. This is a very interesting article which says that the reserve of the lady is predetermined by the health of the mother when the baby was in the womb itself. So exposure of the mother to smoke, diet, obesogenic diet, excessive caffeine consumption, malnutrition, all of these have an effect on the reserve of the baby when it is in the womb. So the reserve of the lady when she is in the reproductive age is actually predetermined by the reserve she acquires in the fetal life itself. So there is so much of connection and there are so many theories to explain what could be the reason for the less ovarian reserve. So this is very common query that many patients also ask me, you keep giving medications for my conception, will I lose my reserve? See, you're giving me medications for folliculogenesis, will I lose my reserve? But actually that's not how it is. Every month a few follicles are getting recruited and that is all that we can play around with. When do we actually suspect poor reserve? So when a patient comes to us with shorter cycles, so she typically tell us, I'm getting cycles earlier, maybe 3 days, 4 days, 5 days earlier than what I used to get. And when you do a day 2 scan, you already see a selected follicle, 10, 12 mm follicle. There again, you should suspect that the AMH is less and probably get her tested. So how do you manage now? What do you answer? What do you tell Riya and Raj? What is she supposed to do? So women with POR have a limited reproductive lifespan to conceive with their own eggs. So this forms the bottom line that, you have limited time to conceive with your own eggs. If you want your own biological child, you should do something fast. So early recourse to IVF remains the only option, though it has challenges of higher cost and less than normal success rate, which a normal reserve lady of her own age would have. So early means how early? How early do you want her to go for IVF? So early, does it mean the next cycle she has to come back for IVF? So this was an interesting study where it was done in the COVID time, where we had guidelines of shutting down all the IVF centers because it's an elective procedure. So the main concern was patients with poor ovarian reserve. So are we actually doing justice by waiting for 6 months because she may lose her reserve? So this study proved that 180 days of waiting did not actually affect the outcome. So by doing immediate IVF or doing it after 6 months, the number of oocytes retrieved or the live birth did not change. So it's okay. 3 to 6 months is still okay. So this was a study where they said that ovulation induction and IUI was equally effective in normal reserve patients and low reserve patients between the age group of 20 to 39 years. And this was one more study published in Fertility Sterility which says age less than 35 years, ideally ovarian stimulation with IUI in normal reserve and less reserve also had equally good results. So that's the news for our couple, Riya and Raj. You can try ovarian stimulation and IUI over a span of maximum 6 months. If they don't conceive, then proceed for IVF. But Riya is not satisfied. She says, do something and increase my reserve. I still want to conceive naturally. So she says, give me some tablets. Give me some medications where my reserve improves. So can we think of any medications? All of us have read about DHEA. DHEA, will it act? Can you rely on DHEA and allow her to go for a natural pregnancy? So how do these androgens act? Androgens basically increase the FSH sensitivity of the follicles and they increase maybe 1 or 2 follicles that reach the recruitable state. So that's how the androgens act, and DHEA basically gets metabolized to androgen and it increases preantral follicular growth and survival. It increases the sensitivity of the preantral follicles to FSH and increases the number of antral follicle counts. So more retrieved oocytes, better pregnancy outcomes. So it is basically given at 50 to 75 milligram for 3 to 4 months. But evidence is not completely strong enough to recommend DHEA to cause a major change. So whatever studies are there shows that it's not making much of a difference. But these are small studies. We still need a lot of data on this. So the similar adjuvant is testosterone. We usually use testosterone patches when we're doing an IVF. Initial results were that testosterone did help, but now after the T-transport trial, we have realized that even testosterone gel probably is not helping much. Coenzyme Q10 is an antioxidant. Basically, it reduces the oxidative stress, so it prevents apoptosis to a certain extent and probably increases the reserve to a certain extent. 200 milligram thrice daily for 60 days preceding IVF was associated with more retrieved oocytes. But all of these adjuvants do not actually have strong evidence in their support. So you just can't put them on these adjuvants and say, take your time and try naturally. You have to do something and you have to speed in her chance of getting her own biological child. Otherwise, she may have to end up going for a donor gamete. So IVF definitely beyond 40 years, less reserve, that should be the first choice. So all the evidence that we have says younger age, probably you can think of IUI, ovarian stimulation and IUI. So in IVF, basically, these are, I'm just putting it in a single slide because I don't want to go too much into ART at this point. So we have to give a good pre-treatment so that you get a synchronous cohort of follicles so that you have a good outcome. Adjuvants like DHEA, testosterone, CoQ, debatable they are. Ovarian stimulation, the recent ISHRE guidelines tell us that either antagonist or agonist, it doesn't matter. I mean, both of them have equally good outcomes. Mild stimulation, don't cross beyond 300 IU. Just because they have less eggs doesn't mean you dump gonadotropins and you get more eggs. You can only stimulate what you see. And growth hormone also, there is some contradicting data. During stimulation, growth hormone 2 or 4 international units have been tried. Dual trigger helps, and you should also be counseling for embryo pooling and dual stimulation. That is, stimulate in 2-3 cycles, pull up all the embryos that you get and go ahead for a transfer. Or a dual stimulation, that you stimulate in the follicular phase, stimulate in the luteal phase, pull up the embryos and go for transfer. So all of these can be tried in a patient with less reserve. But everything said and done, she is definitely going to have lesser chances compared to another female with normal reserve of the same age. So what about autologous platelet-rich plasma? So there are some studies which say that by injecting autologous platelet-rich plasma into the ovaries, there has been an increase in AMH, a fall in FSH. But again, data is not good enough for us to recommend it at this stage. And what about in vitro activation? This is also still experimental, where you take out fragments of the ovarian tissue, you add some activators, promoters, and then you retransplant the ovarian fragments into the body. But still, we need a lot of evidence on this. Stem cell therapy, again, this could be a promising future for patients with low reserve, where stem cells can move into the ovarian cell line, and probably this should be the way forward, but it requires a lot of research and a lot of papers on this. So of late, definitely we are seeing a lot of patients with less ovarian reserve, because basically patients are postponing their pregnancy because it's a biological clock which we can't stop from ticking. But of course, prevention is always better than cure. So can we really stop the biological clock from ticking? Yes, we can, if we do opt for an egg freezing and oocyte cryopreservation. So if you want to prevent somebody to land up in a stage of less reserve and they're struggling to have their own biological child, counseling them for this option is always a great thing to do. At the age of 30, we have only 12% of the eggs remaining. At the age of 40, we have only 3% of the oocytes remaining. And the chances of aneuploidy also increases as age progresses. So this is good data for us to tell our patients that, yes, if you want to postpone your pregnancies, freeze your eggs, right? So now, if supposing a patient is agreeing to, yes, say I want to go for social egg freezing. So when exactly do we ask her to freeze the eggs? How many eggs do we freeze, and what are the chances of live birth? So she says, okay, can I just freeze my eggs and plan whenever I can? Do you guarantee me a pregnancy? How do you counsel her? So optimal timing, ideally when the reserve is best, when the fertility is best, if you're able to preserve the eggs, it is ideal. Earlier the better. But data has told us that it is not going to be very cost effective and reutilization rates are less. So if a patient comes to us, say around 35, 36 years, and she says, I want to freeze my eggs, will you do it? They say yes. Even up to 37 years of age, if the patient wants to postpone pregnancy, still freeze whatever eggs that you can obtain, and she can still wait. The number of eggs to be frozen, it depends on so many factors like maternal age, ovarian reserve, reproductive goals, paternal health, and all of these. 15 to 20 is ideal. So you need 6 oocytes probably to get a blastocyst in an average fertile couple. So say supposing you have 3 blasts, 4 blasts, maybe 15 to 20 should be the number. But again, it depends on multiple factors. And this was one graph where they said that based on the age, you can calculate the number of mature oocytes you should freeze to get one live birth. My take home would be assessment of ovarian reserve by transvaginal scan is of prime importance. I have seen so many patients who come to us with a diagnosis of PCO, and when I put a probe and see, it will actually be poor reserve. So when you look into the details, it would be some transabdominal scan done by a radiologist. No offense, I'm not saying it's just no offense, but I'm telling you that this has happened several times. Doing a transvaginal scan by yourself is very important. If you're not doing it, sensitizing your radiologist to do a transvaginal scan when they're doing an assessment of a fertile couple is extremely important. Ovarian stimulation and IUI have equally good outcome in less reserved patients when the age is less than 35 years. So less than 35 years, give them at least 3 to 6 months time, let them go for IUI. Limited reproductive lifespan warrants early IVF, but don't scare them, you have to do IVF next month, otherwise you have to go for donor gametes. So, they're already in so much of shock. Don't put more stress on them. That stress is going to do more harm. Role of adjuvants like DHEA needs to be established with further clinical trials. So thank you so much for your patient listening. And I also take this opportunity to invite all of you to the South Zone IMSICON conference. We have a registration desk outside. Just if anybody is interested, please do register yourself. And we are doing this in association with Vijayawada Society. It's going to be a great academic feast.
Thank you, Suma Varsha. It was very clear regarding low AMH and what are the options and how to counsel the couple, and the role of adjuvants, and also not to waste much time going for the self-care. Thank you.
Varsha, you want to do routinely for young people of 2 years marital life. Why you have done this AMH, having regular cycles? Only because of 2 follicles are there.
Yes, she had less.
Then only you go for AMH estimation.
That's why
Otherwise, good follicles number is there.
Yeah,
there
if the follicle number is good, I'm not routinely
Any
doing
studies
AMH.
are there having shown AMH low in smoking, chronic smokers, and
Yes,
nutrition?
ma'am. Yes, ma'am.
Pollution.
Yes, ma'am.
Definitely it is there.
Yes. Any more questions?
Any questions from the
Kundan
audience?
sir is also there to take questions. Any questions?
And usually young patients conceive better with low AMH.
Yes, ma'am. Age is very important. Younger age group, they have always better outcome. But if they come with low AMH, just because they're young, we just can't leave them, take your own time. Give them some time, but not
3 to
much.
6 months.
Yeah.
You want to confirm this low reserve only with one estimation of AMH, or you want to go for 2 estimations?
One, ma'am. I mean, if
It
it's
is
a
enough.
good standardized lab, which you are routinely, then I think
One estimation is
Yes, ma'am. Yes, ma'am.
having shown very
Yes,
few
ma'am.
follicles.
It has very less intracycle variability. You don't have to actually repeat.
What about after 40 years, this reserve is definitely going to be low?
Anyways, it's going to
Definitely
be low.
you immediately go for IVF.
Better to go for IVF, but if the patient insists on self gametes, I will still allow them, but I will tell them that your chances will be lesser. Probably based on whatever antral follicle count I see, I'll tell them that, normal reserve patients, maybe they have 50-60%, yours might be 20-30%, and I still have couples trying. I had a patient recently, her AMH was only 0.2, she got only 1 oocyte, she got only 1 embryo, but she conceived. So not all of them are that lucky, but yes.
But one question mark we have put, no?
Yes, ma'am.
More and more number of OI is given. Is there any depletion of the reserve?
Yes, ma'am. Data is not much, but whatever data is available, it says it doesn't make a difference.
But
Because
still
actually,
questionable.
No, ma'am, it's not questionable. Multiple cycles will not decrease the reserve. Because whatever is available.
If I can make a comment, Madam, multiple cycles will not decrease the reserve, but what you need to think about it is, why are multiple cycles not leading to a pregnancy?
That we know. But
no, madam.
Not decrease the reserve.
The thing is, inherently, there are some people in which it is going to diminish fast. So, if you're going in for ovulation induction or anything, every person, their total time of exposure, irrespective of how many gynecologists they went to, it should not be more than 6.
So that's
that is my plea.
Once they change from one gynecologist to gynecologist, they put on again OI inductions 3 months, 6 months. So last time we heard not more than 6 cycles.
Yes,
we are supposed to.
That is the nice guidelines also, ma'am. It's just that if she's not conceived, then it's better to go for the next treatment. It will not decrease the reserve because every month we have a set of follicles, non-growing follicles, antral follicles, and that will not change. So just because you have used ovulation induction this cycle, it will not affect the recruitable antral follicle pool in the next cycle.
Yeah, but as gynecologists, the ultimate trump card what we should play is whatever AMH is, whatever follicles you don't have, you keep trying naturally.
Yeah.
Because you never know, we are treating, sometimes they don't come to us 3-4 months, they come as pregnant also. We have seen in our experience 0.002 AMH also conceiving with 0 follicles. So that we should always keep in mind, whatever AMH is, we have to play. Of course, you have to expertise the treatment, but tell her to try naturally also and encourage her. Sometimes they can conceive naturally also.
Yeah, so that is what is premature ovarian insufficiency. They may have spontaneous ovulation, spontaneous conception, despite having very low AMH. So trying naturally all the time is always helpful. Ideally 1.2 and less, ideally should be referred, but if you're doing IUI ovarian stimulation, you can still try 2 to 3 cycles if the age is young. But don't keep her waiting for too long. So 1.2 and less is...
Aim of us, all of us, is to make her a genetic mother.
Yeah.
See, sometimes so many times it so happens, her AMH is 0.5, 2 years she loses, and when she comes to us, there is no follicles at all. Then we'll be forced to tell her a donor, So our aim is to give her a genetic mother whenever we see her.
Thank you.
So any more questions from the audience? No more means we'll wind up. Thank you, Suma Varsha, for having given me this opportunity, beautiful opportunity, for the national speaker Kundan and for local speaker of you. Thank you very much. Very good academic feast. And I wish this FERTYGNAN 2024 will go further and further highlights. Thank you.
We request our chairpersons to felicitate our speakers with a memento.
Thank you, each of you, for making this FERTYGNAN Vijayawada grand success. So I understand it's the session is in between you and lunch, but please bear with me. I'll try to be as fast as possible. So, the urge of parenthood, it's not new. It's there since ages. On Chaitra Paksha Shukla Masa, trillions of years ago, 5114 BC, Lord Rama was born. Rama was born. Dashratha himself performed something called as Putra Kameshti Yajna. So it's not new. It's there since ages. This sir is Robert Fisher, sir. He is a very pioneer in the field of fertility. I think all my friends know him as well. So when I started my fertility practice 20 years ago, I used to read a lot of his books and something I could not understand as well. I wanted to go talk to him and ask him many questions, unanswered questions. It was very tough then. Every time we go to Ishray, sit with him, ask him some question. So life was then. But now if you see this slide, couple of months back in our every Wednesday journal club we had luxury of having him as a speaker, and he answered all of our 22 consultants' query. So where are we now? Thanks to the digital platform. Just by a click of button we can talk to people and ask questions. Yeah. Now if you see this, in my childhood, when I was just 10 years, I'm not getting this video. Yeah, Star Trek. Okay, this video is not playing. I got a video of Star Trek. When I was 10 years old, this was a very popular TV serial then. Every Thursday we used to wait for this at 5:30. When is Thursday happening? So then, in here it was like, Star Trek with a Spock and a captain. So whenever the Spock comes, he just presses a button and he can see people somewhere outside, somewhere, wherever it is. So I used to wonder, is it real? Can it ever happen? Can we see our friends who are somewhere on face? But then, of course, that's what it was then. Now you see, you all have watched this popular movie in Telugu, Maya Bazar. Maya Bazar, Dwapara Yuga, Krishna had already FaceTime, WhatsApp video call. Everything, he just used to open and used to talk. So whatever we see recent advances are already existing in the past. We are just finding out what was there in the past and we are repeating it now. So about fertility, if you say, what is fertility? What are the advances? I'm talking about advances in the fertility. Can we achieve this magic number 100? Is it possible? When we started the journey, when Louis Born was born, then IVF success rate was very less, maybe less than 15%. But 2000 it was almost 35, and now where do we stand? 2024, it's nearing 60s percentage, 60, 65. So that is something changed, right? Everybody wants, when they come to a doctor, they want to conceive. Somewhere recent advances are important, how we are progressing, to hopefully we should again put one dream now that magic number should be achievable, but it's definitely not so easy. Yeah. So I will talk first about little guidelines, little technology and little techniques. If you see the guidelines, I won't be talking what was in the past. We all know about PCOS, this new guidelines which has come in 2023, the last year. How is it different from Rotterdam's, which was in 2006? We all know Rotterdam's, we are aware about Rotterdam's. 2 out of 3 criteria, right? PCO 12 is the number. How is this different from the recent guideline? These are only 2 ideas I am putting in your mind. Here they have given very beautiful algorithm, the way you screen a woman of PCOS. There are 3 steps. What is the first step? First step is similar to the Rotterdam's. You see a woman with irregular cycles, and if she has hyperandrogenism in clinical, like you can just by seeing the women, you can see all the unwanted hair, hirsutism, all these. So you don't even have to do a scan. Don't ever go and do a scan. You understand she is PCOS. Now say suppose woman has irregular cycles, she doesn't have any androgen symptoms. She is just come sitting in front of you, I have irregular cycles, no hyperandrogen clinically. Then second step is do a biochemical test and then you diagnose. Okay, done. Now, if at all women comes with only irregular cycles without even clinic and biochemical, then or a woman come with only hyperandrogenism, then go to the step 3, that is you do a scan. So scan has been dragged towards last now. Why did they do this? See, any advances, they want to do good to the society. Previous Rotterdam, what was happening? Every sonologist used to do scan, 14, 15 follicles, PCOS. Pandemic of PCOS we started seeing. Now how to eradicate this pandemic of PCOS? So all the societies, if you see here, 3,000 healthcare professionals sat together. And then 1,000 multidisciplinary clinics. With all this, they came to this guidelines. And then other very interesting here is also the number of follicles they have changed here. We have to know about something called as FNPO, follicular number per ovary. It is more than 20 now, not 12. So just by doing this slight change, most of the non-PCOS people are out of the PCOS diagnosis. So this is very important. The second is another called as FNPS, follicular number per section. In one section you see 10 follicles, you can, but this is only step 3. It is not the step 1 and 2. And then of course, what about serum AMH? Either before AMH was never as a diagnostic criteria. Now as a step 3, they have even used either scan or an AMH for a adult women. But for adolescent PCOS, please don't do AMH and categorize her as PCOS. Very, very clear. So this is very simple. Look at this ovary, but just by seeing this, but you have to scroll from one end to the other end slowly and count the numbers. More than 20 in scan PCOM morphology. This is about PCOS. I am not going in detail. Just the diagnostic criteria, what is in the recent. Next is about, if you see about endometriosis. Just 2 words about endometriosis. Now we all know before, what was the gold standard in diagnosing endometriosis?
laparoscopy. I think now it is changed. The gold standard is not for diagnostic. Vinny, I can be very, because she's a surgeon and she's totally into endometriosis. Now I'm not telling about treatment, for diagnosing endometriosis, gold standard is no more laparoscopy. You can do this something called as idea consensus. There is this consensus of idea consensus where they have given again 4 steps to diagnose endometriosis. Very simple it is. First, when I saw these 4 steps, I was wondering what are these 4 steps. But it is the way you do a scan. First step is just, I will put the video, I have a video here. So, first is you take your probe, just go and see the scan. In the scan, you may see some adenomyosis. And then just scroll and then go to both the ovaries. Ovaries, when you see, if at all you see a endometriosis cyst, yes, that is the step 1. Then second step is, again find out, go and then see if there is any pain. She has to, and the mobility of the ovaries. Most of the time, if severe endometriosis, there will be adhesion and the ovaries are immobile. And then next, third step is do a sliding sign. Very easy. You know, the bowel usually is free. Posteriorly, it won't be attached. But in endometriosis, you do the sliding sign. You see the bowel won't slide away. Here I have this video with a sliding sign where you just put it to the posterior fornix and just slide it. And then usually in this, you can see the bowel and the ovary is attached to the posterior and it's not sliding. So most of the time, sliding sign positive or negative, people ask. Positive means it's normal ovary. Sliding sign negative is endometriosis because it has to slide away. And then fourth step is to see any nodules. So these are the 4 steps along with clinical history, like all the D's dyspareunia, dysmenorrhea, dysuria, with history and with this idea consensus, you can diagnose endometriosis. Laparoscopy is no more a gold standard to diagnose endometriosis. That something has changed in the guidelines. Yeah, this is how we demonstrate a sliding sign. See, for some endometriosis, do you have to do all, it's such a huge endometriosis, you don't even, by just look of it, you can diagnose this. And then, if say suppose you are posting the women for a surgery, I'm not here to debate between surgery and IVF now, I'm just enlightening you about EFI, very important. Say suppose you have posted the women for laparoscopy because she has pain or she has other issues, then have this chart, very important, EFI, Endometriosis Fertility Index Score. See, most of the time what happens, you call surgeon, you are seeing OPD. Surgeon does something and he goes away. You should know the relation of the ovary. You should know the relation of the tubo-ovarian mass, how much percentage of adhesion, along with that historical factors like age, duration, infertility, and they give a score, 0 to 10. Score 0 is the poorest prognosis, score 10 is the best prognosis, where, after doing this, you can act like a palmist to her. Her fertility index, you can tell her how much time she has to conceive. Next, I want to know by the rise of hands, how many of you do 3D ultrasound? Today I will urge most of them, after going back, just upgrade your scan and it's very wonderful. Initially, I'll tell you, I'm a person who usually don't like so much change in the life. But then once change, initially it is always difficult. In between it is messy. But once you change, it is something beyond. So please try to incorporate 3D in your daily routine whenever you are using. See, this looks a polyp, but then the polyp here in the sonography, it looks like this, saline sonography. But you do 3D, see where the polyp is sitting, just at the point where the fallopian tube cornu. Just knock off this polyp. Definitely natural conception chance is very high. And this woman, she came to us for IVF cycles. Repeatedly we were doing FET, we put lot of estrogens to prepare the soil. After 4-5 cycles, she used all the type of FET protocol. She failed, endometrium never came up. Then just one 3D we understood it's a unicornuate uterus. there is some shape abnormality. How much ever estrogen I dump, this endometrium won't come. So very important to understand 3D also. And then look at this, how nicely it is seen, communicating, non-communicating horn. And this, what is the finding here? Anybody can tell me in HSG? Very spot diagnosis, MCQ question. Unicornuate uterus. Fine. But then when we did a 3D, it's not a unicornuate. It's a normal uterus because of adhesions. One of the side is already, there is adhesions here. So just releasing adhesion helped her a lot. So that is the importance of 3D. So till now, I have told you what all is existing. But now I will tell you something which are in experimental, because we should know where fertility is going to. There is something called as SOET, self-operated endovaginal telemonitoring. You know how the advancement is going? You don't even need a gynecologist to do a scan. You give a probe to her at home. She will have a small probe. She'll insert into the vagina, and then now there is the smartphone. She'll connect it to the smartphone, and you sitting in the clinic, you can see her scan. But I should caution here, I think Dr. Hitesh sir will be talking about law. PCP and DT, he'll come and hold our neck. That is a different issue. We'll wait for that. Of course, there will be some censoring happening later, but this is what, because one of the company of ultrasound even approached us. They wanted lot of data, but then we thought we'll ask our legal advisor and then sign that contract. Things are there. So much change is happening. And then what about male infertility? About male, even people who, sperm test also FDA approved. It was already launched in India. They don't have to come to center. They can do a test like LH kit, put their sperm, and with the smartphone it will read. But again now, because of ART rules and regulations, this I don't know where this technology will go and lead to. Now, next is artificial intelligence, something really bothering me sometime. But of course, we have to encourage some things. See, this is a mother, a family teaching kids. It is, we teach kids, we tell this is apple, this is orange, that's how they learn. This is called as a not supervised learning. But when it comes to, that is human learning. When it comes to machine learning, it's a supervised learning. They put a machine, they get all scans and feed it to the machine. They get all data and feed it to the machine. And the machine learning, though it is monotonous, it can learn many things at a time. And it is a supervised learning. That is what artificial intelligence is. And then if you see, mostly more than fertility industry, it will hit the sonologists now. Because so much is happening in artificial intelligence. All my daughter's friends, whomever we ask, when our time it was medicine or engineering, we used to take path. But now anybody you ask youngster, I am in AI, I don't know what all these people are up to, where are they going? Yeah.
I have a point to make.
Yeah.
The patients are very smart.
Yeah.
I had a patient whose husband didn't want a child. But she wanted.
Okay.
There was a lot of this thing. And that guy used to use condoms regularly. It's very interesting. So this lady, what she used to do, that packed condom, she would take a needle and that with the needle. So she pokes that with the needle. So the condom becomes, damaged. And then that guy, I think they used to switch off lights and then do it. So that those damaged condoms, and that lady conceived. And after that, that guy, they came to me. They said, I use condoms. How did she conceive? So he started, doubting, suspicion. So then comes the role of counseling. That's what I want to tell.
I will take her story one more ahead. See, I usually tell patient to try naturally. Whatever IVF failed also, I tell you try naturally. So it so happened, one lady with azoospermia, she became pregnant now. So as a doctor, I am in a spot. What should I tell? I just told her, I don't know. Sometime it may happen. You don't have to dig inside, It's enough for the day.
Waxing and waning counts. That's your.
Yeah.
You have to tell. It can go up and down types.
Exactly. Yeah. So now, after pickup, even they can choose which is the best oocyte. It seems AI will choose. I think even in our center we are launching AI maybe in a couple of months. and that will select sperms as well, and embryos also it will choose. Now, I was telling our people, let AI do ET also, why are we here? And when beta HCG fails, let them talk, because most tricky is when it fails, sitting in front of patients and telling what happened. See, end of the day, wherever AI goes, clinical touch, human touch is of value. I somehow feel coming into this fertility field, we have become more spiritual. You know, you take 20 eggs 10 years before, you store that, she becomes pregnant. After 5 years, she comes back again for second set of embryos, 10 years before pickup. Again, life sets in. You don't even know when the life set in. So much is about human touch is very important in any field we choose. And there about antioxidant, there is something coming called as ROS analyzers. You don't have to repeatedly give antioxidants. There is a test which says how much antioxidants has to be given. RI witness is something where, gamete mismatch we can prevent. This is we have launched in our system where human error is 0. There is a barcode. We give it to every patient, and then once they put the barcode, only if there is any little mismatch, there is lot of alarm. So there is no way where we can have a gamete mismatch. So this is something called as we have also adapted to this new technology. And of course, in my inaugural, I have told about the Ziltrix. Ziltrix is something where you keep your embryos inside the lab, and when you go home, the baby has to be in a safe place. If there is any power fluctuation, this gives alarm to the system, and then we can immediately act. So the embryos are very safe. What about PGTA, PGT, all these exist, So many times it so happens, we should know when to use the advanced technology as well. And now there is something new. All my videos are not working. I'm very sorry. I got a lot of videos. So here this is something called as microfluidic chip. This I just wanted to enlighten you on. For IUI we need all the centrifuge, right? No, there is a chip. It's just like a visiting card. It has an inlet and an outlet. You put the raw sperm, process to the inlet. Half an hour you put in the incubator. After half an hour, you get the processed sperm. So this is some game changer. But then again, ART law wants the 4 apparatus when you come to give your licensing. That is a different part. But this is now we are using it whenever there is high DFI and there is male infertility within IUI and ICSI as well. It has definitely given little better success rate. Yeah. And then gene editing. So if some patients come to you and ask, Doc, I have my wife with BRCA, I don't want my kids to have similar breast cancer. There is something called as gene editing. So these are all the advances. There is a technology called as CRISPR technology where they edit a part of the gene and then a pregnancy can happen. The babies should be safe. So what about the designer babies? Most of the time they used to think fertility is all designer babies. Please, we are very far from that, especially of this. After this ART rules and regulation, getting a donor is so tough. It's not at all easy. Getting a donor egg, donor sperm has become very tough. Forget about designer babies. It is, the reality is different. And then here, if advanced technology goes to a different hand and if there is a designer baby, women always want more. They don't settle in less. Already I have got a designer baby. Next what? Let me have a designer husband. Let me see my luck in that. We never know where this stops. And then these are so many technologies. So I think Dr. Suma has covered about all these. I will just skip through PRPs. So ectogenesis, we all know. Now we don't need a woman also. Baby is outside the womb. What about, in our Mahabharata? That time itself all the surrogacy pots existed. Yeah. And then they say they can do a baby in the skin also, from skin. So if you see in our, Ganesh was born through skin itself. She took all her sweat and she made. So it was already existing then. So future of AI should be in the hands of Rama. It should not go to the hands of Ravana. It can lead somewhere. So some people should work on censoring what is not correct for the day. So I end my presentation with this, clinical touch is very, very important, very mandatory. Whatever AI comes, Human will be there, human will exist and control this. To end it, I had got a magic carpet. I was talking to Dr. Padmaja. This is some, in Alauddin Khilji movie, Alauddin, she has a magic carpet, Coming to Vijayawada was so difficult. Long time back, I had put a dream of seeing, FaceTime has come now. So one magic carpet where the hero takes the heroine and shows the whole world. So hopefully days should come true when we all have a magic carpet and our travel time decreases. Thank you so much. Thank you.
Dr. Hitesh Bhattu, our medical legal consultant for the past 23 years, who's a former chairperson, Ethics and Medical Legal Committee, FOGC, and he's a medical legal consultant for over 250 hospitals across India, and he's an office bearer, IMA, AMC, MOGS, and AFG. After the OB-GYNs always had life easy because our MT Pact was very simple. Then we had the PNDT, which made life complicated, and now we have a draconian ART and surrogacy law. And there are so many updates, so many rules, so many changes, so many public interest litigations that are happening. So I'm sure Dr. Hitesh will shed light on it and lead us to a litigation-free life. Welcome, sir.
Good afternoon. Yes, thank you. See, whatever lectures you have heard today, till now and whatever you are going to hear afterwards, will help your patient have successful treatment and happy life.
ART law from gynecologist perspective, what we must understand. And as I told you, law will definitely help you have happy life. So you have to understand the law. ART is no more a guideline. Previously there were ICMR guidelines where law was not there. Now what is the difference between guideline and a law? Guideline is something which your mother tells you to do. If you do it, it is fine. If you don't do it, it is fine. But law is something what your wife tells you to do. If you don't do it, you will have it. There is a punishment behind it. So those doctors who are practicing like this before the law, they have, after the law, they have to practice like this. They have to practice like this now. Right? The life is, there is somebody who is constantly watching you, constantly minding you, and we call them appropriate authorities. So that is what we have to keep in mind and we have to understand further. So first rule is, one can't open and start running new ART clinic or ART bank as per his desire, which previously we used to do. Now, what the law says, section 15, it says, no person shall establish any clinic or bank for undertaking ART or to render this technology procedure in any form unless such clinic or bank is duly registered. So you have to wait till the registration comes, just like PCPNDT. Those who were working before the law were allowed to continue their practice if they have applied in time, that is within 6 months of the declaration of the registry. But otherwise, it is not allowed. And one center in Pune got notice that why you started running a center. And there is no answer. See, in law, you have to prevent something from happening. Once it is done, you can't undo it. So you have to understand it properly. So these are the sections. The law came. Now, we have to understand the definition of assisted reproductive technology. What is the definition and how it will help you, that I will tell you when we will come to few questions. It says that ART with grammatical variations and cognate expressions means all technique that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the human body and transferring the gamete or the embryo into the reproductive system of a woman. That is very important. They have used the word and. One appropriate authority in some lab, the pathological lab there where they do all the tests, semen report they are doing, she was insistent in Mumbai to register that lab as ART clinic. She said, you are handling the gamete. What they have mentioned here is handling the gamete and putting it, intention to put it back into the human body or body of a woman. Just you are handling, you don't require. And I told that madam, I said more gametes are handled in every bedroom. We don't register them as ART clinic. So don't insist on certain things which are not logical. How to register what you require? You require these facilities. It is given level 1, level 2 and ART bank. These are the minimum requirements. What law says is minimum. Like for a ART level 1 clinic or bank, they have said centrifuge machine, incubator, microscope and laminar flow. But it also requires a table and a chair. You have to sit somewhere, right? You cannot let patient sleep on the floor and do the things. So you require what requirements here they have shown is minimum requirement, that much should be there. This is the schedule of payment and the validity of the license. It will be level 1 clinic, it will be 5 years, level 2 it will be 5 years, surrogacy clinic 3 years, and this is the fees you have to pay. What all you can do? At level 1 clinic, IUI with husband or donor sperm, right? Level 2, you can make the embryos self-oocyte, husband sperm, self-oocyte, donor sperm, donor oocyte, husband sperm, donor oocyte, donor sperm, and embryo should be transferred into recipient only, that is the couple. If you want to transfer any such embryo into a surrogate, it will require license for surrogacy clinic. So that we have to keep in mind. Now, how to register? You have to put an application will go to appropriate authority will satisfy himself, and within 30 days he will either grant the registration or he will refuse the registration. If he will grant the registration, it will be labeled as granted, a certificate will be given to you. Now what is level 1 and level 2? Level 1 is where only IUI procedure is carried out as a part of treatment. And what is level 2? Where any procedure which is mentioned in the IVF treatment, that is carried out. And one appropriate authority at Chennai, he started saying that level 2 clinic, if they want to do IUI, they will require level 1 registration as well. So you have to pay 2 lakh rupees plus 50,000 more. But if you read this, level 2, what it says the carry out, last one, carry out storage of gamete or embryos or perform any kind of procedure or technique involving the gametes or embryos. So it includes IUI. You don't require a separate registration, but many appropriate authorities are not understanding. If you are understanding, you can make them understand by making him read this kind of definitions. Selection of the patient is specific now. You cannot treat anybody with their choice. If they say that we don't want to have natural intercourse, we just want to conceive, do something, you can't do that. There are indications given, and we have to stick to those indications. Also, the age. Previously, we used to select any patient and we used to see this kind of news in the newspaper. And unfortunately, it came recently also in WhatsApp, it was making circles that very old couple has become pregnant, or unmarried couples have become pregnant, live-in couples. This is very important. What the law says, commissioning couple means an infertile married couple. Now, marriage is our responsibility to prove. Recently, there is one case filed where a husband has filed a case that this clinic has helped my wife conceive with the semen of her boyfriend. See, ultimately it leads to a succession act. If she will have a child, that child will have all the rights and property on that person. So you have to understand that for us it is embryo, but when it becomes a child, it creates a havoc. It leads to succession. And that is what is the aim. People want to pass on their legacy and money and whatever they have collected to their children. That is why they want children. Otherwise, if you can take it to the heaven, nobody will require a children. Right? Since we are living it here, they want child. So it also takes this property. So marriage we have to prove. Now, how can you prove marriage? Whether person is married or not? There are 4 ways. You can ask for marriage certificate, marriage registration certificate. You can also ask for Aadhaar card where wife of so-and-so is mentioned. 3rd thing, you can take ration card where husband and wife's name is mentioned. 4th is you can ask for passport where spouse name is mentioned. And if nothing is there, what we recommend is at least you ask them to make an affidavit that me, Mr. So-and-so and Mrs. So-and-so are married, we don't have any marriage proof, we want to take treatment at dash ART clinic, and if anything is wrong or any lies are there, then we are responsible, we want to avail treatment of ART from this center. That kind of affidavit they have to make on 100 rupees stamp paper with notary. That will at least save you. But we have to prove the marriage. Right? Socially, you can prove the marriage, like if the female is there, she will have bindi, she will have kumkum in her partition, she will wear Mangal Sutra. You can say she is married. And man, if he is sitting quiet,
not talking to anybody, you can say that he is married, right? But that will not work in the court. In the court, only these 5 things will work. So we have to be very careful. We have to prove the marriage. And it is, they said married couple, means it is our responsibility to prove that they were married. People used to treat at this age, right? 72-year-old woman just had a baby and they used to boast about it. Now it is not allowed. A clinic shall apply ART technology services to a female between 21 to 50 years and male 21 to 55 years of age. And in law, the limits are fixed. We are in medicine taught that hemoglobin is 11 to 15 or any cholesterol, it is 200 to 250. We are taught in range. But in law, there is no range. 21 years means 21st birthday, midnight 12. It is like election. In election, after 18 years, you are empowered to elect, to vote. That means on 18th birthday, midnight 12. If your birthday is falling before the voting date, you can. If it is afterwards, you can't. You have to wait for 1 more year. Same applies here. Don't just treat just 5 days more. Just 5 days more. You will have a punishment. So you can't do it. They can go to court and court will allow them to have a treatment. Be very sure about the age, right? Same thing is in MTP. If it is allowed up to 24 weeks, it is 24th week, midnight 12. Till that time you can do it. 1 minute before you can do it. 1 minute after you can't do it. It is that strict. What is infertility? They have defined. Means an inability to conceive after 1 year of unprotected coitus or proven medical condition preventing a couple from conception. Second sentence is also there. So if there is low AMH, if there is azoospermia, oligospermia, you can start treating them even before 1 year. Patient, we know that who is, and woman means any woman above the age of 21 years and less than 50 years. Single woman can be treated. Now, how to distribution of the gamete and its genetic. Now, how to get the donors? The bank is defined. There is a bank that will only give the gametes. So either donor or sperm. The bank will give either oocyte donor or a sperm. But it is from the bank. Bank is a separate entity. Even if it is in your clinic, you create a separate entity. That is what I say. You just say that this room is bank. So if that is get cancelled, at least that room will remain locked. Right? So make a bank separate from your clinic. The clinic shall obtain donor gametes from the bank and bank shall ensure that donor has been medically tested. So that is very important. We have to take various documents from the bank. Now, whenever a clinic gets donor from the bank, we have to ensure that the profile comes. There are 2 forms. For semen donor, there is profile has to be made in form M. That was ICMR form. That entire record should be there. Not only height, weight, and color of the hair, color of the eye, and blood group. We need whether he has any family history of any diseases there, he has taken blood in past or not, what his education, his occupation, his religion, everything is required. It was there in Form M. And let patient choose the donor. I am seeing so many cases, at least 5 to 6 cases related to donors have come to us, where a child after say sperm donation or oocyte donation, child is having some problem after 5 years, after 6 years. Recent one I got from Hyderabad recently, a case where a child is having some kind of anemia and they said you gave me wrong donor. So that kind of issues will come. And I foresee that if child will become bold at 18 years of age, they will say you have given me bold donor. I am not getting any girl for marriage for my child. And they will file a case against you. So please let them choose the donor. Let them sign it. And then only you give them the donor. It is very important. It is their choice. Females are very choosy otherwise. Even they purchase lady finger for 50 rupees, they will cut the finger with the thumb, right? They will check whether it is fresh or not. How can they take any child? Let them choose. It is their choice. Insurance coverage for the donor is required. For oocyte donor, this is required, insurance cover. And also, a guarantee has to be given by the couple that if anything will happen to the donor, we will pay. Now, looking at this, one appropriate authority, he asked that for semen donor, why there is no such insurance or why there is no such guarantee required from a recipient couple. I told him that, sir, it is not there in the law. You don't to insist on that, but still he was hell-bent on it. And I said, sir, I have yet to see a person dying giving sperms. There are females who have died giving under the oocyte pickup, but not giving sperms. That is why it is not required. Lawmakers are with the senses. So it is only for the oocyte donor. So this kind of, and there is a notification now, magistrate signature is not required, even notary will do. Screening of the donor is very important, and from whom to take the oocyte. That also the law says. The oocyte, the female age should be, donor's age should be 23 to 35, again 23 complete and 35 complete. Beyond 35 you can't take. Semen donor 21 to 55. And there is one line, a bank shall not supply the sperm or oocyte of a single donor to more than one commissioning couple. That means if a sample is sent, it has to be used for one couple only. Even if 5 vials are given by the man in one ejaculate, he has given 5 vials, you can't use that 5 vials for 5 different patients. It should be for one couple only. That is what it means. For oocyte donor, they have further said that not more than 7 oocytes should be retrieved. And all unused oocyte, that means out of 7, should be preserved for that couple only. So 7 oocyte is must. Now there was one circular, it says you take all the oocytes. If there are more, you have to take it. But you have to use 7 only. In that circular also it is mentioned, use 7 only. So in your 14B form, which we have to maintain, only 7 numbers should come, not more than that. A bank shall obtain necessary information, Aadhaar card, that is bank's job, but we have to take a Xerox of this. So what I insist is for 7 things you have to get from the bank if you are a clinic when you receive a donor. The Aadhaar card of the donor, verification of the Aadhaar card you have to ask for. You have to ask for form number 13 filled by the bank. You have to ask for the donor affidavit. You have to ask for reports, HIV, HBsAg, HCV, VDRL. These 4 reports has to be done by the bank. You have to ask for form M1 and you have to ask for a forwarding letter that we are sending this donor to you by this ID. So these things you have to obtain. Transfer of embryos. Previously, people used to transfer so many embryos when the law was not there, and there were, see, this is pentuplet, sextuplet, whatever it is, there are so many babies coming out one after another. This is a real-time video, and that was before COVID time. Like I see, there are so many babies coming. So that is not correct, right? You are putting life of a female into a threat. Law doesn't come otherwise. See, when you can't regulate yourself, somebody else will. And that is how the laws are made. So, section 24 now says that not more than 3 embryos or embryo may be placed in a uterus of a woman. And there is one more circular. It says that if you want to transfer, you have to transfer 1 or 2 embryos. And if you want to transfer 3, you should have a solid reason to prove that why 3 embryos were put. And there is a very interesting case. Also, we have to take signature of the patient in form I that how many embryo transfer she wants. There is a case in Mumbai where a female had twins. Now, she had 1 child. It was secondary infertility. The first child was 3 to 4 years. Section was done. She was 39. 3 embryos were placed. She had twins. And then she, because of twins, because of previous section, she had all the complications which we can think of. She had gestational diabetes, she had hypertension, she had placenta previa, she had polyhydramnios, she had PROM, she had premature delivery, premature labor, and she delivered at 32 weeks. Cesarean was done, she had PPH, she was in ICU, both the child, they were IUGR, they both were in ICU, NICU. For 2 months, all 3 were in an ICU. 1 male, 1 female. After that, she came and gave 1 female to the clinic. After the discharge, she said, you keep this one. I told you to have 1 more child. Why you have given me 2? You have not, my pediatrician told me that why you got 3 embryos transferred. I did not know. See, number of children also they decide. We can't decide. And she said, my mother-in-law is not taking care of this thing. My previous child is 3 years. Now these 2 are added and she says, I can't handle. One of you take the off from the job and you stay. She said, I am earning 60,000 rupees a month. My husband's salary is much more. I will leave the job. So you pay me or you take the baby and take care of it. So are we taking that signature? How many embryos we are transferring into the uterus before transferring it? You can't put it at your whim. It is their choice. We have to tell them. So please write the genetic material properly and please write number of embryos to be transferred into the uterus properly in the plan. That should be told to the patient. Or else, we should not have our own children. People will come and give us. We have to raise them only. Right? So, better not to have our own child. That is another option. Storage. For storage, they says gamete of the donor or embryo shall be stored for a period not more than 10 years. So, gamete of the donor and embryo, any embryo, that cannot be stored more than, but self gametes can be stored for more than 10 years. Right? And sale and transfer of the gamete is not allowed. Sale or transfer. That is not allowed unless there is a permission from the national board. So you cannot shift embryos or sperms from one place to another. Anonymity. Anonymity was very much given importance previously. Why? Because, as I told you, it leads to succession. Now, if somebody has come to know that I am not the biological parent or my biological father is Mukesh Ambani, or somebody has become Mukesh Ambani, not by giving sperms as a donation, but by some other business. Once he has given some sperm in the donation and the child is born, child comes to know that there is a link, he can ask for his property because there was no law before. So anonymity was must in that time. And that is why we were insisting on anonymity. But today it is changed. Why it is changed? Because Section 31 of the ART Act says that the child born through assisted reproductive technology shall be deemed to be a biological child of the commissioning couple, and the said child shall be entitled to all the rights and privilege available to natural child of that commissioning couple under any law, and the donor shall relinquish all the parental rights over the child. And they are signing form number 13 and form number 15 for same purpose, that we are releasing all the rights on the child and child will not have any right on me. Form number 13, the female signs, oocyte donor signs. Form number 15, the sperm donor signs. So that is why it is important. Just like Adoption Act. In adoption, you used to know that these are the real parents. But in Adoption Act, it was mentioned that once the child is given for adoption, there will not be any right on the previous parents. Same thing is here now. So anonymity has gone. But still, if patient wants to, donor wants to remain anonymous, or she wants to maintain her privacy, there is a line added that I understand that there will be no direct and indirect contact between me and my information identity will not be disclosed to the recipient or to the child born through it if applicable. That means if she wants. A female a patient can bring their own donor, their own relatives as a donor, and that is allowed because anonymity is not required. And who else will give otherwise without any payment, right? So relatives will come. So that is allowed and they will have no right in future on that child. So that fear is gone now. There are certain other FAQs. Can I stimulate the patient without registered as ART clinic? Yes, you can. For registration is required for ART practice or ART procedure. I told you, both the things are required to handle the gamete outside and putting it back into the genital tract. Now, when you stimulate, you are doing neither. You are neither taking it out, nor you have intention to put it back. So, you can do it. And I have to give this example. In law, it is not, nowhere in the ART Act it is restricted. And the thing which is not prohibited is allowed. We are living in a free country. The thing which is not prohibited specifically is allowed. Sir, this is applicable only in the law. In practice, don't apply it at home. Right? There are things which are not prohibited but still not allowed, right? So you have to be very careful if you are husband. But otherwise, and I will give you one example. One girl, she was at her bank of river and in the evening around 7 p.m. she started removing her clothes and she just came into one bikini and one policeman was looking at her. She changed into a bikini and she was about to dive in that river. He said, "Madam, after 7 p.m. diving and swimming is not allowed." She said, "You should have told me when I was changing." He said, "That is allowed." Same thing. Stimulation is allowed, but taking it out and putting it back is not allowed. So understand that. Can any laboratory process semen without registration? Yes, they can process the semen, they can teach, because they don't have any intention to put it back. If they process it, fine. but they can keep it as a souvenir. They cannot use it for any purpose if they are not registered. Can I get processed semen and do IUI in my clinic? You can't, because how will you shift the embryo, gametes? Without national board's permission, you can't shift. And national board gives permission of shifting of a gamete or embryo from one center to another, not from unregistered center to a registered center. So that clause will come here and you can't do it. Can a level 2 clinic allow outside doctors to do pickup or stimulate and accept the patient? Yes. Legally there is no restriction, but you have to be careful. It is like at the airport. Can I take care of somebody's luggage? If somebody gives me a bag, sir, please take care, I want to go to a loo. It's okay, you can do it. There is no legal risk. But anything happens to that, anything is found from that luggage. See, there are narcotics. You are liable for that because you are caught with that thing. Similarly, when you accept the patient from outside, there is no restriction, but you are taking all further liabilities of that patient. If that patient will have, say, central venous thrombosis, there are 2 cases recently I got where there is central death immediately after the pickup or after embryo, 15 days after the embryo transfer. In both the case, patient died, and it is because the postmortem and other opinion came as central venous thrombosis due to hormone use. Then you can't say they have stimulated. It happened in your premises, you are liable. So please be very careful in accepting the patient from outside. There is no restriction, but there is a caution. Documentation is very important. I am not talking about medical documentation, but there are various forms, and these forms are part of the rules. You have to fill all these forms as appropriate conditions, and this is a chart, and this chart you have to follow. What forms to fill. And these forms, if you will not fill, there is a punishment behind it because it is ART Act, just like PCP and DT Form F. See, and what is the punishment? Last thing is this one. If any rule, just like PCP and DT, they have used very vague word, whoever contravenes any provision of this act or rule, these forms are part of rule. The punishment is fine of 5 to 10 lakh rupees for first offense and subsequent offense 3 to 8 years of imprisonment. So if 2 places you have not signed, or you have not put the date, or you have not written the name of the patient, for first offense there will be 10 lakh rupees fine, and for second offense there will be 8 years of imprisonment. So this is it. You have to be very careful about this thing. So you can go to jail. This is a criminal offense, right? So you have to be very careful about that. So what I say is, in ART, a small mistake can lead to a big disaster. You have to be very watchful about all these things, right? And also, if you go to jail, it is not a bad place. What I tell is, don't fear jail, because jail is a good place. They give you food, they give you work, they give you some recreational activities. You will have Z security. Wherever you will go, there will be 4 policemen around you. They will give you clothes. And most importantly, you will get to see your spouse 1 in 15 days. What more a government will do for you? So whenever there is a patrol, there is possibility of fire. Whenever there are clouds, there is possibility of rain. And whenever there is law, there is a possibility of litigation. If any notice is received, anything happens, these are last slides. Just take medical advice, legal advice, and medico-legal advice. Why medico-legal? Because general advocates, they don't understand our concern, they don't understand our language, right? It is like ENT surgeon, though he is dealing with the discharge from the ear, he can't treat vaginal discharge, right? Because he doesn't know what to do. Similarly, there are more than 10,000 laws. Every lawyer don't know medical laws. So as I don't know banking law, I don't know family laws, I don't know the Land Requisition Act, I don't know company laws. There are so many laws which I don't know. Whatever you are specialized, you know only that thing. So what happens to if you go to any random advocate? See, there was one board, only tennis shoes allowed on the court. And one lady went there with only tennis shoes. That is what happens with the advocate who don't understand our language. Or this girl, she is in some foreign country, and you will come to know what she requires, right? See, she has come here, and she needs something, right? But he did not understand. Right? Lawyers don't understand our actions also. Why this was done, why that was done. So that is why you must have proper advocate. And if you want to be 100% safe, because after listening to me, many people feel very tense. So if you want to be 100% safe from medical legal issues, you can start your band, you can become photographer, you can join Bollywood, you can join some Baba, or you can join Daud gang, because there also punishment is 8 to 10 years of imprisonment, right? You can join any of this. But ultimately, what I mean to say is, you have to run away and leave medical practice. And that is not possible, right? My teacher used to say that if you do not perforate a single uterus, you are not doing enough MTPs. Similarly, I am telling you, if you are not getting a single notice, you are not having enough OPD, right? So what I mean to say is, there is a possibility of medical legal problem. So if you follow Baba Ramdev, you may learn some asana to diagnose your own piles. It is possible. But it is impossible to be out of medical legal problem while being in a medical practice. It is bound to happen. So don't worry about that. Do not think of leaving ART practice. Anywhere you go, the problems are there. Sometimes we look for things very far off, but actually it is very near. Similarly, if at all you need me, I will be just round the corner. Do not panic if you get a notice. Do not keep concentrating on a problem which has happened. You may harm the other normal case. Do not let that also happen. Just continue your journey, not only walking, but dancing like this baby. Thank you very much. Thank you for patient hearing. Thank you.
Thank you, Dr. Hitesh, for the wonderful talk. I'm sure not a single person moved out of the hall towards the lunch session. And
I must compliment Dr. Jyothi on having such a wonderful speaker with the pre-lunch session. Thank you.
And I'm sure sir is available for questions. Oh, always. Thank you.
We request our chairpersons to felicitate our speakers with a memento.
They had prior risk factors like a cryptorchid surgery done. So in those cases, you go for scrotal ultrasound. But otherwise, physical examination is the cornerstone. And then moving on to truss. Truss, normal seminal vesicles are less than 1.5 centimeters in APD. So in transrectal ultrasound, if it is more than 1.5 to 2 centimeters in diameter, so it indicates that there is some obstruction in the lower part. So it could be your ejaculatory duct obstruction, or it could be even in the and another important thing is presence or absence of seminal vesicles. Most often in patients with bilateral absence of vas, there is seminal vesicle aplasia as well. There are wide variety of grading systems, ultrasound grading systems for varicocele, but for treating the varicocele or diagnosis of varicocele, again, physical examination is much more important. So varicoceles are present in approximately 19 to 41% of men with primary infertility and also 80% of men with secondary infertility. So diagnosis according to ASRM or EAU guidelines is based on physical examination. Ultrasound is only post-varicocele repair. If you suspect recurrence or persistence, then probably ultrasound. And ultrasound criteria are wide varied, so we will not be going into the criteria. Let us look at a scenario. Here we have a 33-year-old male. He had secondary infertility of 3 years duration. Wife is 29, has no fertility issues. There is bilateral grade 2 varicocele on physical examination. And on ultrasound also, it is a bilateral grade 3 varicocele, but the testis size is normal on ultrasound. Hormonal assessment is normal, semen analysis is normal, including DFI. So how will you proceed? Do you treat the varicocele or not? We don't treat the varicocele, because varicocele treatment is if varicocele is palpable on examination and associated with infertility and abnormal semen parameters. If the semen parameters are normal, you have a normal DFI, there is no role of treating varicocele. Probably we need to relook at the female partner evaluation. Moving on to the endocrine evaluation. So all of us know the HPT axis. For females, it's HPO. For men, it is HPT, hypothalamus, pituitary, and testicular axis. So what we need to understand in hormonal evaluation is, it is advised in men with abnormal semen parameters, sexual dysfunction, or in men having known or signs of endocrinopathy. So We have FSH, LH, everything normal in normal spermatogenesis. Primary testicular failure, that is hypergonadotropic hypogonadism, so wherein FSH, LH are elevated. Hypogonadotropic hypogonadism, also called as secondary testicular failure, wherein the FSH, LH are low and testosterone is low. So if we look at the incidence of all these three scenarios, we need to understand that hypo, wherein FSH, LH is low, and these patients are the patients who are amenable to medical treatment. They constitute less than 10% of the population, but an important 10% who would require medical and who would respond to medical treatment. And also in hormones, we check estradiol and testosterone ratio. Because if the testosterone estradiol ratio is more than 10:1, then it is good. But in obese males, especially where the estrogen levels are high because of peripheral estrogen production, they do present with hypogonadism. So treating them with aromatase inhibitors like letrozole will give us better results. And then prolactin, yes, you do evaluate if there is higher prolactin levels. Moving on to post-ejaculatory urine, it is done only in patients with low volume azoospermia or low volume and severe oligoasthenoteratozoospermia, wherein you are suspecting retrograde ejaculation. So to suspect retrograde ejaculation, low volume sample, then only you go ahead with this. So classification based on semen analysis could be low volume ejaculate, azoospermia, or oligoastheno or astheno. So if we look at it, to roughly divide patients based on volume, if you have absent or low volume ejaculate, you need to rule out. First is sample collection problems. Was entire sample collected? Was there any spillage? Was there any problem with the abstinence? Once you rule out all this, then you look at post-ejaculatory urine to rule out retrograde ejaculation. And if that is not so, then you look at transrectal ultrasound to look at obstructive causes. Moving on to the azoospermia. Azoospermia, yes, we have various causes, but our focus would be, is it treatable? That is amenable to treatment. So pre-testicular causes, like you have endocrine problems, hypo, can be treated medically. Post-testicular problems like ejaculatory dysfunction or obstruction, we are pretty sure we would be getting sperms for surgical sperm retrieval. But testicular causes, we might or might not get a sperm. So in azoospermia, how do you go about? First is physical examination. Was present, absent? Was absent, direct diagnosis, CBAVD. If vas is present, then you look at testicular size, FSH levels. If testis is small, FSH is elevated, indicates that it is primary testicular failure, or if FSH is low, it is secondary testicular failure. So moving on to the genetic evaluation. Now that we have discussed AZU and obstructive and non-obstructive AZU, genetic evaluation is a very important component of male partner evaluation. Especially what we need to understand is, in cases with non-obstructive and severe oligoasthenoteratozoospermia, we need to look at karyotyping and also Y chromosome microdeletion testing. Because karyotyping, most common abnormality is Klinefelter's, and Y chromosome microdeletion, it gives us the chances, it predicts the chances of surgical sperm retrieval. The only test which is used to predict surgical sperm retrieval is Y chromosome microdeletion. So patients with AZF-C deletion have a higher chance of surgical sperm retrieval, whereas AZF-A and B have poor chances of surgical sperm retrieval. And moving on to obstructive. Once you diagnose patients with obstructive, the most important thing is there is an association with cystic fibrosis, and it is an autosomal recessive condition. So if you want to evaluate only one person, then I would advise evaluate the female partner. If female partner is not a carrier, then you are pretty sure you can go ahead with your ART treatment irrespective of the male partner evaluation. But if possible, evaluate both the partners to rule out cystic fibrosis. And the role of male partner evaluation in RPL and unexplained infertility. Sperm DFI. Nowadays, many people are advising DFI. So is it useful? What we need to understand is semen analysis is a information about the messenger, whereas DFI is the information about the message, that is the chromosome, chromatin content. So why after knowing that DFI is so important, it is still not a norm. Because what we need to understand is not all DNA nicks are detrimental. There is an autocorrection mechanism in the body. Nature has provided a wonderful autocorrection mechanism. So we don't know, we don't have a test to differentiate between pathological and physiological nicks. And also we are incapable of evaluating the genes affecting the fragmentation. But still DFI is advised in these specific conditions. One is unexplained infertility, recurrent pregnancy losses, and also patients with previous ART failures, and also varicocele. And also patients associated with risk factors like smoking, alcohol consumption. So there are wide variety of tests again for DFI. So different labs use different tests. What you need to understand is the DFI cutoff for different tests is different. If your lab is using SCD, the sperm chromatin dispersion test, which is the commonly available kit, then the DFI cutoff is 30%. But if they are using a tunnel assay or if they are using an SCSA assay, then the cutoff varies. So you need to look at your lab report, what was the test used before you interpret the test. And then management, yes, depends on the risk factors and controlling the risk factors. Another test which is coming up is the test on ROS, reactive oxygen species. I would not be covering much because you have a talk coming up on that. And last but not the least, male partner evaluation is also an important opportunity to evaluate underlying pathologies. This should not become a lost opportunity because sometimes, if you have noticed, erectile dysfunction has been quoted as the earliest sign of cardiovascular disease. So a young male has no psychogenic issues, still coming up with erectile dysfunction, definitely needs an evaluation for cardiovascular problems as well. So it is a marker of somatic health, can indicate psychiatric issues, cardiovascular metabolic syndromes, and also underlying malignancies like in cryptorchidism. So the take-home message is history and physical examination, no matter how far we have gone, still remains cornerstone for our treatment. And also ultrasound should be used as a selective tool. Genetic evaluation in specific cases is very important to prevent transmission to the next generation. And also working collaboratively with fertility specialist and reproductive urologist can give us better outcomes for our patients. Thank you.
Well said, Sravya. If semen analysis shows abnormal forms, what is your treatment? Normal forms more than less than 4%?
For isolated teratozoospermia, that is if there is no other abnormality, only teratozoospermia, we have to look at what are the abnormalities, ma'am. If it is only 2%, 3%, still no treatment is required. We need to look at the risk factors. If patient has underlying risk factors like smoking, obesity, we need to advise them lifestyle modification. But if the semen sample shows specific abnormalities like pinhead sperms and also tapered heads, these can affect fertilization. Pinheads are commonly noticed in varicocele. So if semen analysis shows abnormal forms, majority pinheads or taper heads, we need to go back and look at the physical examination or the ultrasound report to see if there is an associated varicocele, and treating that probably can improve the outcomes.
Can coenzyme Q, these antioxidants can cure this problem?
Coenzyme Q, among the plethora of antioxidants available, coenzyme Q is the only one which has grade A evidence. But it is proven to improve more on the motility pattern rather than the morphology. So morphology is most often genetic also associated.
Okay, thank you. Any doubts from Adi?
Liquefaction. Liquefaction is a function of the prostatic glands. So we have seminal vesicles secreting the alkaline secretions, prostatic enzymes secreting the acidic. So if your prostatic function is compromised, then liquefaction is prolonged. So if the liquefaction is prolonged, we need to look at infections. So if there is an associated epididymitis, prostatitis, and probably treat them, then the semen sample liquefaction improves.
Thank you, Sravya. We go on to the next session. So the next session is by Dr. Anuradha Kar. So it's my proud privilege to introduce Dr. Anuradhaka. She is the Director, Nurture Fertility, Bangalore, Member Managing Committee, ISAR, Joint Secretary, Karnataka ISAR, former Treasurer, Karnataka ISAR, and she is the author of articles in index journals and chapters in several books. Madam is going to talk on optimizing IUI outcome. Over to you, ma'am.
I think we are all in carbohydrate coma post lunch, but I'll try to make it short and interesting. Good afternoon, everyone. A big thank you to Vijayawada OBG Society, Dr. Jyothi Budi and Dr. Suma and the whole team of Ferty9 to organize this academic event today. So the topic today I'll be discussing is optimizing IUI success. I think how many of you are doing IUI in your centers? Huh? Yeah, you can't do in unregistered. How many of you are registered centers? Anyway, so see, IUI is a very easy process. It's not too expensive. Anyone can do with basic fertility and reproductive endocrinology physiology knowledge. Anybody can do. But what is important is per se IUI has less success rate compared to IVF. So what should we do to optimize our success? Now we know what is IUI. I'm not going to tell this. So indications commonly are for ovulatory disorder, male factor, endometriosis and coital dysfunction. There's sexual dysfunction like vaginismus, erectile problems, ejaculatory problems. Which factors, if a patient walks in that she has this, and you'll be little bit satisfied that, okay, this is a good result patient, I'll get good result. So it's unexplained infertility, cervical factor problems, anovulatory, donor IUI. These are the best results. Now where we get poor result is severe male factor. So like 1 million, 2 million count. We will not have good results there. Tubal factors, pelvic adhesions, severe endometriosis, that is grade 3, grade 4, and severe PCOS. Now, we all know that we'll do the general workup, the hemoglobin and everything, and thyroid is very important, prolactin. You will do an FSH-LH of every patient who comes for IUI and an antral follicle count and a general TVS to rule out other pathologies. So this is the thing I have made. So what is most important is today I would highlight your success will also depend on if you're doing ultrasound yourself. I would request all of you to get basic ultrasound training, especially the youngsters who are coming into this field. Transvaginal ultrasonography, if you do it yourself, the cycle you will control well. And then you will know what's happening. You will have an eyeball on the endometrium, the type of endometrium, and the follicle size will measure properly. In radiology centers, they are sometimes in hurry and some junior will measure the follicular size and it may not be proper. So do your own ultrasound, and transvaginal ultrasound is the best. One patent tube at least before you proceed for IUI. We should not go for blind IUIs nowadays because we are practicing evidence-based medicine. So at least one of the tubes, if patient doesn't have associated problems, can just do a simple HSG and see if there is patency of at least one tube. What is most important is counseling because IUI per se has hardly 20-22% success rate. Okay, so what we have to, patient comes with big hope that I am going to conceive. I'll do this IUI, I'll spend say 10,000 rupees and I'll conceive. We should not give false hope to the patient. One, explain the procedure properly, the physiology behind it, basic how the pregnancy occurs in a natural way and what you are going to do. Procedure details you have to give, number of visits because many women are working, and success rates, very important. Consent forms, registration of the ART clinic level 1, and the cost, financial. This you have to explain. Now, does age have a bearing in success rate? Yes, definitely. For women, age is the most important So maximum success rate in 2008, they have done this RCT, that they saw that less than 25 years of age, you get the best success rate. But in 2010, they said less than 30 also we have. More than 35, the success rate drops. And also the age of male partner also can adversely affect the outcome. Now, there's one entity, unexplained infertility, where we can't find a cause with the standard testing. So we have 2 randomized control trials on IUI, 31% live birth rate with IUI compared to 9%. So if a patient comes, young patient, and she's not conceived for 3-4 years and you can't find a cause, so she's, for technical purposes, unexplained infertility, and she said, I want to wait. So you can give this figure. So if you wait and try naturally, you have 9% chance. And if you do IUI, around 30% it goes. Very good success rates in unexplained. Stimulated cycles in IUI, best rates, they compared this, that clomiphene with FSH stimulated. So clomiphene turned out to give better success rate in unexplained infertility compared to the gonadotropins. Does duration? No. When a patient comes, you take the history. First question we ask, how long are you married? So highest rate of success is if the duration of infertility is less than 3 years. So if less than 6 years, conception rate 20%. If more than 6 years, conception rate drops to 50%, that's 10%. So the longer the duration, the success of IUI is less. So this you have to keep in mind. Now this is a very common question, like the patient will ask before starting, at least they ask us in Bangalore, that how many maximum cycles we can do. So this is your answer, that pregnancy resulting from IUI occurring in first 3 to 6 treatment cycles. Most women, we should remember this. I have had patients who have done IUIs for like one year, intermittently. So that's not correct. So 4 to 6 cycles within that time frame, most of the patients who have to conceive with IUI will conceive. And the fecundity rate will decline by half to 2/3 after 6 cycles. So this has to be kept in mind. And 88% will conceive within 3 cycles. So, and 95 4. So best chance of conception is first 4 cycles. So I do not go beyond 4 cycles. I don't go for 6 cycles unless the patient has sexual dysfunction. In that you can go 6-7 cycles. Okay. We have the NICE guidelines also, up to 6 cycles for patients of unexplained infertility, male subfertility, cervical factor, minimum and mild endometriosis. They said you can go up to 6, but I don't agree in endometriosis up to 6. Yes, sexual dysfunction, I agree. What clinical conditions will have best results? Okay. So you have higher pregnancy rates with unexplained infertility and ovulation dysfunction. That's the good result patient. Moderate in cervical factor. And who are the poor ones? Endometriosis. Now if there's any immunological infertility. And male factor. Okay. And in male factor, with ejaculatory or erectile problems, you get the best success rates. If there is something called we do ovulation induction in most of the IUI patients. Now, patient may ask you, doctor, I want to do a natural cycle without any medication, just I'll come on this day and you do my IUI. So should we agree? I would say no. Most of the IUI cycles better to do the ovulation induction, except if the patient is unable to have vaginal intercourse because of physical disability, psychosexual problem or erectile dysfunction, and specific considerations, sperm washing with HIV positive donor, and people of the same sex relationship, donor IUI. These patients, you can still go for the natural cycle without any induction. So I think we had a long session on stimulation. I'll quickly summarize. We have natural cycles, that's no stimulation is done, clomiphene, letrozole, CC plus gonadotropin, letrozole, gonadotropin, only gonadotropin. These are the cycles we use for IUI. How do we decide the stimulation protocol? Remember this chart. Natural cycle plus IUI, 3% pregnancy rate. Clomiphene with IUI, 9%. Clomiphene with HMG and IUI, 13%. Your best rates is HMG plus IUI, around 17%. So little bit about this, that how we do, like a combination cycle, which most of us do, a CC HMG or a letrozole HMG. So there's conjunctional regimen where we give CC or letrozole for 5 days, and from third day, 5 days we give FSH 75 and HCG trigger at 18 to 20. This is one way of doing it. The other way is that you finish your CC or letrozole, whatever, do an ultrasound 6th, 7th, 8th day, 3 shots of FSH you give, or HMG, whatever, and HCG trigger at 18 to 20. So these are the 2 commonly followed regimens. I thought I should tell you. Success rates are good. Now this is a forest plot. You can clearly see that IUI, the pregnancy rates are more. It favors the gonadotropins, the other side. And there are anti-estrogen means clomiphene. If you do only clomiphene versus gonadotropin has better success rate. This is the same thing. How do we monitor? First I said, learn doing an ultrasound. Have a machine. Do the PCPNDT of that center. Please do your own ultrasound. Okay? So how do we do monitoring? Now this is a chart we use, wherein we put the day and everything. So these are the regular charts. And how the follicle is monitored TVS, 2 perpendicular to each other, in one direction and another. So you should have like this. This is don't measure them like this or this. The 2 measurements have to be crisscrossing each other at 90 degrees, 90 here, 90 here. So perpendicular. Now you may ask me, patient is coming from a remote area or a village and she doesn't want to monitor her cycle with ultrasound. We'll not leave those people, right? So what we offer, we can offer them LH kits. Generally LH kit consists of 5 to 7 of those strips, what we use. And urine, while passing urine they can do. When do they start? In a regular cycle, they can start from day 10 onwards. In shorter cycles, say 26, 20, start from day 8 or day 9. And in a 30-day cycle, start from day 10 onwards. Now, they recommend once a day, but I would not agree. We should do twice a day. LH monitoring should be done. Ladies should do morning and evening. Twice a day for 3 to 4 days when she gets the LH positive result. And when should you time the IUI? The timing of IUI is, if you go back to physiology, when the LH surge occurs 24 hours later, you should do the IUI for such patients. Very easy. If lady is smart, teach her and tell her to contact your clinic, and next after 24 hours, let her come and do the IUI. Okay. So number of follicles. So roughly, I'll give gold standard, up to 3 follicles, not beyond. We have no right to give OHSS, ovarian hyperstimulation, to an IUI patient. Okay? Number 1. Second, 3 follicles, if you get say 4, 5, 6, please cancel the cycle. Don't feel bad about it. Okay? Because it's for your own safety and patient safety. So now this is why 3 follicles. One is to avoid triplets and all that. Second is, if you have 1 follicle, 5% pregnancy, 2, 13%, 3, 16. At 3 follicle, it's the maximum pregnancy rate. But when you have 4 and all, the pregnancy rate will drop. No point giving 4 or 5 follicles for IUI. The more the better, it doesn't work here. Okay? So it has been cut off at 3. Endometrial thickness, it's a bit controversial. But what is the minimum, endometrial lining above which you will go and do IUI, and below which? I would say 7. Most of the studies are 7. And no pregnancy occurs when ET is less than 6 mm. So your endometrium should be good. And then only you should go for IUI. Because it costs a lot of money and you give false hopes to the patient. If it's very thin endometrium, don't do it. So what do you do with thin endometrium? Know the cause, say, does she have tuberculosis, endometriosis, treat all that and then start again. And CC cycles may have comparatively lesser this thing. Letrozole has better. So if on one cycle you find, say, 5-6 mm, it is not growing beyond it, next time you can use a letrozole cycle for them. So that's how. Now gonadotropins will give better endometrium, so you can even go to a gonadotropin. So low-dose aspirin, vaginal sildenafil, arginine, estrogen, PRP, G6 is a bit controversial. PRP and all is coming up now, a big wave. Maybe in another 2 years we'll have good trials and all, then we can decide whether it helps or not. But these are all controversial things. The adjuvant role of adjuvant is not too much. But we all give, right? Let's be honest, everyone gives this. So optimal follicle size, you should know when to trigger now. Okay? So this you should remember. In a clomiphene letrozole, 20 to 22 mm tak you can go and then trigger. But in gonadotropin, it's same as IVF, 18 to 20, you should trigger off and schedule an IUI. It's very important. Now, many of us try to do a little bit of Doppler to the follicle. So perifollicular perfusion, 50 to 70% if it's there, it's good, it's ready to trigger. RI less than 0.5, PI less than 1, PSV more than 11 to 20 centimeter, and uterine artery PI less than 3. Now how do you trigger? Mostly we give HCG. Most of the times we give HCG. So HCG 5,000 you can give, or if the patient has too much weight, then you can give 10,000 also. Now, last line, I would take it as a pinch of salt. Agonist trigger only if OHSS. But I don't like this line. I put it because I want to tell you, we have no right to give OHSS to this IUI patient or any patient who we are doing IVF. So, I hope we don't come to this agonist trigger. If we are giving agonist trigger, we are not doing IUI. Simple. So, but for your knowledge, Leupride around 0.5 to 1 mg and triptorelin 0.2 mg subcutaneous can be given. You should know this as a doctor, your limitation. When can you cancel? So if there are more than 3 follicles, more than 16 mm, or more than 8 follicle, more than 12 mm, this is when you should not do an IUI. Okay? Or if you have an IVF center, you can convert it to IVF with all the precautions. Sperm count, I think we had a long lecture on sperm count, but I'll tell you simple thing that there's something. When you get the semen report, try to calculate the total motile sperm count, because most of the labs where you get it done, they don't give you. It's very simple: sperm concentration multiplied by volume multiplied by total motility divided by 100. You get the TMC. This is very important. Now, if you see 10 to 12 million total motile count, 18% pregnancy, 5 to 10, 5.6, if it's less than 5, 2.7. Okay. So standard, what they say is between 5 to 10 million, it should be their minimum. More the better. If it is less, you have to counsel for less pregnancy rates. So now this is called as post-wash count. This was a study, it was a Cochrane review actually. They say that when you wash the sperms, at least 1 million you should have, then only you should do IUI. If it is very less, you should not, like few sperms here and there, don't do it. So this was one Cochrane which I wanted to tell. And predictors of 10 to 20 million, I think this is the repetition of the, I want to tell about the DNA fragmentation. If it's less than 35%, is it a good count? Yes, it is good because the DNA damage is less. But there are further studies which I will tell you that DNA fragmentation does not play a big role in the IUI. Okay? So women with proximal tubal blockage and one open tube, conception rates are around 38% after 3 IUIs. So one open tube is very important. Please do the tubal test. Don't think that she's young and let me do 2-3 IUIs and then I will do the tube test. No. Counsel the patient. Rather, don't do IUI without that. You can do just simple ovulation induction or natural monitoring. Try them, tell them to have intercourse. Try 2-3 cycles like that. But then you sit with them and tell that we have to check the tubes. This is very important. So, ideal time interval, no consensus, but when IUI was performed, when you prepare the sample, this is that story, that within 30 minutes, if you do, it is the best time to get pregnancy. And it decreases if you leave it for like 60 minutes and all, okay? So I would say ASAP. As soon as the sample is ready in the andrology, please go and do the IUI. The lesser the time interval, the better the result. Now this also you may ask me that which is better, swim up or density gradient. Now there are different, like if a normal count, you can just do a simple swim up. If the count is little low, teratoma, steno, or if it is HIV or sexually transmitted some disease, there you do the density gradient. Comparable results. Swim up, I cannot say swim up is better than this. Both, you can do any kind, but you have to have that indication for that. So the timing of insemination. Now you are given the trigger, when will you call the patient? So single planned insemination after the HCG trigger, 36 to 38 hours. This should be your this thing. Now there is something called a single IUI and double IUI. Now if you're doing double IUI, they say 24 hours post HCG and 48 hours. This should be fixed. Okay, and variable protocol that you call after 36 hours, do the scan. If she's ovulated, finish the IUI. Not ovulated, you can do one IUI at that time and repeat afterwards. But what is the take? My take, or by evidence, is that there is no evidence. There is no difference between single and versus double. Why go for double? 2 times patient has to come. Do a proper one single IUI. That has equal pregnancy rates. Again, the more the better is not the case here. So single IUI time post ovulation gives better PR when compared with single in non-main infertility. Now this is one controversy. I just wanted to tell you, if you read these kind of things, just forget it. For all practical purposes, single IUI has good success rate. Catheter. Now, there is no difference in pregnancy rates, whether you use a rigid catheter, soft, embryo transfer catheter, anything. Just use a simple 30-40 rupees ka catheter, it has equal pregnancy rates versus if you use a 1000 rupee catheter. Okay. Volume of insemination, the standard is 0.5 ml, what we get preparation. But they are saying that there was no difference if it varied 0.3 to 1. But standard technique what we are using is 0.5 ml should be what you will put in the uterus, that's all. What care? Okay. Preferably use a Cusco speculum. Patient should be in lithotomy, relax, little head low, semi-full bladder. Why bladder should be semi-full? Because in case you get stuck and you can't enter, it's a difficult transfer, you can put an abdominal probe and get a window and you can see where you are going, number one. Second, little bit straightening of canal also will happen when your bladder is little bit full. Clean with saline, gentle insertion of cannula just beyond internal os. Please don't go like her and touch everything there. Internal os, you negotiate, you will get that feel and just put it. It's not like embryo transfer, like 1.5 centimeter down, you have to put at accurate location. Just cross the internal os and do it. Slow insertion, yeah, you have to be gentle. Hands have to be very gentle. 10 to 15 minutes rest. One paper had come, they said you should give this. So okay, we do that. Difficult IUI, again, ultrasound guided, or you can use a stylet, okay? And if the patient has vaginismus, first only while doing scans, if she doesn't allow you to do a scan, you can't do an IUI. So better do it under a IV sedation. So you have to talk to the patient, and while doing, that's why I said you have to do your own ultrasounds. You'll know whether she'll allow us to do IUI or not. Okay, now this is the same thing. Difficult insemination, 80 to 85% patients are easy to do. Difficulty comes in 15 to 20%. So you will have resistant, that there's something called as giveaway feel, no, at internal loss, what you do. You won't get that, and you know you are stuck. Okay, so try to put, change from Cusco to the Sims, down, up, try to create a straightening of canal. In IUI, you can use one Ellis forceps to, catch the anterior lip of the cervix and pull it gently and then straighten the canal. Ultrasound guidance, I would say, is the best. And if still you can't negotiate despite stylettes, what you will do? You cancel, put them for hysteroscopy next time, dilate it, and then later do it. Okay, so this is the technique. I think most of us know how it is done. I have already explained. Ultrasound guided, you'll say, no, now we know ultrasound, let's do all the IUIs ultrasound guided. It has no benefit. So simply you will be holding up, and then 15 minutes patient will be in ultrasound room lying down for rest, and your patient OPD will become long for the ultrasound. So use ultrasound only in difficult IUIs. I think this I have explained. Okay. Okay, so this is little age-wise, less than 35, you can go up to 6 cycles, more than 35, 3 or 4 cycles are enough. HIV discordant, yes, you can do sperm washing, it will decrease the risk of HIV infection, use a density gradient method. Okay. Now these are advanced methods, I'm just mentioning them that they are there, we are not using them on a regular basis, this is just for academics. Now this, Dr. Jyothi has explained microfluids. This was one paper in fertility, sterility. So good motile sperm, less DFI, less miscarriages. And that chip thing which you insert and then you get a prepared sample. This is that one. This is the newer one. Okay. So minimal count we have explained for microfluids is more than 10 million. Okay, that's very important. I'm almost done now. Retrograde ejaculation, I think she has explained, the previous speaker. But if you have retrograde, like she said, the volume will be less. What you do, you hydrate and alkalize the urine with the sodium bicarbonate and then collect the urine and then prepare it. This is for the andrologists, they'll know what to do. You can retrieve sperms from the urine also with these methods. So I'm not going into detail, this your andrology department will do. Do we do sperm retrieval, putting a needle into the vase, and do we do? Very less cases, only in an ejaculation, like they can't ejaculate. They're only that indication in obstructive azoospermia, they can't ejaculate. There you can try, do a trial needling and routinely it's not done. This is if patient doesn't want to do anything else, they want only IUI, there you put in a needle into vas deferens, aspirate and see whatever you get, you put it in. Okay, so this was the procedure. So high motility sperms were obtained in 34 cases they had done. This is study, and with IUI pregnancy rate per cycle was 73%, I don't know. But I don't believe that success rate, but then no abortion occurred. So, I mean, such cases were done. So, I have not done. If I have azoospermia and we do IVF, right, Dr. Jyothi? We'll do a TISA, take the sperm, do the IVF and do it. That's all. Luteal phase support, should you use or not? Who all uses? So, most of us provide luteal phase support, okay? Maybe a small dose of progesterone, 10 mg dydrogesterone can be used, but it is mandatory to use in a gonadotropin only cycle. There you have to give. In natural cycle, you can skip also because they have the natural LH surge, and the rupture of follicle, and it will produce progesterone endogenously. I would not say there's much use, but ovulation induction, if you are using gonadotropins, you can give a small dose of dydrogesterone or vaginal micronized progesterone. Okay, so this was the ESHRE guidelines. This is my last slide. So I hope you've got the message clearly, what to do, when not to do, and how to do. So selection of the patient is very important. If you have like few motile sperm, patient tells you, no, I want only IUI, will we do? No, that's a case for IVF or ICSI. So select your patients carefully, select the correct protocol, vigilant monitoring with ultrasound guided, transvaginal ultrasound, correct timing, good sperm preparation. Check the sperms yourself. What I do is, like, when too much rush, I can't go, but if we line up the IUIs, I'll go quick visit to the lab, check the slides. I tell them don't throw. Even if I go late, I'll check the washed sperms, because they can tell anything, na? So I'll just go if I have time. So earlier when I had less practice, I used to do for all, now it's less. But yeah, check the sperms, smooth procedure, and adequate luteal phase support, and good luck for the doctor and patient both. I think we should have loads of luck, because the failure rates are significant in IUI. So this is my village. I belong to Kashmir, but I'm settled in Bangalore. So that was my village in Kashmir, and thank you so much for a patient hearing.
Thank you, ma'am, for the excellent lecture. And the important thing is that the last slide you have put everything and summed up, including the good luck after the IUI. And also it is a very interesting topic. How many ever times we listen to this topic, we tend to get useful points whenever we hear to this topic.
And even I learn. Every time I prepare slides, there is 1 or 2 points which will come from here and there. And our, especially reproductive sciences, what we are dealing, ART, we have changes every 2 to 3 months. One time they'll tell us FSH is good, one time after 3 months they say, no, HMG is good. So we have to update our knowledge, and these platforms are so good for us. We don't have time. Like, I would have seen at least 20-30 articles and made this presentation and given you a concise. So I think these platforms are very good to learn. I also learn.
Madam, nowadays most of the patients have no marriage certificate.
Yeah.
So notary for proving.
See, ideally, Dr. Hitesh, he is not here, but he has told we should have the marriage certificate. But I think Aadhaar card is a good way. In my place, everyone, even in villages, people. Now, I think Aadhaar card, like what this government has done, is the Aadhaar card is very good.
They don't get it updated. They will have only father's name, madam. They don't get it updated. It is with the father's name. That is the main problem. They need to get it updated. That is okay. Otherwise, it is a problem.
See, another thing is that, like most of my patients, some family member will be with them. Little bit we have to trust, I would say. Mother-in-law will be there, especially if the sperm count is low, they'll be sitting like this. The mothers, the pet, in-law side, whoever has problem, that person's parents will be sitting like this. You will understand. This is a family.
Madam, misoprostol is necessary. Madam, misoprostol is necessary for every case of IUI.
Misoprostol. There was a study using 25 mcg of misoprostol when I was doing fellowship, but we did a pilot study of 50 cases and it didn't give results, so we don't use misoprostol.
And is ultrasound mandatory after a trigger, ma'am? After 36 hours of the trigger?
You will see ovulation. You call after 36, majority of the patients 36 to 40 hours they'll ovulate. So you will see ovulation. You will see. We don't do blocked tubes. If both are blocked, it's IVF, ma'am. Okay, yeah, this is a very interesting question. So while I do the ultrasounds and I know, say, right tube is blocked and the follicle is coming left side, I'll cancel the cycle. I'll not do.
Okay, thank you, Ferty9 Suma Varsha, for giving us this opportunity. Thank you.
I'll take this privilege to introduce
I've already been
Suma.
introduced.
Everybody knows her, but I'll take this opportunity to just tell her in one word, very hardworking, and she feels for patients. All degrees are there. So go ahead, Dr. Suma.
Yeah, so Dr. Ashish was not able to make it. But I'll be very quick. I know it's difficult to listen to so many lectures at a time, but just quick take-home points. So male factor, we all know, is responsible for almost 50% of infertility. But the worst part is that majority of the time we don't find a cause. So we may have an abnormal semen analysis, but we don't know why it's abnormal. So identifying a specific cause and treating a male factor is quite a rare thing that happens. So this antioxidants that we use, especially as an empirical treatment, is we generally use it left and right to all our patients. Especially when I passed out after my PG, any male who comes anxious to conceive, the only prescription I knew was writing some antioxidant and sending him away, because I didn't know anything else apart from that. So I'm going to talk about antioxidants. How do they help? Where do you use? Why do you give them? Whom do you give them? Which one to use for how long? And what does the evidence say? So let's come to why do we need them. So what are these reactive oxygen species? So we have superoxide anion, we have hydrogen peroxide, hydroxyl anion. All of these ultimately leads to DNA damage. So they are free radicals, and if they are not neutralized by any enzyme or anything which can counteract them, they will ultimately cause DNA damage. So normally there is, in a metabolic process, there is always release of reactive oxygen species. It happens in every cell of the body every moment. But usually there is a neutralizing capacity that happens. But if the neutralizing capacity is exceeded, we usually have an oxidative stress that is happening, and this causes cell death or damage and eventually organ dysfunction. So especially the reactive oxygen species in the sperm, it's like a double-edged sword. In this physiological level also, it is required in certain functions like capacitation, acrosome reaction, hyperactivation, sperm oocyte function. But in supraphysiological levels, it can be pathological, which can lead to cell membrane damage and even apoptosis. So there are a lot of things that can increase the oxidative stress, and it can cause damage to the sperms, like lifestyle changes like smoking, alcohol, so many environmental toxins, and varicocele, cryptorchidism. Leukocytes produce almost 1,000 times more ROS when compared to a normal cell. Abnormal sperm cells also produce more ROS, and these, if they exceed the neutralizing capacity, it becomes harmful to the patient. It's not just about damage to the sperm. The DNA of the sperm also can get damaged and can even lead to recurrent pregnancy loss. So obesity, varicocele, leukocytospermia, gonadal infection, lifestyle factors, environmental factors, all of these will increase the reactive oxygen species. One important thing we have to remember is it is not only the patient factor, it is some things that are in our control also, which if we do not check can lead to increased ROS production, like not maintaining your lab properly, doing excessive centrifugation, causing more of light exposure, causing a lot of temperature variations. So these are something which are in our control, which we should also monitor and take care of. Now, when the sperms are in the testicles, they produce a lot of ROS, but they have a good neutralizing capacity because there is a lot of cytoplasm in the sperms. But once they enter the epididymis, as the spermiogenesis happens, most of the cytoplasm is lost. So the neutralizing capacity becomes lesser, and it is in the epididymis where the sperms are maximum exposed to ROS and lead to damage. So for this reason, in any patient where the DFI is high, we go for testicular sperm retrieval, because they are less affected compared to an epididymal or an ejaculate sperm. It is mainly in the outflow tract where the sperms are maximum exposed to ROS and they are getting damaged. So in what ways can we combat this oxidative stress? So there are so many behavioral and lifestyle modifications like frequent ejaculations. So as I told you, in the outflow tract, if the sperms are present for a longer duration, they are more exposed to ROS and they get damaged more. If we advise them to have frequent ejaculations, the time the sperm spend in the epididymis is decreased, and it can reduce the effect of the oxidative stress. Decreased consumption of simple sugars, high fat food, regular exercise. They have to avoid alcohol consumption, cigarette smoking, excess exposure to environmental toxins and psychological stress. Treat any underlying pathology like diabetes mellitus and infection. So all of these lifestyle factors itself can correct oxidative stress to a large extent. And of course, you have antioxidants. So in whom do you give them? Now, as we discussed, and this oxidative stress causes a large number of patients to have infertility, but there's no consensus on which antioxidant to use, when to use, how to use, and there's no regulation on it. So does that mean we should give it for all? Do we restrict it to patients who come to us with an abnormal semen analysis? Do we give it in patients with varicocele because we know they are more prone for oxidative stress? Or do we just give it in patients with idiopathic male factor? In the sense the semen analysis is normal, physical examination is normal, but still they are not conceiving. So do we give it in that set of patients? So many a times I at least used to think, when I didn't know much about this, that kya hai? It's vitamin A, vitamin C. They're all nutritional factors. What is there? Even if it doesn't help, it may not cause harm, so just keep giving it. So this is an important aspect that, excess of reductive stress is also not good, and it can also lead to infertility. So there should be a balance. There should be a balance between ROS, and there should be a balance between the antioxidants in the body, and this balance is necessary for proper fertility. Excess of ROS or excess of reductive stress, both are not good for the patient. So then how do you do it? So actually what is suggested is measuring oxidative stress by measuring the ROS, and if ROS is high, then giving antioxidants for 3 months, again testing the patient, again if it is high, continue, otherwise you stop is what is recommended. So various methods to measure the oxidative stress, like chemiluminescence test, there were so many tests that have been described, but they are going to increase the cost, and they yet need to be validated. So when I searched for articles as to in which set of patients actually antioxidants are benefiting the most, so I came across this article which says that actually antioxidants have been used most in asthenozoospermia, followed by idiopathic, followed by oligospermia, followed by varicocele-ectomy. But all of these studies were very heterogeneous. They were like, different populations. There's no, it's a vast group which cannot be actually compared. So you can't draw any proper conclusions. So this study says that in abnormal semen quality, the level of recommendation is C, varicocele it is C, unexplained male infertility or idiopathic male infertility, that is when the semen analysis is normal, physical examination is normal, patient is not conceiving, it is a grade B recommendation. So which one to use? So there are so many antioxidants that are available in the market, broadly classified as enzymes, non-enzymatic, vitamins, so on and so forth. Coenzyme Q is one thing which is very commonly used, carnitine, vitamin C, vitamin E, N-acetylcysteine, so many of them are used. So L-carnitine, coenzyme Q mainly improve motility, and folic acid vitamins mainly increase, folic acid mainly for the DNA, prevents the DNA damage. Vitamin C, E and thiamine improves the sperm concentration. So, but as was already discussed, coenzyme Q is the only one which has grade A evidence supporting its use, apart from carnitines and N-acetylcysteine and vitamin E having grade B evidence. So this is one article which tells us which group of antioxidants to use in which kind of a problem. So vitamin E, vitamin C, N-acetylcysteine is universally improving all the parameters. I think L-carnitine, CoQ improves oligo and astheno parameters. Apart from that, I think it's a combination of many things. So for how long do you give it? So as I said, you can't keep giving antioxidants to eternity. I've seen some male patients coming to me with using antioxidants for years together. So you have to be judicious, because excessive antioxidants can also cause infertility, because as I already explained, ROS is required even for certain functions like capacitation, fusion of the egg and sperm, and all so on and so forth. So if the pathology is in the epididymis, antioxidants even for 2 weeks will make a difference. But if the pathology is in the testicle, antioxidants for 3 months should do benefit to the patient. So most of the studies have used antioxidants for 3 to 6 months. So I think 3 months or maybe a maximum of 6 months is what is recommended. So, what does the evidence say about antioxidant? This was the recent Cochrane review in 2022. A large number of studies, a huge number of patients. They showed a slightly increased clinical pregnancy rate and a slightly increased live birth rate, but not a very conclusive review because, again, most of the studies are very heterogeneous. This is a SWOT analysis describing antioxidants in male infertility. So the strengths are, it's easy to use, it's just an oral drug, it has very least side effects. But the threats are that, there is no grade A recommendation for its use, and excessive use can be harmful to the patient. So even in this particular article, they say that antioxidants in infertility, there is no conclusive evidence supporting its use. So I think the way forward should be standardization of oxidative stress measurement, like, standardizing the method by which we can measure oxidative stress, assessment to facilitate which candidate should be using it, and then use it only till the oxidative stress is more and then stopping it. But it is yet something that we have to do with caution. So mainly, if at all we are prescribing antioxidants, we should be giving it for a maximum of 3 to 6 months and not beyond that. It is not a nutritional supplement, it's not a placebo. Excessive use also can cause infertility. So I think that is the take home I want to give. Thank you so much. Yes, ma'am. If there is an abnormal semen analysis, if you are using it for oligoesteno, then yes, it's better to repeat a semen analysis and see. But I think for every male partner, instead of just giving a prescription of an antioxidant, lifestyle modification is something which we have to re-emphasize. Telling them eat on time, exercise regularly, at least 6 hours of night sleep, keep away from your cell phone in the night, no smoking, no alcohol. All of this along with antioxidants, maybe after 3 months you can see some change.
After improvement is noticed, for example, 1 more 3 months we will continue. Meanwhile, if she doesn't consume, then we have to stop definitely.
Better to stop, according to this.
And also now they say sitting is new smoking. Sitting for a lot of time. There is studies which says 8 hours you sit, it is as if you are smoking also. So some kind of activity is very important. The sedentary life has caused a lot of issues now. Infertility is one of the obesity, all these to the sedentary activity. Yeah, good lecture, something eye-opener for antioxidants. Even I second her. So continuous use of antioxidants more than 6 months. Sometimes we do see 1 year, and anytime it's not anybody's mistake. You know what happens? Any male come to your gynecologist doorstep, something you have to write for them. What is that? Everybody puts to the antioxidants, but taking some time, creating some awareness and telling about lifestyle, and also they say even in IUI, the patients most of the time in IUI, they say they should not ejaculate. IUI means for 10 days I should not ejaculate. That's the thought process. Recurrent ejaculation also helps in decreasing the DNA fragmentation. So good talk. And so now we'll move on to our next talk.
Sandeep Sharma. He is Vice President Embryology at Ferty9 Fertility. He earlier worked in Art Fertility and Nova Fertility. So he has a PhD in clinical embryology and trained in Spain. So he has experience of doing more than 10,000 IVF ICSI cycles. Welcome, sir.
Thank you, ma'am, for the kind introduction. Good evening, all of you. So today's my topic for the presentation is advanced sperm selection techniques. So selection of best spermatozoa. Why? The ultimate goal for the IVF treatment is single pregnancy and the birth of one healthy baby. So for the time being, the take-home message is that the DNA damage in the main germinal is potentially damaging and the care should be taken when treating the patient. to determine the cause of DNA damage and to do everything possible to elevate the DNA damage. For example, antioxidant therapies, or use the sperm isolation techniques that will select for the gamete possessing very low level of DNA damage. So the question is, are there techniques that select the spermatozoa with reduced level of chromatin or DNA damage? So for the use of ART, the good quality sperm must be separated from the seminal fluid. The goal is to obtain highly motile, normal morphology, minimum or no DNA damage, improved and maintain sperm functions like capacitation, hyperactivity, motility, and to eliminate the decapacitation factor, prostaglandins, zinc, cytokinins, cellular debris like RBC, WBC, epithelial cells, immature or morphologically abnormal sperm and immotile sperms. So normally in all the IVF labs and the IUI labs, we prefer the three methods of sample preparation. Simple wash method. So it's normally we use simple wash in the severe samples, cryptozoospermia samples. The advantage of simple, I will not take much detail on these methods, but I will give you the brief information, the advantage and disadvantage. The advantage is easy to perform, good yield we get, but the disadvantage of simple wash method is not ideally for the IUI because there is a risk of developing the anti-sperm antibodies and the ROS attacks are there. Swim-up method we normally use where the count and motilities are good. So advantage of swim-up method is easy to perform, cost-effective and very clean fraction of highly motile sperm we get. But the disadvantage is yield is relatively low and the damage from the ROS. The third technique is DGC, the density gradient centrifugation method. Normally we use this type of sample where we have some debris or WBCs or some in fact HIV samples or HVAC sample or HCV samples. So advantage is this, it takes less time as compared to the swim-up method, relatively easy to perform, and the disadvantages are the negative effect on the sperm DNA integrity compared to the swim-up method. So the safety and efficacy. Centrifugation can be harmful for the spermatozoa. Everybody knows about this. The centrifugation removes the leukocytes, immature sperms, dead cell, which induce the ROS and leads to the sperm membrane damage, DNA damage, and mitochondrial damage, which impact the poor fertilization rate, poor embryo development, and poor pregnancy rate. So what are the safe methods available in IVF field? So there are some advanced sperm selection techniques are available. For example, migration sedimentation, MC, MAX, and microfluidic and HA binding. So my main topic will be on these 5 methods of preparation. The first is the migration sedimentation. The migration gravity sedimentation offer a gentle method for the sperm selection compared to the centrifugation based technique. It allows the isolation of the sperm with a higher motility and better morphology, which can improve the success rate of the procedure like IUI and the IVF. So if you see the ABC category in the pictures, the A part is the migration gravity sedimentation without centrifugation. This is called the Meglis procedure. So normally this is a device where we, on the left, if you see in the B picture, the I column, we inject the liquefied semen sample in the space between the outside of the central tube. And the inside the container, we put near the edge of the cup. And we place the inner lid and gently pour the phosphate buffer solution to the bottom of the cup and cover with the outer lid. And after 1 hour, we keep at the room temperature. And after 1 hour, we take out the 0.5 of the semen sample, and this sample we use for the IUI or IVF procedure. So what are the advantages of the migration sedimentation? Highly motile spermatozoa recovered, ROS level is reduced, easy to perform in outpatient settings also, very gentle separation method. But with advantage, there are some disadvantage of this technique, restricted to the ejaculate with the high sperm concentration and motility. Low recovery rate, seminal plasma not removed completely. We need a special glass or plastic tubes are required and more expensive. Next method is IMSI, the intracytoplasmic morphologically sperm selection injection. The sperm selection during the ICSI, which takes place using the low magnification, that is 400x. Any sperm ultrastructural abnormalities that affect the fertilization and the embryo development, if present, will not be detected with the help of ICSI technique at 400x. To address this issue, The IMSI technique for the sperm selection has been, the method is developed based on the motile sperm organelle morphological examination at the magnification of more than 6000x. The different sperm organelles can be visualized using the IMSI technique. For example, nucleus, acrosome, post-acrosome area, neck, tail, and mitochondria. The detailed organelles assessment allow the identification of specific abnormalities such as lack of acrosome in globosospermia. There are some studies which suggested that the vacuole are shown to be linked to the chromatin condensation failure. Chromatin condensation failure is associated with the recurrent abortions. And the sperm chromatin condensation at the time of fertilization can influence the early and late embryo development. One more paper in sterility and fertility and sterility suggested that the pregnancy rate are higher with the IMSI as compared to the normal ICSI technique. What are the indications of the IMSI? Previous ICSI failures, total fertilization failure, severe OATs, recurrent miscarriages, high risk cases, and recurrent implantation failure. IMSI, we have some disadvantage. It is an add-on, like normally this takes time as compared to the normal conventional IVF and ICSI. Due to its elevated cost, because we need a special lens for this IMSI technique, not all the labs have this type of technique. And we need a special glass-based dish as compared, and normally in ICSI dishes, we use the normal ICSI dishes, but for IMSI, we need a specialized glass dishes. The third method is MAX, magnetic activity cell sorting. So MAX technology using the annexin bead, microbeads, which helps in separating the apoptotic sperm from the non-apoptotic sperm. When the apoptosis starts, the integrity of the sperm membrane is compromised, and PS, one of the elements that makes the sperm membrane, is rise to the cell surface and externalized. Annexin V beads bind to the disturbed integrity of the sperm membrane, but does not have ability to pass the intact membrane. So based on the annexin binding, the subsequent magnet separation, two fractions are obtained: annexin negative, unlabeled, intact membrane, and non-apoptotic. Annexin positive, which is labeled, altered membrane, and apoptotic. So how we process the MAX sample? So after the 15 minutes of incubation at room temperature, sperms and microbeads are loaded into the column with magnets. The MAX column are placed in the stand surrounded by the magnetic field. The loading of the MAX column with liquefied semen sample labeled with annexin bead, coated micromagnetic beads, which then the apoptotic sperm with annexin beads are retained in the column, and the non-apoptotic sperm or we can say the healthy sperms are elevated and collected in the tubes. The combination of density gradient and the MAX has given the higher sperm quality preparation. The spermatozoa selected by the MAX were associated with a higher cleavage and pregnancy rate. What are the indications of MAX? High level of DNA fragmentation, chain smoker, patient with more than 2 IVF cycles with unexpected poor fertilization, poor quality of embryos in previous attempts, repetitive absence of implantation in previous ART attempts, repetitive indications of spontaneous abortions. What are the advantages of MAX? MAX is a rapid, convenient, and non-invasive technique. Act at the molecular level, separate the apoptotic sperm from the non-apoptotic ones, provides the optimal purity and recovery with reliable, consistent result. Yes, again, disadvantages with MAX are labor and time intensive, loss of sperm yield, annexin V is photosensitive, and more running cost and not suitable for all the samples. There are multiple studies are published on MAX. If you see the first one, they mentioned that does the combined MAX sorting with the density gradient improve the sperm selection? So they have mentioned that considering the cost ratio benefit and MAX application together with traditional techniques may only be preferred in certain cases where the high concentration of spermatozoa, but it does not seem to be an ideal and practical sperm selection technique for routine cases. There is one more paper on the sperm selection using the MAX in assisted reproduction, a systematic review and meta-analysis. The MAX appears to be the safe and efficient method to select the functional sperm with consistent good result. These techniques may improve the pregnancy rate when used to the complement standard sperm selection method in the ART. Fourth one is microfluidic. Microfluidic is a device which mimics the natural environment of the female reproductive system, especially the fallopian tube. The sperm sample are passed through the microchannels or micropores within the clip. As the sperm navigate these tiny passes, the device selectively allows the functional sperm with the low DNA fragmentation to pass through. The goal is to filter out the sperm may have a higher DNA damage. There are multiple microfluidic devices are available. For example, the fertility chip from Turkey, Qualis from Japan, Zymote from USA. So in microfluidic, there are some sperm selections based on the guided mechanism. The first one is by rheotaxis. The human sperm move against the direction of fluid flow. This is known as rheotaxis. De Martin et al. In 2017 conducted a study in which the sperm were selected by this feature. It was reported that the sperm selected were enriched with higher chromatin compaction as compared to the sample processed by DGC. Animal studies results are positive, but the passive nature of the rheotaxis indicates that it has a poor selective potential beyond the separation of those sperm with good motility. Second, by chemotaxis. Chemotaxis is the chemical guidance mechanism that can help the sperm orient towards the egg during the in vitro fertilization. In chemotaxis, the sperm swim in the response to the gradient of the chemical substance released by the COCs. Picomolar concentration gradient of the progesterone, the maintain the steroid component secreted by the cumulus cells that surround the egg, attract the human spermatozoa. There is a study, in 2013, it was found that the selected sperm had threefold capacitated sperm with lesser DNA fragmentation and less ROS as compared to the original sample. However, the effectiveness of the sperm selection by chemotaxis in the improvement of the ART is not studied to the date. Third one is the thermotaxis. The thermotaxis is the process in which the sperm cell swim up a temperature gradient by changing their swimming directions. This process has been observed in the mammals and is thought to be the essential mechanism that guide the sperm from the cooler reservoir site to the warmer fertilization site. However, the research in this is only carried out in bovine model. Effectiveness of the sperm selection by the thermotaxis in the improvement of ART is not studied to date. So there are some studies on the microfluidics. So one study was done, does use of microfluidic sperm sorting device for the sperm selection improve the IVF success rate in male factor infertility? The conclusion of the study was the IVF success rate might improve with the use of microfluidic device for the sperm selection in male infertility. Second was the effect of microfluidic chips technique in the sperm selection for ICSI for unexplained, a prospective randomized control trial. So as per the study, they mentioned that there was no changes in the fertilization rate, clinical pregnancy rate, and the live birth rate during the IVF treatment of unexplained fertility. So what are the advantages of microfluidic? It is quick and gentle method, mimics the natural selection process. The small volume is enough for preparing the semen sample, eliminate the centrifugation and related ROS attacks. Disadvantage of this device is need special device, risk of material toxicity is there, no standardized, low yield, high cost, and not useful for all the semen sample. The last but not the least, the fifth method of advanced sperm selection technique is hyaluronic acid binding. The hyaluronic acid receptors are present on the plasma membrane on acrosome intact sperm and are indicative of the sperm maturity. Hyaluronic acid is the main component of the cumulus ovorus. It plays a role in the natural selection of spermatozoa during the in vivo fertilization. Hyaluronic acid acts as a natural filter, allowing only the mature sperm with the right receptor to interact with the egg. Hyaluronate-bound spermatozoa exhibit the lower percentage of chromosome aneuploidies and the DNA damage and shows a significant improvement journal and nuclear morphology as well as the higher embryo quality resulting from the ICSI technique. So this hyaluronic acid binding method is having two ways of doing. One is PIXI. PIXI is basically the physiological ICSI, is the method that help us to select the mature sperm from the injection. Normally when the sample, there are multiple samples in one of the, like if you have the men with poor sample often have a greater degree of immature sperm. Immature sperm can still have shown the normal motility and morphology. However, there may be the higher level of DNA damage, which if we select for the insemination can result in the poor embryo development and pregnancy loss. So PIXI is a dish. If you see in the picture, the second dish, there is a dish which is having 3 arrows. Next to the arrow, there are 3 circles are there. They are the dry drops of hyaluronic acid. This is the method. Normally what we do, we hydrate the sample, hydrate the drops, and then we put semen sample, we keep it for some times. After 10 minutes, we check the sperm which is bound to the hyaluronic drops. They are healthy sperm, they have less DNA damage, and we select for the ICSI process. Indications: when HbA test is less than 65%, high level of DNA fragmentation, poor quality embryos. PIXI is having benefit, increase the blastocyst rate and decrease the miscarriage rate. Second is hyaluronate containing medium. The alternative of the PIXI dish is a viscous medium containing hyaluronic acid. Company name or like product name is Sperm Slow, medical by the Cooper Surgical Company. So this is also the same, like we have to make it instead of PVP dishes, PVP drops, we are using hyaluronic, this Sperm Slow media. On the basis of hyaluronic effect, the sperm which is having a slow movement we select, because it shows that the sperm which is having a slow movement is having low DNA damage. So we select, we keep it for some time at incubator, then we select the sperm and we use for the ICSI process. What are the key benefits of the Sperm Slow media? No need of PVP during ICSI, significant lower abnormal fertilization rate, better embryo quality compared to the standard ICSI, higher implantation rate as compared to ICSI. Spermatozoa with Sperm Slow has low DNA fragmentation. There are multiple studies, the PIX, so I will take only a few. PIXI improves the fertilization rate and transfer eligible embryo rates in the sibling oocyte in the selected study group. Both PIXI and Sperm Slow allows the comparable clinical efficacy in selecting the HA bounding spermatozoa. PIXI improve the fertilization rate and transfer same. Take home message: I have described the number of sperm preparation devices that are available to process and select the sperm for the use of ART. Each infertile couple must be carefully examined to determine the best sperm preparation method. Further research must be seek to improve the efficacy and the safety of the sperm preparation technique. The advanced sperm selection technique strategize including the selection according to the surface charge, sperm morphology, under ultra high magnification, ability to bind hyaluronic acid, and sperm apoptosis and microfluidic separation. These techniques may improve the chances of selecting structural, intact, and mature sperm with high DNA integrity for the help to improve the pregnancy rate and the fertilization rate.
Thank you, Mr. Sandeep, for a wonderful presentation on advanced sperm selection techniques.
We request Dr. Jyothi ma'am to present a memento to Sandeep sir.
So after hearing Sandeep with so many technology, one thing we understood, any male infertility, some selection method is there, and genetic, becoming a genetic father, there is a lot of possibilities. Thank you.
I think with the microscopic examination, we have to have some system to select the good intact DNA sperm. So like these are some techniques are available in the market we can utilize, not for the examination, but for the treatment of the patient.
Ultrasound, especially TVS, has become an indispensable tool for infertility workup as well as for monitoring and treating of patients. So without further ado, let's move on to our next session of the day on ultrasound in infertility. This is an exclusive video demonstration of different case scenarios in infertility. We invite Dr. Shravya ma'am and Suma ma'am onto the stage for the video demonstration.
Thank you for your patient hearing. Fag end of the day, I know everyone is tired. So we'll just show the videos and move quickly. The eyes don't see what the brain doesn't know, borrowing from our surgical textbook. So we have a case, 20-year-old lady and 31-year-old gentleman with primary infertility of 2 years, irregular cycles. OI was given, and let us look at her ultrasound findings. So this is the uterus. You can see the ovaries, you can see the follicles, antral follicle count. As already elucidated earlier, follicular number per ovary, if we look at, if it is more than 20, we give the diagnosis of PCO, or rather on ultrasound it is a diagnosis of polycystic ovarian morphology. So PCOM on scan. So she has irregular cycles, PCOM, a diagnosis of PCOS, so OI cycle was given. So how do we check the antral follicle? We know antral follicle, when we look at the recruitment, there is two phases, initial and cyclic recruitment. So cyclic recruitment is the one wherein we manipulate the follicles. Initial recruitment is something which happens on a regular basis in women, but cyclic is the one which we manipulate during our ovulation induction or ovarian stimulation. So antral follicles, we measure them on day 2 to day 4. So we can measure them normally on a 2D ultrasound, or we have an automated sono AVC also to measure the follicles. This video we are measuring the uterus, the APD and the uterocervical length, and also looking at the follicles. If you can see, when we are moving the probe from side to side, you can see both the ovaries. There is an average number of follicles, more than 10 follicles combined AFC. So we can take it as a normal reserve. Then moving on to the next scan, if you look at this patient with the ovaries, hardly there are some 2 to 3 follicles in each ovary. So this indicates diminished ovarian reserve. So when do we call diminished ovarian reserve? If the AFC is less than 5 to 7 in both combined.
So moving on to the next case, 24-year-old Mrs. A, 28-year-old Mr. B, anxious to conceive since 2 years. They started on ovulation induction for an IUI cycle in view of unexplained infertility. So this is a scan finding. So this is a case of secondary infertility. We can see that there is a scar there, cesarean scar is visible. There's no point. So this area you can see there's a discontinuity. So this is how we do a complete assessment. Transverse we are seeing. Now we do a 3D. You can see the discontinuity clearly even on the 3D. So this area, you can see that defect, that's the cesarean scar area. So let's look at the ovaries, because we've given ovulation induction. So this ovary doesn't have any dominant follicle. So as we scroll to see the next ovary, we're taking the measurement of this ovary. So there is a dominant follicle over here. It's more or less rounded, so the measurement is quite easy actually. But many a time the follicle is actually not rounded, and there's always a dilemma as to how to measure. So inner to inner in the largest diameter and axis perpendicular, 2 diameters, and if you take an average, that should be a follicular measurement. So when it is rounded, ideally one single diameter is okay, but when it is like this, ideally this is how it has to be measured. The largest, the follicle has to be exposed in the largest diameter. Measure the largest diameter and take the measurement in the opposite direction and take an average of it. So follicular study ideally should be started from day 2 itself. Day 2 scan is very important because you should rule out any cyst of the previous cycle. If you directly give oral ovulogens and ask the patient to come back for a follicular scan, we might mistake the cyst as a follicle, as a dominant follicle. So role of color Doppler enhances our follicular scan monitoring, and by looking at the vascularity, we can enhance the success rates by giving the trigger at the right time. We are looking at the perifollicular flow and measuring the peak systolic velocity and RI. So the follicle measures almost around 16 millimeters. It has quite a good vascularity. When we are doing Doppler, we should make sure that the PRF is around 0.5 to 0.4. So generally the machine is set at around PRF of 0.8, 0.9, and that detects only the larger vessels. The perifollicular and the subendometrial flow are the smaller vessels, so the PRF has to be set to 0.4 to 0.5, only then you will see the perifollicular flow or the subendometrial flow. So in this particular patient, the peak systolic velocity is 8 to 9 and the RI is 0.9. So this shows that there is still some more time for us to give a trigger. So a mature follicle is one where the follicle is around 3/4 by vascularity, and when you see the perifollicular blood flow, if the PSV is 10 to 15 and the RI is less than 0.4, it is ideally the right time for us to trigger. So now this is one more follicle. So almost 3/4 it is surrounded by vascularity. Now if you look at the PSV, it's almost 10.5 and the RI is less than 0.4. So this is a follicle which is ready for trigger. So perifollicular flow, as the blood flow surrounding the follicle increases, the chances of having a mature oocyte increases. So the one which has maximum blood flow, the resistance index will be low and it is a good follicle for us to trigger. So blood flow is also important to check the subendometrial blood flow. So this is a good zone 3, zone 4 vascularity. Again, we have to be mindful that the PRF is set to 0.4, 0.5. If you keep the PRF at 0.8, 0.9 and you won't see a single vessel and you will misinterpret. So you have to be a little cautious about that. So this is the Applebaum classification of subendometrial blood flow. The vessels are hardly seen in the myometrium, they are not even touching the endomyometrial junction. In the second scan, you see they are almost approaching the endomyometrial junction. Zone 3, it is up to the endomyometrial junction, and zone 4, it is up to the cavity. So this is how we stage, and zone 3, zone 4 is ideal for us for an implantation. So another importance of doing Doppler in a follicular scan is if the PSV is already high, say it is around 15, 20 or 30, then we have to do an IUI earlier. That means there is already an imminent rupture. You can't give a trigger then and wait till 36 hours because the follicle would rupture earlier. So that is another importance where you can time the IUI better and you can improve the outcomes. So ideally trigger should be given when the follicle is surrounded 3/4 by vascularity. It has PSV more than 10 and RI less than 0.4. So after giving a trigger, it's ideally actually not mandatory to do a scan. So the evidence right now says that 36 hours later, documenting ovulation is not mandatory to do an IUI. So if at all we do a scan, then there are varied appearance of corpus luteum that we come across. So this is one video showing the scan post trigger. So we have a good secretory endometrium in this patient. We can already see the first sign of rupture. We see free fluid there. So this ovary is looking normal. The opposite ovary, you can see the corpus luteum. So it's something like a hemorrhagic cyst. It's a corpus luteum with very good vascularity. So it's a good sign for us.
Moving on to the next case, we have a 35-year-old lady and 30-year-old gentleman with primary infertility of 2 years. So she has regular cycles but spasmodic dysmenorrhea, heavy menstrual bleeding lasting 8 days. So let us look at her ultrasound findings. So here in this ultrasound you can see a fibroid, okay. The measurements are being taken about the fibroid. So fibroids usually present like a hypoechoic masses. Very rarely they present hyperechoic. Most often it is iso to hypoechoic mass in a sagittal plane. So for fibroids, we do what is called fibroid mapping. So you do ultrasound, take the measurements of the fibroid in the sagittal plane and also in the transverse plane, and you take the measurement of the fibroid from when you move the probe from cervix to fundus. That is, you ideally locate the fibroid. And also we do the 3D. 3D scan of the fibroid will give us the location of the fibroid and its distance from the junctional zone. So for fibroids, we know we are clear cut about the management that subserosal fibroids do not affect fertility, whereas submucosal fibroids need to be removed. But the gray zone occurs in intramyometrial fibroids, wherein these fibroids are located your FIGO 3 to FIGO 5. So if the fibroid is somewhere close to the junctional zone, then we need to remove the fibroid. Otherwise, there is no role of removing the fibroid. So for submucosal fibroids, we have the Lasmar classification. So recommendation is if the fibroid is larger than 4 centimeters, reaching the junctional zone, then it needs to be removed.
So moving on to the next case, 26-year-old lady, 30-year-old gentleman presented to the hospital with secondary infertility of 5 years. She had 5 previous spontaneous miscarriages at 8 to 10 weeks of gestation. So this is her scan. So this is a sagittal section where it looks quite a normal uterus. But when you see the transverse section, you can see that the cavity is dividing. So once the cavity is dividing, you know that we are looking at some uterine anomaly, query septum, query bicornuate, query didelphys. So in a 2D scan itself, we can more or less differentiate between a septum and a bicornuate, because there is division of the myometrium as well when it comes to a bicornuate uterus. So now when we do a 3D scan, we see that it's a septate uterus. See, there is the external contour is maintained, right? And you can see the cavity being divided into 2. Yeah, so you can see the 2 cavities, and the external contour is still maintained. So that is why you can differentiate it from a bicornuate uterus. So this is the Ishre classification of uterine anomalies, and this is the next case. So in this you can see that the cavity is extending up to the left ostium, but towards the right ostium you don't see the cavity. So when we put a 3D, we see it's a unicornuate uterus, and there is even a small polyp inside. So this is a unicornuate uterus with a small uterine polyp. So based on the surface indentation, we can differentiate between various anomalies. So you look at this, the surface is intact. This is a complete septum. If there is indentation of the surface as well, as I have marked over here, it is a bicornuate uterus. And based on the depth of indentation of the inside, you can differentiate between arcuate and septum. So if the indentation is only 1 to 1.5 centimeters, it becomes an arcuate uterus. Now this is the septum, and this is a septum extending even up to the cervix. This is a video of a hypoplastic uterus. So it's a less than normal size uterus, and ideally it should be differentiated between an infantile uterus, where in an infantile uterus the cervical length and the fundal length will more or less the same. So if it is a hypoplastic uterus, there is a scope to give hormone replacement therapy and go for a donor cycle. But if it's an infantile uterus, the response may not be very good.
So moving on to the next case, again we have a couple suffering with primary infertility of 5 years duration. She has intermenstrual spotting, but otherwise regular cycles and occasional spasmodic dysmenorrhea. So let us look at the scan findings. So here you can see a clear polyp on your sagittal plane. So the polyp can be measured. So how do we differentiate between a polyp and a submucosal fibroid? So one polyp, you can see it causes splitting of the endometrial cavity. You have a central line that is split. Whereas in a submucosal fibroid, the origin is from the myometrium. So you have pushing out of the endometrial line. So in 3D also you can see the origin of polyp. It is arising from the fundus and extending downwards. So ideal way to differentiate between polyp and submucosal fibroid is to put a fluid as well. So you can do a saline infusion sonography wherein you can see clearly the polyp moving. And also if you put a color Doppler, for a polyp you will identify a feeding blood vessel, whereas in case of submucosal fibroid you have a peripheral uptake. So polyp, one, you need to look at the location, and SIS has better sensitivity and specificity for identifying the polyp from a submucosal fibroid. So for management, less than 10 mm polyp, and if it is lower in cavity, no need for management. Conservative is advised, but for more than 1 centimeter polyp, probably removal helps.
So the next case, Mrs. X and Y, anxious to conceive, trying for pregnancy since 3 years, tried few cycles of ovulation, induction and timed intercourse. Male partner evaluation was normal, so now we've called her for a tubal patency test. So this is a video of saline infusion sonography. So we have inserted a pediatric Foley's into the uterine cavity, distended it with up to 2 ml of saline, and now we are looking for the flow. So clearly you can see at one ovary you can see the flow. Now we are looking on the other side. Again you can see the flow. Can you observe? Initially it may be a little difficult to do a saline infusion sonography, because by the time you are able to put your probe and look at the ovaries, sometimes the fluid has already come out, then you won't know from which places it's come. So with skill, the sooner you do it, you will be able to appreciate. So this is another video. You can clearly see the fluid
coming and dropping near the ovary. This is more clear, I guess. And this is the opposite ovary. Here again you can see the fluid coming and dropping near the ovary. So most of the tubal patencies we are doing at our own hospital with saline infusion sonography. Only in certain conditions we are sending for a HSG, because several times HSG is quite painful, and getting it done at a radiologist is not a very comfortable thing for a lady. So this is definitely a better option for them. And you can also evaluate the uterine cavity problems. So as the cavity distends, if you have any small polyps or anything, it can be easily visualized.
So moving on to our next case, we have a 33-year-old lady and 38-year-old man with 5 years of primary infertility and regular cycles. So let us look at the scan. So this is the sagittal plane. Here again we are measuring the UCL, uterocervical length, and APD. You can see clearly there is a endometrioma. It's a spotter, so ovarian endometrioma. So this endometrioma, already we have discussed in the earlier presentation. So endometrioma, ovarian endometrioma, typical sign is ground glass appearance. So you can see once the other ovary is focused, there is a uniform homogeneous ground glass appearance of the ovary, the cyst. So this is a two endometriotic cysts are present in the left ovary, and this ovary is adherent. You can see it is adherent to the posterior surface of the uterus. So in endometriosis, as elucidated earlier, we need to look for adhesions. See, we have identified a ovarian endometrioma. Is it adherent? What is the ovarian reserve in this patient? And what are the atypical signs? Sometimes you might not see such clear endometrioma. You have doubts whether is it a hemorrhagic cyst or is it an endometriotic cyst. What you need to understand is, in case of hemorrhagic cyst, it resolves. So you can call the patient back again on day 2 to check if it is persisting. And another atypical sign of endometriosis is sometimes you do see fluid levels. So what happens is it's endometriotic cyst is a chocolate cyst. So you have a hemorrhage inside. So once the hemosiderin separates, you have fluid levels. So as William Osler once said, he who knows endometriosis knows gynecology. So we will not go into idea consensus. Already this was elucidated earlier. So 36-year-old lady presented with primary infertility of 8 years duration. She had regular cycles but associated with dysmenorrhea. Male partner evaluation is normal. This is her scan. So this is a patient with adenomyosis. So you can see cystic spaces in the myometrium. The anterior wall is disproportionately larger than the posterior wall. You can see the alternate banding pattern. So you have so many features in favor of adenomyosis in this patient. Yeah, there are myometrial cysts as well. And there is uptake of vascularity, which again supports a diagnosis of adenomyosis. So adenomyosis, now we have the MUSA guidelines, where the direct features are cysts, hyperechogenic islands, echogenic subendometrial lines and buds, and the indirect features are asymmetrical thickening, fan-shaped shadowing, translesional vascularity, globular uterus, irregular junctional zone, and interrupted junctional zone. So moving on to the next case, so we have a couple who had one IVF done outside 2 years back and failed to conceive. Her previous reports have shown persistent fluid in the endometrial cavity. So this is the scan findings. So we have again the sagittal plane of the uterus. You can see this is away from the cavity. It is at the cervical level. In the transverse plane, you do not see the fibroid at the fundus. But when we come to the ovary, you can see a large fluid-filled cystic structure. So this is something similar to hydrosalpinx. So what is the differential diagnosis? Either you have a paraovarian cyst or a hydrosalpinx. So how do you differentiate? Paraovarian cyst, if you see any fluid-filled cystic structure, rotate your probe in a transverse direction. So if the shape is maintained, either it becomes round, oval, but the shape is maintained, then it's ideally a paraovarian cyst. But if it's a hydrosalpinx, it becomes a septate, partial septate, lobulated structure. So this is typical of hydrosalpinx. And another thing is the fluid which is coming into the endometrial cavity. This also shows that it is a hydrosalpinx. Here in the other ovary, we have a nice corpus luteal cyst. So for hydrosalpinx, we know that this fluid is detrimental for implantation. So the management ideally is to remove, that is salpingectomy, bilateral or unilateral, depending on which side the hydrosalpinx is. If not, at least tubal clipping. So Cochrane supports both. There is not much role of antibiotics. The role is controversial, and there is no role of aspirating the hydrosalpinx because it refills again. And hydrosalpinx repair is not possible because it's like a stretched elastic band.
Mrs. A married since 10 years, para 2 life 2, secondary infertility. She was anxious to conceive again, so she underwent recanalization, and 1 year post surgery she came with amenorrhea, pain lower abdomen, UPT was positive. Now this is her scan. So we can see a thickened endometrium, but we don't see any sac inside the endometrium. As we scroll and we look at the adnexa, we can spot ectopic pregnancy. So that is a gestational sac seen in the right adnexa. It has a perfect ring of fire appearance when we put the Doppler. So it's currently an unruptured right tubal ectopic pregnancy. So any antenatal scan is incomplete, especially in a patient who has conceived with ART if you don't look at the adnexa. So this is one patient where we have seen an intrauterine sac, but definitely we have to scroll and look at the adnexa because there is always a chance of a heterotopic pregnancy. So when the mean sac diameter is 20 millimeters, we should see the fetal pole, and when the fetal pole is 7 millimeters, we should see the cardiac activity. So these are just simple take-home points, and this is a good corpus luteum in that antenatal scan as well, which is supporting the pregnancy. So thank you all for your patient listening. I know it was a very long day. I'm sorry we rushed it because we didn't want you to stay here for any more time because you already had a lot of patients. So thank you so much.